دكتور أبو بكر، لو إن مثلا السبيكرز اللي بعد دكتورة إيمان إنهم ما سووا لوجد إن، ممكن تقدم قبل ولا لازم تبغى في السيكونس؟ ما سمعت إنه يمكن
Yeah, I'm ready. At any time you want me to join in, I'm happy.
it's okay if it يعني قصدي لو إنه يعني I'm trying to get everybody logged in على أساس إن إحنا ونمشي بالسيكونس. بس لو فرضنا إن مثلا دكتورة منى ما she's not logged in، ممكن تقدم صح؟
Absolutely, yes.
أوكي شكرا دكتور، شكرا.
الله يسلمك.
We'll wait for a few minutes until the people gather.
شغل الصوت ماما اسمعهم وش يقولوا.
صباح الخير دكتورة إيمان جاسم.
صباح الخير. Shall I start my presentation?
دكتورة إيمان الأنصاري is first. إيمان يعني قصدي دكتور إيمان الأنصاري after her is دكتورة منى and then it's your turn. Just I want you to log in just in case Dr. Mona is delayed, then you can be instead of Mona al-Dabba.
Okay.
Good morning and welcome to day 2 of the 5th International Pediatric Hematology Conference. Today we have many eminent speakers from all over the world, and they will present to us a keynote of the up-to-date advancement in pediatric hematology. So stay tuned in. So we'll start. Our first speaker is Dr. Iman Al-Ansari. Dr. Iman is pediatric consultant and neonatologist at Salmania Medical Complex and a teaching faculty at Arabian Gulf University. As a clinical lecturer, he graduated from Dubai Medical College for Girls in the UAE, trained in pediatrics and completed the Pediatric Arab Board Residency Program at Salmania Medical Complex, followed by neonatal perinatal fellowship, a program at King Faisal Specialist Hospital and Research Center in Kingdom of Saudi Arabia. Qualified doctor with over 10 years of work experience in the field of pediatric and neonatology. Welcome, Dr. Iman. No, Dr. Iman Ansari.
Unmute your mic, Dr. Iman.
Okay. Good morning. Thank you, Dr. Najat. Good morning, good day to you all. I would like to thank first the scientific committee.
Iman, can you put it on the slideshow, please?
It is not in the slideshow.
No, it will.
You are in slideshow, Doctora.
Now you can see my slide moving.
Okay, Iman.
Okay. First of all, I would like to thank the scientific committee and the organizing committee for having me today. I will be presenting neonatal hematology update from a neonatologist perspective on neonatal thrombocytopenia. I have nothing to disclose. Neonatal thrombocytopenia is a quantitative platelet disorder, and thrombocytopenia in a neonate of any gestational age defined as a platelet count less than 150 10 to the power 9 per liter or 150,000 per microliter. Thrombocytopenia is one of the most frequent hematological disorders encountered in the sick neonate. The incidence is high among the cases admitted to the NICU. It ranges around 22% to 35% of cases. The incidence is inversely proportional to the gestational age and birth weight. Severe thrombocytopenia with a platelet count less than 50,000 per microliter, usually affecting around 55 to 10% of all neonates and 14% of extremely low birth weight infant. Patients with neonatal thrombocytopenia, usually they will present with either petechia, bruising, bleeding from mucosal surfaces, bleeding from the umbilical cord, oozing from puncture side, hematuria, gastrointestinal bleed, intraventricular or intracranial hemorrhage, pulmonary hemorrhage, or life-threatening major bleed and subsequent shock. There is two main mechanisms for neonatal thrombocytopenia. First, impaired platelet production or increased platelet consumption and sequestration. There is different, the causes of neonatal thrombocytopenia is divided according to the pathophysiology into immune-mediated, infectious causes, genetic causes, drug-related, or disseminated intravascular coagulations and other causes like necrotizing enterocolitis, intrauterine growth restrictions, birth asphyxia, or newborn born to mother with a pregnancy-induced hypertension. The diagnostic evaluations of a neonate with a thrombocytopenia is usually based on the onset, like either to start in the fetal time period, early onset if it starts less than 72 hours of age, late onset if it starts more than 72 hours of age. Also upon the overall presentation and the natural course of the disease. So the causes can be classified according to the fetal, when start in the fetal life as autoimmune causes, congenital infections, genetic causes, or autoimmune as in case of mother with ITB or SLE. While early onset causes, which start less than 72 hours of age, it will be related to chronic fetal hypoxia, perinatal asphyxia, perinatal infection, autoimmune and autoimmune causes, congenital infections, bone marrow replacement, and other metabolic diseases. While late onset thrombocytopenia can start usually more than 72 hours of age, either it will be due to late onset sepsis, necrotizing enterocolitis, congenital infections, autoimmune, and other metabolic diseases. In case of immune-mediated thrombocytopenia, the platelet will be, in general, will express usually a unique protein called the human platelet antigens. The fetal platelet expresses specific human platelet antigens inherited from the father that the mother usually lacks and can cross the mother circulation and cause an immune reactions. So it will cause feto-maternal incompatibility. There will be a mismatch of a specific human platelet antigens between the fetal antigens and the mother, who's deficient in this antigen. The mother will produce antibodies against the fetal human platelet antigen in response to exposure to fetal blood. Usually it is in form of maternal IgG. There will be transplacental passage of maternal antibodies. They will enter the fetal circulation and bind to platelets, and subsequently they will destruct fetal platelet, causing thrombocytopenia, resulting in uncontrolled bleeding, leading to intracranial hemorrhage with severe lifelong neurological disability, miscarriage, or loss of the newborn. The incidence of fetal and neonatal autoimmune thrombocytopenia range between 1 in 1,000 to 2,000 live births. It usually presents with severe neonatal thrombocytopenia at birth or shortly thereafter in absence of other risk factors. It accounts for 10 to 20% of clinically recognized cases who have intracranial hemorrhage. And around 50 to 75% of intracranial hemorrhage occur in utero. It will be related to fetal and neonatal autoimmune thrombocytopenia. It can be fatal in 1/3 of cases, and the risk may result in significant neurological sequelae. While autoimmune thrombocytopenia, the infant usually born to mother with immune thrombocytopenic purpura. Usually it's caused by transplacental passage of maternal IgG antiplatelet autoantibodies, in which these antibodies will usually be formed against mother-owned platelet, and it will be crossed the placenta to the fetal and cause destruction to the fetal platelets. Typically, the lowest platelet count will be observed between day 2 and 5 after birth, with resolution on day 7. Some neonates may continue to have thrombocytopenia for months, necessitating long-term monitoring. The inherited thrombocytopenia, there is a wide range of inherited genetic diseases that can cause thrombocytopenia in neonatal period. And the underlying genetic predisposition or genetic transformation, either it will be autosomal recessive, autosomal dominant, or X-linked diseases. It is a rare heterogeneous group of disorders with highly variable bleeding tendency. It's considered a neonate with persistent unexplained thrombocytopenia since birth. The bleeding tendency usually disproportionate to the platelet count, and there is a family history of thrombocytopenia. There will be association with dysmorphism or congenital malformations. And the blood smear that shows some abnormalities as either large or small platelets, abnormal platelet granules, or neutrophil inclusions as Dolly bodies. The management of neonatal thrombocytopenia usually depends on the management of the underlying cause. And the platelet transfusions is the mainstay of management in neonatal thrombocytopenia. They found that the risk of bleeding is higher in neonates with fetal and neonatal alloimmune thrombocytopenia, sepsis, necrotizing enterocolitis, and extreme prematurity. Platelet transfusions usually administered to neonates either therapeutically or prophylactically. Therapeutically in neonate with those with active bleeding, and prophylactically usually to prevent serious bleeding events and hemorrhagic complications of a thrombocytopenia, usually and particularly intracranial hemorrhage and intraventricular hemorrhage in preterm infants. Neonatal platelet transfusion threshold policies are usually varies widely nationally and internationally among neonatologists. And largely, usually it is based upon the expert recommendations and the clinical experience. The correlation between platelet count and the risk of hemorrhage usually it is poor. And the studies showed that among neonates with similar degree of thrombocytopenia, they have different risk of bleeding. For neonates with severe thrombocytopenia, the lower platelet count is not a strong predictor of increased bleeding. And different studies showed whether the administration of minor bleed or the minor bleeding is considered as a predictor of major bleed still remains unknown. The neonates have different risk of bleeding given the same degree of thrombocytopenia, based on the underlying pathophysiology. So a neonate with neonatal alloimmune thrombocytopenia, usually they have a high risk of major bleed, while a neonate with sepsis or necrotizing enterocolitis, they have an intermediate risk of bleeding. And in infants with intrauterine growth restrictions, usually they have low risk of major bleed. Generally accepted transfusion threshold for platelet count less than 30,000 per microliter for stable newborn, and usually they will transfuse infant in unstable conditions and the platelet count less than 50,000 per microliter. While for high-risk neonates with active bleeding, usually they transfuse them if platelet count is less than 100,000 per microliter. Because of the concern for intraventricular hemorrhage in the sick neonate, many physicians, they adapted traditionally an aggressive platelet transfusion threshold even with no active bleeding, as to give a platelet transfusion if a platelet count less than 100,000 per microliter, especially in high-risk patients. So if you ask around 5 different neonatologists when to transfuse or what is the threshold to transfuse newborn patients, they will give you around more than 10 answers. Usually, they believing that different etiologies of neonatal thrombocytopenia, usually they need to be transfused at different thresholds. So based on that, there is multiple studies conducted so there is one multi-center randomized controlled trial. They transfuse a neonate with a platelet count less than 150,000. They found that there is no benefit of maintaining a normal platelet count around to maintain it above 150,000 in a preterm neonate, compared with maintaining it at more than 50,000 per microliter. In another studies, it shows that a more restrictive platelet transfusion protocol using a platelet transfusion threshold of 25,000 in a clinically stable neonate and 50,000 per microliter in a clinically unstable neonate was not associated with an increased risk of intraventricular hemorrhage. With a more aggressive, if they compare it with a more aggressive transfusion protocol, if they transfuse a platelet count less than 50,000 per microliter in a stable neonate and less than 100,000 in a clinically unstable infants. The main and largest trial in this regard is the Planet 2 trial. It is a multi-center randomized controlled trial conducted between 2011 and 2017. And a total of 660 infants, they underwent randomization. And they, in this study, they randomized infants to receive a platelet transfusion at a platelet count of less than 50,000 per liter, 50,000 per microliter, which is the high threshold group, and the other group is to transfuse them if platelet count dropped to 25,000 per microliter. This is in low threshold group. And the result showed that a new major bleeding episode or death occurred in 26% of infants in the high threshold group and 19% in the low threshold group. The odd ratio was 1.57 and 95% confidence interval is 1.06 to 2.32 with a significant p-value. So they concluded that transfusion in neonatal thrombocytopenia at high threshold group had a significant higher rate of death or major bleed within 28 days after randomization. From this study, it showed that the reported overall lack of benefit in high threshold group and the transfusion at high threshold group is ineffective in preventing bleeding episode. And unexpectedly, it showed that the lower threshold usually had benefits in terms of substantial increase in survival without a serious bleeding, around 7% the absolute risk reduction. The benefit seems to be on both outcomes, as the primary outcome in this study was a composite outcome, but when we divide them in death, it's around 5% absolute risk reduction, and a serious bleed is around 3% absolute risk reduction. Also, this study showed there is a lower threshold for bronchopulmonary dysplasia, around 9% with absolute risk reduction. They performed a logistic regression analysis and showed that a relative and absolute benefit of a lower threshold of a platelet transfusion on the primary outcome as a survival without serious bleeding was among the all-risk group and especially on the high-risk group with a high risk of bleeding. There is a follow-up study. For this study, it showed that transfusion at a high threshold group, it showed that higher rate of death or significant neurodevelopmental impairment occur at 2 years of age. When we will go for the dose for platelet transfusion, the dose usually is calculated based on ml per kg in a neonate. And the dose is usually around 10 to 15 ml of kg per of platelets concentrate. And there is different studies showed that the optimal volume to be transfused, and there is no superior of one dose to other of 10 or 15 ml per kg. In regard to pre-transfusion testing and risk of transfusion, there is risk of alloimmunizations, and the platelets usually express intrinsic ABO antigen, but not RH antigens. And they should be ABO-specific group whenever possible because of the risk of intravascular hemolysis following transfusion of ABO-incompatible blood platelets. RH matching usually does not affect post-transfusion platelet survival, but RBCs are usually present in a small amount of whole blood platelets and can cause RH sensitization in RH negative recipients. The risk of a transfusion, there is risk of acute lung injury and TRALI. And from this, we will conclude that neonatal thrombocytopenia is a common finding in neonatal period of different etiologies. And platelet transfusion is the mainstay of treatment, and it has considerable variation in practice in regard to management and platelet transfusion threshold. And recent recommendations are more restricted, accepting lower platelet threshold for transfusions. In conclusion, I will thank you for your attendance and for your listening. And thank you. I hope that I was on time. Thank you for listening.
Thank you so much, Dr. Iman Al-Ansari, for the excellent review of neonatal thrombocytopenia.
Thank you.
We move now to the Q&A. Okay, there's one question for you, Dr. Iman. Does plasma exchange have a role in the treatment of thrombocytopenia in neonate?
In this age group, it is still it is not applied or conducted, or it is used as regular management in this age group.
Okay, as no more questions, thank you so much, Dr. Iman. And now we'll move to our next speaker, Dr. Muna Al-Dabbar. Dr. Muna, she is the chairman of Pediatric Department of King Abdulaziz Medical City in Jeddah. She is a consultant pediatric infectious disease and transplant infectious disease at the same hospital. She is associate professor of pediatric infectious disease at King Saud bin Abdulaziz University for Health Science in Jeddah. And she is also the director of continuous professional development, deanship of postgraduate education, Jeddah, King Saud bin Abdulaziz University for Health Sciences. Welcome, Dr. Mona.
Thank you. السلام عليكم. يعطيك العافية دكتورة. Thank you very much. It gives me actually a great pleasure to participate with you today in that wonderful, excellent event. What I'm going to talk about, I wonder if you see my slides. Can you see my slides? Doctora?
We see your
Dr.
slide,
Yes,
Doctor.
we
Okay,
can see your
fantastic.
slides, yes.
Thank you very much. So what I'm going to talk about today is managing infections and sickle cell disease. As we all know, sickle cell disease is a very a common disease that we see in the Middle East areas. So I'm going to start with a disclosure. So the objectives of my talk today is to present the burden of infections among patients with sickle cell disease, to present the means for management of infections in patients with sickle cell disease with emphasis on the preventive strategies. As we all know, sickle cell disease is mainly widespread through most of African continent, Middle East, and India, and is localized in some localized areas of the Mediterranean countries. Patients with sickle cell disease have decreased or absent spleen function, and this places them at great risk for serious infections, specifically by encapsulated organisms. With that, until now, children with sickle cell disease infections in them actually is the second leading cause for death in the first 10 years of life. With that, the National Heart, Lung, and Blood Institution guidelines have established guidelines in 2014 stating that any patients with sickle disease who presents with fever as higher than 38.5 should be considered as a potential emergency and recommends evaluation, including complete blood count, reticulocyte count, blood culture, and other laboratory studies appropriate for the clinical settings. And they recommend also to administration of empiric antibiotic therapy for all of these patients. So let's start looking at the burden of disease. This study was actually published in 2022. It was conducted in Atlanta, US, looking at the annual incidence rates of bloodstream infections among children with sickle cell disease between 2010 to 2019. And as you can see here, that throughout the years, and this was actually 2010, this was after approval of PCV 13 vaccine routinely in the US. So as you can see, so despite PCV 13 vaccination, Streptococcus pneumoniae continued to be the highest causative organism for bloodstream infections, to get followed by very dense group Streptococci, and then other organisms, including E. coli, Haemophilus influenza, and other Streptococcus species. With that, and that study, they found that subjects with sickle cell disease had an odds of 1.88 for development of bloodstream infections compared to those who do not have sickle cell disease. This is another meta-analysis that was conducted looking at the prevalence of bacteremia in febrile patients with sickle cell disease. And they found in that study that the weighted prevalence for bacteremia across all studies was around 1.9%, whereas the prevalence for Streptococcus pneumoniae was around 0.31%. With that, they tried to look for the risk factors for development of bloodstream infections, and the only risk factor they found was the presence of central venous catheter, where subjects with central venous catheter had a 21-time higher rate for development of bloodstream infections, for development of invasive bacteremia in those subjects. However, it's important to highlight that the total number of cases that were found in the literature were not many. This is another study that was conducted in Saudi Arabia, looked at the frequency of the most common bacterial isolates from blood cultures of the patients with sickle cell disease. And as you can see in that study, the trend was a little bit different from the study that I just shared with you in Atlanta. So the most commonly reported organisms in those subjects were gram-negative bacteria. Okay, mainly E. coli, and some other cases with Acinetobacter and so ever. So gram-negative were the most common, followed by gram-positive. The gram-positive organisms, Staphylococcus species, were highest, followed by Streptococcus pneumoniae and other types of streptococci. In that study also, they looked at the bacteremia episodes, comparing them between, for all population, rate of bacteremia per 100 years, and they found that actually the rate of bacteremia per 100 patient year for all subjects was around 1.5 per 100 patient years. The rate for gram-positive bacterial infections was 0.5 per 100 patient year, whereas for gram-negative infections was 1 per 100 patient years. It's very important to understand the basics. Why do these patients actually develop infections? That's because patients with sickle cell anemia, actually, they do have immune problems that really involves the innate and adaptive immune functions from all prospects. So important to highlight is the neutrophil dysfunction. So subjects with sickle cell anemia, they have impaired splenic function. The impairment of splenic function does affect neutrophil function, affecting its chemotaxis, migration, and killing ability. Furthermore, these subjects have splenic dysfunction. The splenic dysfunctions leads to repeated sickling with the spleen, leading to compromised splenic filtration by organisms. And important to highlight that because of the splenic dysfunction, macrophages are also present microbial antigen that are important to present microbial antigens to T lymphocytes, which in turn stimulates B lymphocytes to produce high affinity antibodies. And these antibodies are important for killing and opsonization of encapsulated organisms. Furthermore, they do have affected opsonization. So one reason that I mentioned is because of the splenic dysfunction, but also they have reduced opsonin production, leading to decreased ability of destroying encapsulated organisms. And they also, the opsonization with antibodies and the complements is impaired. And again, this is in particular to encapsulated infections. So this tells me that basically those patients, they have affection here of T cells, of B cells, of complement pathways together with the neutrophil function defects. Not only that, patients with sickle cell anemia have impaired adaptive immune function, where they have decreased humoral immunity. And this is also because of splenic defect, where they do have defect in producing sufficient antibodies. Here, the B and T cell lymphocyte function are impaired, resulting in inadequate memory B cells function and T cell independent production of natural polysaccharide antibodies, which are very specific to the encapsulated bacteria. And they do have impaired virus-specific production of immunity, and this is mainly T cell related, where these patients do have impaired lymphocyte function. The lymphocyte function affects CD4, CD8 counts, and it does affect also affect B lymphocytes. Such a defect in T cell function does put these patients at risk to severe respiratory infections. Additional factors that these patients encounter are mechanical factors because of the recurrent vaso-occlusive crisis that they encounter, the blood supply to the bone does diminish, and this leads to higher risk of development of osteomyelitis. Additional factors include nutritional deficiencies. So those patients, they do have zinc deficiency, and this is related to multiple factors, including increased reduced uptake or the increased demands. This zinc deficiency per se can lead to lymphopenia and decreased Th1 response. This was also linked to the development of lymphopenia, reduced IL-2 production, and deficient coordination of the innate and adaptive immune response. And as I mentioned, the deficiencies in macro and micronutrients are present in those subjects due to diminished caloric intake, elevated resting metabolic rate, increased red cell synthesis, elevated protein turnover, and dysregulated inflammatory response. So this table, I know it's a big table, but it just shows you the infections that occur in sickle cell patients. This table basically summarizes the bacterial infections. So it shows you that subjects with sickle cell disease can develop bacteremias, can develop meningitis, can develop upper and lower respiratory tract infections. They can develop musculoskeletal infections and GI and GI disorder infections, specifically with cholecystitis. And this is all really I'm going to discuss this in a few coming slides. It's an interchanging process in those patients. So infections can lead to increase the risk for development of sequestrations, vaso-occlusive crisis, aplastic crisis, and at the same time, having vaso-occlusive crisis can increase the risk of developing infections as well. As I mentioned earlier, osteomyelitis and acute chest syndrome is associated also with higher risk of hospitalizations and hospital-acquired pneumonias. Not only that, subjects with sickle cell anemia are considered higher risk of developing other infections such as HIV, hepatitis B, and hepatitis C because of transfusion problems. And they are at higher risk of developing more severe disease, viral diseases with influenza and COVID-19 and together with respiratory syncytial virus. They are at risk of development of aplastic crisis with parvovirus B19 infection. And they are at higher risk for developing helminthic protozoic infections and more severe. And so here they're basically at higher risk for development of more severe disease, okay, and more severe malaria and more severe tuberculosis. As I mentioned, subjects with sickle cell anemia, they have an interrelationship where sickle cell disease having vaso-occlusive crisis can lead to development of osteomyelitis, for example, of the bone, can have acute chest syndrome, can increase the risk of development of pneumonias, and at the same time, having an infection per se can predispose to vaso-occlusive crisis, aplastic crisis, and sequestration crisis. Having said that, it's very important. We all know that subjects with sickle cell disease, they're at a high need to develop extra vaccines against encapsulated organisms, specifically Haemophilus influenza, pneumococci, and meningococcal infections. Together with influenza. However, if we look at real life, okay, this table basically summarizes vaccine uptake. And as you can see, still, despite all the efforts that are being done, you can see that the uptake for the pneumococcal vaccines is actually 60%, meningococcal vaccine for the MenACWY is 77%, whereas if we look at Men-B vaccine, we're going to see that the uptake is very, very low, and influenza vaccine uptake is just hardly 50%. If you want to manage patients with sickle cell anemia, really the biggest part, as you can see here, is prevention. So prevention is basically with immunization and antimicrobial prophylaxis. So immunization primarily against Streptococcus pneumoniae, Neisseria, meningitis, Haemophilus influenza, and other vaccines. and a prophylaxis with antimicrobial agents. So this is the recommendation from the evidence-based management of sickle cell disease that was published in 2014, suggesting that subjects with sickle cell disease should receive penicillin prophylaxis up to the age of 5 years. So all patients with sickle cell should receive oral penicillin prophylaxis up to the age of 5 years, and prophylaxis should be discontinued at the age of 5 unless those subjects had splenectomy or invasive pneumococcal infection. And in such a case, when discontinuing penicillin prophylaxis at the age of 5, it's important to assure that the child has completed the recommended pneumococcal vaccination. So here, the antibiotic prophylaxis in these subjects is basically for the purpose of preventing Streptococcus pneumoniae infection. What about immunization? So those subjects should receive vaccines to protect them from Streptococcus pneumoniae, Neisseria meningitidis, Haemophilus influenza, hepatitis B, and seasonal influenza specifically. And you can see this from the CDC, the recommendations for immunization in subjects with asplenia. And under this falls the category of sickle cell disease. So you can see in brown specific highlights for additional vaccines to be given related to pneumococcal prevention and meningococcal prevention, including 4-valent meningococcal vaccine and the MenB vaccine as well. So let's talk about pneumococcal vaccination. We all know that the previously used pneumococcal vaccines included PCV7, PCV10, PCV13, and the polysaccharide vaccine, 23-valent polysaccharide vaccine. So this shows you the different serotypes that are included in different vaccines, and how with advancement of immunization, more and more serotypes of Streptococcus pneumoniae are covered. But now, actually, we have even PCV15 and PCV20 that add actually further coverage against additional serotypes included here. And it's very important to share with you the updated knowledge on PCV15, PCV20, because these vaccines were actually very recently approved for usage in pediatric population. We know already that before 2022 that the PCV20 was approved for adults 19 to 64 years of age, including those with sickle cell anemia. However, as of June 2023, new guidelines were published recommending the use of PCV15 and 20 for subjects with sickle cell disease. Okay, so the vaccine is recommended for those who are less than 6 years and those 6 to 18 years, together with these vaccines, together with giving them additional polysaccharide vaccine. We know that the previous recommendation was for catch-up. So what's recommended is that all children receive the routine vaccines, which include the routine vaccine, whatever it contains. If it's PCV13, then that's good. If it's PCV15, PCV20 is even better. Okay, so depending on the age of the child, if the child, let's say now the child has received PCV13, he is 2 to 5 years old. So if this child did not receive his routine vaccines of infancy, okay, and the child is now 2, and he received 0 to 2 doses of the vaccine, then this child should receive 1 dose of the PCV13, and then for another dose 8 weeks after, and then 8 weeks after. So the child should receive 2 doses of the PCV13, 8 weeks apart, and then 8 weeks after should receive the polysaccharide, the 23-valent polysaccharide vaccine, and this vaccine should be repeated every 5 years. If the child received 3 previous doses of PCV13, then the child should receive only 1 dose of the PCV13 at the age of 2 to 5 years, followed by 8 weeks by the polysaccharide vaccine. Very important to highlight that the polysaccharide vaccine is only recommended for children 2 years or older. For children who are 6 to 18 years of age who never received any doses of the PCV13, they should receive 1 dose of the PCV13, and 8 weeks after should receive the polysaccharide vaccine, and repeat the polysaccharide vaccine every 5 years. Now, with the recent consensus guidelines for the PCV20 and PCV15, so the recommendations, if let's say the child received PCV13 or 15, with the availability, if the PCV20 is available, I know that most of the Middle Eastern countries, the vaccine is not available yet, but if the vaccine is available, so we have multiple options. So option number 1 is after 8 weeks from the last dose of the vaccine to give 1 dose of PCV20. Option 2 is to give 8 weeks after the last dose, and this is again after the age of 2 years. After 8 weeks from the last dose of the PCV13 or 15 to give a single dose of the polysaccharide vaccine, and after 5 years you can give the PCV20. Or option 3 is what we mentioned earlier, is 8 weeks after the last dose of the PCV13 and 15, you can give a single dose of polysaccharide vaccine and repeat this after 5 years. So these are the changes that were made as of now. Again, if PCV20 is available right now, so you can give the PCV20 to any child after 8 weeks from the last dose of the PCV13-15. What about meningococcal vaccine? So in meningococcal vaccine, there are 2 vaccines that are currently recommended by the Advisory Committee on Immunization Practices. Those include the quadrivalent meningococcal vaccine, MenACWY, that provides protection against the serotypes A, C, W, and Y. And this is recommended for all individuals 2 months of age who have functional anatomic asplenia. And the other vaccine is the MenB vaccine. And this is recommended for individuals over the age of 10 years of age who are diagnosed with functional anatomic asplenia. So the recommendations for those subjects is to receive 2 dose primary series of either MenACW4, MenACWY, MenView, or the Menactra vaccine. This should be given to all children 2 years of 2 years of age or older with asplenia, and then a 3-year interval to the next dose is recommended for people who received their previous doses at an age younger than 7 years. But if they received the previous dose after 7 years of age, then an interval should be 5 years between the 2 doses. Meningococcal
dear all. Just a second, Dr. Mona, she tried to log in again.
We apologize because the internet has disconnected with Dr. Mona Dabbagh, but she's trying to reconnect. So we'll give her maybe 2 minutes more to see if she can reconnect.
To you. I need everyone to be quiet, please.
دكتورة منى.
أيوة دكتورة معلش أعتذر. I apologize for this disconnection because
It always happens. Technical difficulties and problems always happen in conferences. It's absolutely okay.
my apologies. Okay, so can you see my slides again?
Yes, yes.
Okay, so I was talking earlier about the men ACWY vaccine, and then we'll talk about the recommendations for the men B vaccine. So as we all know, the men B vaccine are licensed for people 10 to 25 years of age and are recommended for people 10 years of age or older with functional anatomic asplenia. Here, meningococcal B vaccine should be administered as either a 2-dose series of men B 4C or a 3-dose series of the men B FHBP formulation. So the summary for the meningococcal vaccine for patients with asplenia or hyposplenia is that the vaccine, depending on the formulation, if we are using the Menview versus Menactra, Men ACWY, so the Menview should be given in 3-dose series, whereas starting at 8 weeks of life, whereas the Men ACWY Menactra formulation can be given in 2-dose series. For the Men B, as we mentioned earlier, it should be given to children above 10 years of age with 2-dose series, 1-month interval, and revaccination 1 year after the primary series and every 2 to 3 years if the risk of infection remains. This is a study that I really like to share with you. It's a study looking at the, again, compliance with the meningococcal vaccine uptake in the US. It's a nationwide study in the US with newly diagnosed asplenic patients from 2010 to 2018, looking at the uptake of men ACWY and Men B vaccines. Here, the study included 2,200 subjects with 741 eligible for vaccination. And as you can see, after follow-up, the time for first vaccination after new asplenia diagnosis. So the vaccine uptake for men ACWY was only 28% after 36 months and reached up to 34% after 60 months from becoming asplenic. And for men B, the uptake for 1 dose was only 9.7%. And looking at those who received the first dose and who followed up to take the second dose, only 51% of those who received the first dose of the Men B received the second dose, whereas those who received Men ACWY first dose, the 22% continued to receive the second dose. This also slide shows you the uptake of all vaccines. So this is the blue is Men ACWY. You can see that the uptake maximum was 34%, whereas for Men B, the uptake maximum was 9.7%, while for pneumococcal vaccine, both the conjugated and the polysaccharide vaccine maximum was 56%. Just highlighting that the uptake is really low. These guidelines were published by the British Society for Hematology, looking at the prevention and treatment of infections in patients with absent or hyposplenic function. You can see that they recommend Haemophilus influenza B, but Haemophilus influenza B, not any extra doses apart from what's given during infancy. Just the routine vaccines for infancy, Haemophilus influenza. No any other doses of the vaccine are recommended. For pneumococcal, as we mentioned, so subjects should receive the routine PCV vaccines in infancy. During infancy, and then they should receive the polysaccharide vaccine after the age of 2 years, and then repeat the dose every 5 years. For meningococcal, it's recommended that they take the MenACWY and the MenB vaccine, as mentioned earlier. They're also advised to take the annual influenza vaccine. They're recommended to take the COVID vaccine and hepatitis B vaccination. For those older than 10 years, and adults, so Haemophilus influenza is no longer recommended, whereas pneumococcal vaccine, they should take 1 dose of the conjugate vaccine followed by 1 dose of the polysaccharide vaccine, and repeat the polysaccharide vaccine every 5 years. And for meningococcal, so they should take the doses that I mentioned earlier. What about treatment of infections? Really, treatment of infections relies on multiple factors, rely on the epidemiological data. As we mentioned, and as we shared with you together earlier, that the most common pathogens causing infections in those subjects are strep pneumo, Neisseria, Haemophilus influenza. And there are data that show that also there is risk of Staph aureus infection. So really what antibiotics to give depend on the clinical presentation, the site of infection, and the local epidemiological data for pathogens available. So if you think that the risk the patient is having, for example, Staph aureus infection pneumonia, then you should cover Staph aureus, and depending on your local epidemiological data, additional coverage for MRSA can be considered. So the standard is to give ceftriaxone, and this antibiotic should cover all 3 strep pneumo, Neisseria, and Haemophilus influenza, together with salmonella. But you can add antibiotics based on the site of infection, whether you need to add anti-staphylococcal coverage or not, and based on epidemiological data as well. Furthermore, other infections you should treat accordingly. If the subject is having malaria, so treat it accordingly. Tuberculosis, treat it accordingly. And if they're having HIV infection, treat the infection. So in conclusion, subjects with sickle cell disease are at increased risk of infections and mortality due to encapsulated infections. Therefore, it's essential to it's essential that this particular population of patients adhere to the ACIP recommended immunization schedule for functional asplenia, and more work is needed to be done to improve vaccination coverage among individuals with sickle cell disease, and this should include identifying the challenges for implementing vaccine recommendations, discussing strategies to increase coverage, and improve provider education. This is the end of my talk. Thank you very much.
Thank you so much, Dr. Mona, for the excellent and very impressive review of infections in sickle cell disease. As we know, this is very important topic, and also it is a serious complication in sickle cell patients. There is one question for you, Doctora. The question is there any benefit of continuing penicillin V prophylaxis after the age of 5 years?
Yes, so the recommendation for continuing on prophylaxis really depends on the risk of the patient, okay? So if this patient had encountered any previous invasive pneumococcal infection, so yes. If this patient is receiving other immunosuppressive medications, then yes. If the patient is, these are the main risk factors, you know. However, if it's only sickle cell anemia, and no other complications, and it went smoothly, so 5 years are adequate. Also, there are also some recommendations for sicklers who undergo splenectomy. This is also one of these conditions where you may expand the prophylactic penicillin. So again, to conclude, prophylactic penicillin is recommended for the extremes of age, so all children younger than 5 and those who are above 65. So also, if it's someone who's above 65, you might consider prophylactic penicillin.
Excellent. Thank you so much, Dr. Mona. And now we move to the next speaker.
Thank you.
Our next speaker is Dr. Iman Jassim. Dr. Iman graduated from Arabian Gulf University, and she did her residency and fellowship at the Westmead Hospital, Sydney, and King Khalid University Hospital and King Faisal Specialist Hospital in Riyadh. Fellowship of King Saud University Fellowship and American Society of Clinical Pathology International Specialist. She is a senior consultant hematopathologist at Salmania Medical Complex. Welcome, Dr. Iman.
Thank you very much, Dr. Najat. Assalamu alaikum.
Alaikum salam.
Jum'a Mubarakah. I'll share my slide now.
Yes, please.
We'll start about the antiphospholipid syndrome. As you know, the antiphospholipid syndrome is a multisystemic autoimmune disorder characterized by the presence of antiphospholipid antibodies that directed against the protein, the phospholipid protein, with the 3 main categories. And the epidemiology for the antiphospholipid syndrome in adult, it's a rare disease, estimated that it's 40 to 50 cases per 100,000 cases, with the annual incidence of 1 to 2 per 100,000. It's typically diagnosed with younger population, less than 50 years. And with the pediatric, it's a rare disease because we are missing main category in the classification, which is the thrombotic obstetric complication or pregnancy complication. We don't have it in the pediatric. So it's either underdiagnosed in the pediatric age group or it's really rare. And with the registry of 120 children, reported mean age of onset 10.7 years. Now, with this background of antiphospholipid syndrome and with the epidemiology changes or distribution with the adult and pediatric, we are moving to the how to diagnose this antiphospholipid syndrome. It's divided with the 2 main categories. One is clinical manifestation, the other is lab manifestation or lab diagnostic criteria. And we will go through it all. The most specific clinical criteria with obstetrician is preterm delivery for preeclampsia, severe feature of placental insufficiency, fetal growth restriction, or recurrent early miscarriage, which is below 10 weeks of gestation. We have another catastrophic antiphospholipid syndrome, which should be differentiate between TTP, HUS, and HET. Other clinical manifestation, which are common and uncommon. This is uncommon, less common manifestation. The common manifestation, clinical manifestation, where is it, the slide of? Yeah. This is the common clinical manifestation, is the thrombotic manifestation, deep venous thrombosis of the lower extremities, cerebral arteries. Uncommon sites of thrombi are intestinal viscera or the brain. Other non-common or less common: skin, eye, heart, lungs, and kidneys. And the other division of the category of classification is the obstetrical manifestation. And this is the catastrophic. This is this diagram showing the less common. Some of them, they are not included in the criteria to diagnose antiphospholipid syndrome. For diagnosis of antiphospholipid syndrome, we need the lab criteria and the clinical criteria. And this is the Sydney criteria of 2006 for classification of antiphospholipid syndrome, which has been revised in 2009, and the criteria of 2023 of the rheumatology, European and American Rheumatological Society. And I'll go through the diagnostic criteria first, which is for diagnosis of antiphospholipid syndrome, we need clinical criteria, either thrombosis or pregnancy morbidity, which is the recurrent abortion or recurrent abortion or fetal death, because it's not my field, sorry. Persistent circulating antiphospholipid. The lab criteria, we need persisting circulating antiphospholipid antibodies, which include the lupus anticoagulant, and I'll go through it, the lupus anticoagulant and how we diagnose it and how we reported, the interpretation of this report, because it's very important for the physician to take the weight of the lupus anticoagulant or anticardiolipin antibodies, IgG, IgM, or the anti-beta-2 glycoprotein 1 antibodies in their report or in their diagnosis of antiphospholipid syndrome. As I mentioned, that we need to diagnose antiphospholipid syndrome, clinical laboratory identification, we need at least one of these tests to be positive, either anticardiolipin antibodies, which is IgG or IgM. We need anti-beta-2 glycoprotein 1, IgG or IgM, and we need lupus anticoagulant. And these should be present for at least 12 weeks, because low positivity or other initiation of these antibodies, the positivity will disappear in case of infection. But in case of antiphospholipid syndrome, it will continue to be positive for the patient. In 2006, a criteria of Sabaro, which is initiated in 1999, has been reviewed in Sydney and included lupus anticoagulant, which should be present in plasma on more than 2 occasions, at least 12 weeks apart, and or anticardiolipin antibody IgG and or IgM serum or plasma. And this should be above 40 units or above 99 centile, measured by standardized ELISA on 2 occasions. And these 2 occasions should be 12 weeks apart. And in Sydney criteria, they include the thrombotic, the thrombosis, the clinical criteria, vascular thrombosis, venous or arterial. And we have seen that the deep venous thrombosis of the lower limb are the most common criteria to be seen with the patient of antiphospholipid syndrome, or arterial or microvascular. And this confirmed by objective validated criteria. No evidence of inflammation in the vessels wall. And or pregnancy morbidity. The pregnancy morbidity in the criteria of Sydney 2006 was unexplained fetal death, but it should be more than or equal to 1 of more than 10 weeks of gestation, or preterm or premature birth below 34 weeks of gestation because of the preterm, because of preeclampsia or eclampsia, features of unexplained constructive abortion below 10 weeks of gestation. And again, for the laboratory diagnosis, ICTH meeting, the International Society of Thrombosis and Hemostasis, met again on 2009 and 2016. Review again the criteria which has been set on 2006 in Sydney. Again, it's the same. Anticardiolipin, antibodies, IgG or IgM exceeding 40. It's either IgG or IgM exceeding 40 units, anti-beta-2 glycoprotein, and these both by ELISA. And anti-lupus, anticardiolipin. And this is the way that the rheumatology people, they are using to label patients with antiphospholipid syndrome. This is part of it. I'll go through the clinical criteria for them, for the rheumatological people, after that. In 2023, they met and they label or weight each test with a weight. And to diagnose patient, they say that we need 5 and more to diagnose patient with antiphospholipid syndrome. So patient with moderate or high positive IgM, anticardiolipin, it will give 1 equal to 1. Moderate positive, 4. High positive, 5. High positive of anticardiolipin and double positivity, it will give 7. And to diagnose patient, we need persistent positive test equal 5. And single positive anti-lupus anticoagulant. And this is again, this is the weight of the lab and the clinical criteria. For the clinical criteria, they weight the venous thrombosis with high risk of 1. Venous thrombosis without high risk with 3. So calculatively, to diagnose antiphospholipid syndrome, we need the lab criteria plus additionally the clinical criteria to diagnose the antiphospholipid. And this is, it says that the meeting on 2016 of International Society Thrombosis and Hemostasis, ICTH, they elaborate more on anticardiolipin and lupus anticoagulant. So previously, for the lupus anticoagulant, we do it, traditionally, we do it on 2 steps. using APTT with low phospholipid and high phospholipid, using the silica, which is sensitive for the antiphospholipid antibody present in the plasma of the patient. And they add the DRVVT, dilute Russell Viper Venome test, with a sensitive APTT. Previously, we used APTT, the sensitive APTT, with the silica as activator. So, and mixing with the patient plasma with normal plasma, which is not corrected. So, if the lupus anticoagulant is prolonged with the screening, we go for the mixing as confirmatory. Now we add the DRVVT, which is very sensitive. So we have to diagnose lupus anticoagulant in the lab, which is a functional test. We need two tests. We need the dilute Russell Viper Venome test, and we need to add a silica or APTT test, which is sensitive to the phospholipid with high phospholipid and low phospholipid, and we add, and then we do mixing. So this is just to summarize what we are doing in the lab and what we need according to the last ICTH recommendation. We need anticardiolipin antibodies IgG, IgM by ELISA. We need anti-beta-2 glycoprotein 1 antibodies IgG or IgM by ELISA, and we have to report it above 40 to be positive, 40 units. And we need the anti-lupus anticoagulant, which is functional clotting assay by APTT. And we mentioned that we need the very sensitive reagent for antiphospholipid and dilute Russell Viper Venome test. The lupus anticoagulant, which is a functional test, we do it in the lab to diagnose the presence of antiphospholipid antibodies. It should characterized by prolongation of phospholipid-dependent clotting test, and it has the inhibitory effect in patient plasma. And it should also has the inhibitory effect if we add more phospholipid. A dilute Viper Venome test, which has been added on 2016, added to the criteria. It was before present, but added to the criteria which must be done to diagnose lupus anticoagulant positivity. It's a Venome reagent based on direct activation of factor 10. Antiphospholipid in a patient plasma will react with phospholipid component of the reagent through the cofactor and prolong the dilute Russell Viper Venome test by the decreased activity of a prothrombin activator complex. It's the same as APTT assay, which is depend on the intrinsic pathway of the clotting factors. This diagram explains how the dilute Russell Viper Venome test will activate factor 10, and how the silica will activate the beginning of the cascade intrinsic pathway. And this is how we detect the IgG and IgM by ELISA for both anticardiolipin and anti-beta-2 glycoprotein. So these are the tests which have been weighted on criteria of the rheumatology meeting on 2023. And little bit, just pay attention with me, little bit about how we choose these assays. Of course, we depend on the criteria and international recommendation of the ICTH, but lupus anticoagulant should be sensitive APTT assay. We preferred, or they preferred, silica. And for the screening tests, as I mentioned before, traditionally, we do screening and confirmatory. Now, we do it one step with the mixing study, with a mixing step. Before, we do screening step, mixing step, and again, screening and mixing of the positive and negative. And this is the recommendation for the cutoff value, because it is very important how we report this report, because we will label the patient with antiphospholipid syndrome if we say positive or negative. According to the manufacturer cutoff value, it should be above 40 units. Usually we don't do the in-house verification of more than 120. Usually we do on a 20 sample, but we depend on the manufacturer report. So again and again, the moderate to high anticardiolipin antibodies of IgG and IgM, it's a very important. With the ELISA, we can detect presence of IgA, but actually it is not that important in the diagnosis or clinical, or we don't have enough evidence to use it for the diagnosis of antiphospholipid syndrome yet. Or other domain of the anti-beta-2 glycoprotein, like 2, 3, 4, we don't have any evidence yet to use it. It can be detected in the lab, but still we don't have enough studies to use it for the diagnosis and included in the criteria for diagnosis of antiphospholipid syndrome. This is show that beta-2 glycoprotein structure, this is an open way of the antibodies with a domain of 1, 2, 3, 4, and 5. Usually, we are working on the 1. This here, the antiphospholipid bind this domain of the beta-2 glycoprotein, preventing them from being the hook way of this antibodies or antigen. There are a new assay, as I mentioned, that it will be on other domain of beta-2 glycoprotein and IgA of instead of IgM, IgG, and still we don't know the importance of this assay. Again, this is the anticardiolipin, which is measured by ELISA. The same way of the reporting. We need above 40 units to be reported, or above 99 centile to be reported as positive. And this is the, as I mentioned before, the classification of the American and European rheumatology, which has been developed and studied on 2023 or reviewed. And This is the clinical domain. We have discussed the laboratory domain before, and we have seen the weight for the laboratory domain. For the clinical domain, macrovascular venous thromboembolism, 1 for the high risk, without risk 3, and for the macrovascular arterial thrombosis, high risk 2, without high risk 4, and obstetric 3 or more, consecutive pre-fatal and or early fatal death 1, fetal death in absence of
Iman,
preeclampsia.
3 minutes more, please.
Sorry?
3 minutes more, please.
Okay, so I have lots of slides, Dr. Najat. I'll go through the conclusion if you don't mind.
Okay, excellent. Okay, if you're in the conclusion, we're okay. Yes.
Okay. Just to mention that the pathogenesis of antiphospholipid syndrome need 2 hits of thrombosis. And the first hit is the antiphospholipid when it joined to the phospholipid, and the other hit is by activating the inappropriate activation of hemostatic factor, clotting cascade, endothelium, and platelet, disturbance in coagulation and fibrinolysis, immunothrombosis, complement, and monocytes and neutrophils. And each of this is the hypothesis how the thrombosis event happen in the antiphospholipid syndrome, because there are people with antiphospholipid antibodies positive without any symptoms or complication. And this is again all details of pathogenesis of the antiphospholipid syndrome. And there are other risk factors, and the treatment and prevention is not my field, but I will mention one thing only, that still the vitamin K inhibitor or warfarin is the drug of choice. As I mentioned, Dr. Najat, before, that patient with positive antiphospholipid antibodies need another hit to stimulate or to begin these thrombosis in everywhere. Just considering the COVID-19 and the vaccination, that have seen that people with COVID-19 reported to have more thrombosis events, arterial, venous, or microcirculatory thrombosis. And even with attenuated virus immunization or vaccination, they have seen that these people, they're prone to have more of a thrombosis. In conclusion, in summary, antiphospholipid syndrome is a thromboinflammatory autoimmune driven by autoantibodies that recognize cell surface phospholipid and phospholipid binding proteins. The result, an increase the risk of thrombotic events, pregnancy, morbidity, and other autoimmune or inflammatory complication. Vitamin K antagonists remain the most important or the appropriate treatment for the most of the patient with a thrombotic antiphospholipid syndrome, and based on current data appear superior to the direct anticoagulant. Beyond anticoagulant and anti-aggregant, recent research has highlighted additional potential therapeutic target within the innate immune system, because if we understand what happened during the presence of antiphospholipid antibodies and inflammation activation by the immune system, by the complement, by the neutrophils and monocytes. So we do think about how we can do the trigger therapy or target therapy. the potential role of immunomodulatory treatment in antiphospholipid syndrome management is rightly receiving increased attention. Because if we understand the pathophysiology of this disease, we can develop more target therapy. And this is the last slide, and thank you, everybody. That explains that the presence of antiphospholipid antibodies in a patient, sometimes discovered in the lab, coincident, but need another activation when the symptoms begin, when the thrombosis happen. Usually, we diagnose patient after the thrombosis happen. Thank you very much.
Thank you so much, Dr. Iman, for the excellent and very impressive review of antiphospholipid syndrome. And as there's no questions, we'll move to the next speaker. Our next speaker is Dr. Abu Bakr Imam. He joined the faculty at the Children's Hospital of Michigan, Wayne State University in 2001 as an assistant professor of pediatrics and became the director of renal transplantation program from 2003 through 2006. He then joined the faculty of Akron Children's Hospital in Ohio as associate professor and as a chief nephrology from 2006 through 2009. He became the head section of nephrology at King Fahd Medical City in Saudi Arabia from 2009 through 2012. And then the head of pediatric nephrology at Hamad Medical Corporation, Qatar, from 2012 to 2018. He was the director of pediatric fellowship program at Hamad Medical Corporation and the director of postgraduate medical education at Sidra Medicine, Qatar. Dr. Imam is currently the division chief of nephrology at Sidra Medicine and a clinical professor of clinical nephrology at the College of Medicine, Qatar University, and associate professor of clinical pediatrics at Weill Cornell Medicine. Welcome, Dr. Abu Bakr.
Thank you very much for the invitation. I'm trying to share my slide. Can you see my slides? Can you see my slides?
Yes, doctor, we can see your slide, but go for the slideshow, please.
Okay. Thank you very much for the invitation. I appreciate the panel inviting me for talking about this important topic that we see it a lot, and we have intersections all the time between the hematology oncology service as well as the ICU due to the clinical seriousness of the condition. I'm trying to move my slides. Yep. I have no conflict of interest. I'll start my talk today by saying that the description of hemolytic uremic syndrome has been established back in the 1950s, by Gasser et al. When he described children with kidney failure, as we now refer to as acute kidney injury, that's associated with hemolytic anemia and thrombocytopenia. From that description time, we realize that this disease is not only a identified one condition, it is part of spectrum. The spectrum is be labeled as thrombotic microangiopathy, that is, when we short term it as TMA. And a big component in that spectrum was thrombotic thrombocytopenic purpura, TTP. It's characterized by an endothelial injury that happens to the endothelial lining of the arterioles and the capillaries. And there was local alteration of the coagulation regulation that happens with it. TMA in the 1980s people are recognized that certain clinical condition associated with E. coli diarrhea, and that the patients develop thrombocytopenic purpura, hemolytic anemia, and full picture of thrombotic microangiopathy. And at that time, it was recognized and called and classified as either you have diarrhea positive, hemolytic uremic syndrome, you see. Can you hear me?
Yes, doctor.
And you can see my slides?
Still not.
You can see my slides?
Still, you can share your slide, please?
Can you see it?
Yes, it's clear.
All right. So I'm just going to say that in the 80s, we said that the Shiga toxin producing E. coli has been identified. And at that time, we classified those patients either diarrhea positive or diarrhea negative. And that was based on the clinical presentation. However, in the late 90s, we started to change the classification into from clinically based classification to pathogenesis-based classification. And at that time, the identification of TTP related to deficiency of specific enzyme or a decreased activity in that the ADAM TS13 as a causative for it. From that description, we found that there are secondary thrombotic microangiopathy. And this is due to an existing disease. And we found that certain diseases can give you secondary thrombotic microangiopathy. And that could be an autoimmune disease, as going on all the way antiphospholipid disease to medications that sometimes we use. We found that even bone marrow transplant or solid organ, specifically solid organ transplant, and the medication can also give you this. The medication used for it can also give a picture that we refer to as secondary TMA. Now, this also can be related to metabolic cause. Scopolamine has been attributed to be there. And this secondary TMA, extrinsic major endothelial insulting factors, may interact with the complement dysregulation and may not, sometimes a direct effect of it. But at that time, we identify a specific group of patients. And at that time, we changed the name from D- into atypical hemolytic uremic syndrome, or we call them AHUS. It is related to inherited or acquired dysregulation of the complement, specifically the alternative pathway of the complement. And hematologically, they display the full picture of thrombotic microangiopathy with cells that showing infectious histiocytes circulating. In the kidney, we found those grouped to have active lesions, such as thrombi that can be seen in the glomerulars or the arterioles or the big arteries, and a specific presentation in the pathology of these. Most of them are acute lesions. And this is a slide showing you how it looks with a thrombin formation and clots that's all over the glomerulus, obstructing the glomerulus from its function. How does the Shiga toxins or the E. coli affect this endothelial injury? Well, Shiga toxin, we found that they bind to a G protein, GB3. This G protein expressed a lot in young children, and that's the reason young children tend to be more affected with the Shiga toxin infection than adult. As you grow older, this G protein expression in the endothelium of the kidneys become less. And then it induced some sort of intracellular mechanism resulting in caspase activation, resulting in apoptosis and cell death as soon as the endothelium is injured and the integrity of the endothelium is disrupted. Now the platelets come to heal this damage. With the healing, platelets come in, and the end result is fragmented red blood cells in the circulation and the blockage and the thrombin in the kidneys. Now, the atypical HUS, we found that it is due to variance in complement genes or genomic rearrangement in around 60% of patients. And some literature take it from 50 to 80%. However, in North America, it's been reported to be 26%. And this is because they're mixing the primary and the secondary together. But if you isolate the primary from the secondary we said other diseases can cause it, and the primary as due to specifically to the complement activation or deactivation or dysregulation. Around 500 and more, and as the day goes by, we've seen more variants of these 5 complement genes that I wanted to focus on. Complement factor H, complement factor I, and membrane cofactor protein, what you call it also CD46, and the complement C3 convertase component, which is C3 and complement factor B. We identified there is other group of patients also have non-complement gene that we call it DGKE gene. This is not related to the complements, and they have a different pathogenesis for it. This is a display of how the complement system works. While it goes through an activation either of the classical pathway, lectin pathway, and alternative pathway, those result in this activation and amplification phase. This amplification phase requires certain controllers to control this system. And the normal circumstances, we do not need to do anything. The whole thing is that the complement system is trying to protect our immune system from bacteria or from any invasion with any organisms. So it does want to opsonize or have these organisms to be killed and to be eradicated. So the complement system keeps this amplification with a control there, either a membrane, or CD46, or in a fluid phase, factor I and factor H. Those complement control this activity. The end result is the C3b is important, and the convertase, C3 convertase is an important factor. Why they are important? Because they continue to go to the terminal pathway when they are activated, when they are in a higher levels. So any factors or any conditions that affect these inhibitory system of the complement from activation, it will affect the production of C3b and B component of the complements, which is what we call the active form. This is the one that you need. If you have any condition that increase the production of these in certain genetic mutation, yes, you will end up having an override of these inhibitors. So the end result is C5 get converted into C5a, which is a weak small protein, and the C5b. C5b is a very important because it then goes to the final terminal C3s, C6, 7, 8, and give you the C5b. This is what we call it a membrane attack complex. These are the ones that really going to go and create holes in the organism. Another factor here is called CD59, which has been attributed to a different type of disease, paroxysmal nocturnal hemoglobinuria, which is another disease. So the complement factor H, we know exactly where the mutation takes place. What is the mechanism of the complement? It competitively binds to the CB to inhibit the C3 convertase production, and the end result is less of accelerating the C3 convertase degradation. So you will have more of that, and the end result is a stimulation of the terminal pathway. It also helps the factor I also. Now, this mutation is the highest one, the complement factor H, more than 30%. You're going to see 45%, 40%. The MCP, or the CD46, as I mentioned, is a cofactor for complement factor I. Again, it helps in the cleavage to maintain the integrity of the system. Factor I regulates both the classical and alternative pathways. The mutation of this is around 4 to 10%, 8 to 10%, and so forth. C3 is required for the formation of C3 convertase, and again, that will go to C5 convertase. Again, these tend to be now less and less causation. There is another one that I'm going to say, I'm going to leave it for you, thrombomodulin, which is involved in the cascade coagulation. Again, there is very little one. We always focus on these top three, one factor, I factor, H, and MCP1. They tend to be the one that cause most of the problem. This is how it works in the initiation phase and the cleavage. The system of the complement, it works by an induction of an enzyme that cleave. Whenever they cleave, now it's an active format there. And then it goes through an amplification phase that the same product amplifies itself and brings more. And then it goes by regulation. Now the regulation comes in, the complement factor I and complement factor H, and they play a significant role. What's the importance of this? That the frequency, as I mentioned, factor I can be up to 30% and so forth. But what's important that when you have those mutations, your outcome can be of concern. 63 or 60 to 80% you might die or develop in the stage kidney disease. And again, the rest have the same effect. Now, the relapse rate on those patients, that how much of them they can develop further the disease, yes. And what's so important also for us in the nephrology world, that those patients, we end up transplanting them because transplant is the treatment choice for children with kidney disease, that they might have a recurrence of the transplant. You can see how high this recurrence, and this recurrence can result in loss of graft. We know that it typically actuates is a multifactorial in nature, and it can have not only renal manifestation, but other renal manifestations, central nervous system. That when we start to interfere with, intersect with TTP, cardiovascular, peripheral vasculature affected, pulmonary and gastrointestinal skeletal muscles. Now, what we found that very interesting, that relatives of the affected children with genetic mutation can be there in about 50 to 80%. And that it is not only that you have the mutation, you develop the disease. So there might be a second hit that was identified in 35% atypical events. And we know that individuals who harbor several genes develop the disease. So maybe you have an intersection between the genes, and the genetic people here help us in interpreting all this data for them. Now, we know that clinical expression of one pathogenic variant could modified by the association of other genes, and that there are some genetic modifiers. We know that this disease have some sort of endothelial stressors that when we'll talk about chegotoxins and strep infection and antiphospholipid syndrome, catastrophic antiphospholipid syndrome can be there, and solid organ transplantation and hematopoietic stem cells are also there. Now, atypical HUS tend to be on the genetic background. We've seen that malignant hypertension can give you this. This is through the effect directly to the endothelial injury. However, they found that there is some genetic background associated. And you could see they are intersecting at some point between the two domains. Strep infection can cause a problem for us on those patients with how many times we see pneumococcal infection? A lot. And those patients, we found that 5 to 15% of those patients can develop this disease, typically present with pneumonia in 70%. The pathophysiology is that you do have an increased suppression of the surface protein bind to the plasminogen, and the role of the cell is released by the pneumococcal infection, causing direct exposure of the T antigen on the red blood cells, causing aggregation of these cells. However, we found that why those patients develop this, we found that it might not be due to the organism, it might be also due to the host has some sort of tendency to developing this, because not all of them develop it. Looking at the complement system through all it is factors that involve in the activation and then the amplification phase, and then the modification where the complement modification takes place in the control of the C3b, and the end result is prevention of this from happening, C5b combination with the terminal complements. We have to remember that the terminal complements, when we talk about C6, we know that they affect those individuals who have mutation indirectly on this or problem with it. They end up having meningococcal problems, and we're going to see how important that end result is. C5b is not being delivered to the terminal pathway, and the membrane attack complex is not delivered under normal circumstances. Any mutations here or increased production of this part result in the system get dysregulated. The end result is membrane attack complex get generated. We know that this will attack directly the endothelial cell and cause the damage, while the weaker one, the C5a, has been associated with other uncalled thrombosis and so forth. Now, the atypical HUS, either due to the overactivation, the C3 and C4 complement factor B, making it more, takes off the control of the complements, factor HI and the MCP over there, or failed regulation of these, or sometimes the antibody presence. Certain diseases can have these antibodies, and that's why it's important to identify where the problem is. It genetically, or there is an antibody associated with it? Because there is antibody, the treatment also have to be affected. In all, sometimes can be delivered in adult by pregnancy, or in pediatric by transplant, cancer, and medications that treat it. And sometimes just viral infection disturb the complement system, triggers, and that's why we call it the second hit. This puzzle has been going on for a long time, and I can tell you we lost a lot of patients with this disease. As I mentioned, it's a multifactorial, it has different presentation. Until the discovery of the terminal C5 and human antibody, monoclonal antibody, has been established, the eculizumab, and approved by the FDA in 2011. That prevent this from cleavage of the C5 to C5a and C5b, and the end result is stopping the membrane attack complex from formation. And what we find that when that happens, all of the upside of the alternative pathway get terminated. And the end result is you protected the endothelium from being attacked. We found that this has been used for a long time, and it has improved kidney function and improve those patients' outcome, and the platelets formation, all things being established in all, and with different responses that we can see in those patients with different mutations. That's why we like to see what type of mutation and how can that help. The question came up that can this help in the atypical, in the typical one? Well, data did not show that it does change the outcome of those with diarrhea positive, as we used to call them in the past, and we call them typical HUS right now, because the complement system is affected, but not to the maximum degree as in the atypical one. Different people have different tried other medication that have some role on there. This has been used mainly for specific treatment for what we call it ANCA vasculitis in children, but the presence of eculizumab and then ravulizumab has come in to replace eculizumab because it's a more long-acting, and eculizumab went out of the manufacturing phase. When we try to transplant those patients, we look at what is the recurrence rate, high recurrence rate. Those are high risk, moderate risk, and low risk for them. And that's why we give them eculizumab at the time of the transplant. And sometimes we have to do certain interventions for those moderate low risk if they have no mutation identified. And yet we still have some patients who don't have genetic mutation. And that's why we're still solving the puzzle as we go, and we're looking for more and more. Yet the puzzle is much better right now, and the mystery is much better understood. Now, if we have a TMA syndrome, we have to rule out TTP from the beginning. We send Adam TS13. If it is high, it's TPP. No, it's HUS. Do we have diarrhea or not? There is no. It's sugar toxin or not. If it is yes, out. Now, if it is not, we have all these, as we call them here, the secondary type of atypical hemolytic uremic syndrome, and then we go to the primary hemolytic uremic syndrome for the transplantation can also be there. We try to avoid a lot of implications on the treatment. We try at the beginning, first of all, remove antibodies. We think about antibodies. Plasmapheresis tend to be handy. However, with the discovery of eculizumab became the primary approach for our patient. We have to identify if we have anemia, elevated LDH, thrombocytopenia, decreased haptoglobination size in the peripheral smears. Again, it is atypical, or it is you have a diarrhea and a PTT. So we rule those at the beginning, and then we go back into what are the causes. It is associated with a syndrome or a medications and all that. And then we have primary atypical HH. We send the factors, mutation, and the antibodies, because we make sure that we do. And sometimes we start this, and as I mentioned, there is a specific one that it's not complement mediated, the GKE atypical HUS. Now, with all this puzzle being solved and being solved, as we know that the inhibition of this, now eculizumab is out of production by the company, and now we're going with ravulizumab as an alternative because it's long-acting and it's better given for those patients. For the sake of time, I'm going to summarize my presentation saying that atypical hemolytic uremic syndrome is a serious disease that may lead to multiple organ damage and end-stage kidney disease. As you've seen, that it has a big spectrum of clinical presentation, and the impact of it is a serious ill child in the ICU, sometimes can go from infancy all the way, and those are tend to be the most difficult ones. The alternative pathway is the key role and its pathophysiology, the dysregulation, either overproduction of certain factors or underproduction of certain factors due to genetic or antibody mediated problems. Now, the complement system inhibition gave us, and that's why in the old days, we tend to lose those patients. We did not know what to do with them when we try our plasmapheresis. Our plasmapheresis was our only way out. But sometimes if the problem is genetic, and we don't have, when we do this plasmapheresis with our plasma exchange, we don't remove anything. It's not helping the patient. However, we have to do something. Nowadays, we have the first-line therapy is the inhibition of the terminal pathway. Now, eculizumab is the first one available, that was available. Right now, ravulizumab is a long-acting one, regenerated from the eculizumab. It's the same component, same mechanism of action, but it enables reduction of the dosing frequency. It's long-acting and improving the quality of life patients, that they don't have to come that frequent for the infusion. But the story is not completed here. I'll be unfair to tell you that the problem is completely solved, because we have a problem that these are expensive medications. We have to all put in mind in that. But when do we stop it? When do we say enough is enough? We are treated and we can get over. Those who have genetic mutation, we cannot stop because we found that the recurrence rate continues. And right now in the community of nephrology, we are trying to figure out with multi centers studies, looking at what are the criteria, and different agencies, different societies have established some sort of guidelines to tell you when to stop and how safe where to stop. We still use plasma exchange for antibodies removal when we start to think about that. With this, I would like to thank you all for listening to me, and I am happy to take any questions from you.
Thank you so much, Dr. Abu Bakr, for the excellent and impressive review of HUS. As there is no questions, we'll move to the next speaker. Our next speaker is Dr. Kate here. Dr. Kate is an advocate of the nurses' role in the multidisciplinary team, is the chair of the Nurses Committee of the World Federation of Hemophilia, a founding trustee of the HEMNET, a hemophilia education and research organization, where she is now director of research and is the editor-in-chief of the Journal of Hemophilia Practice. Dr. Kerr worked in Hemophilia Center at Great Ormond Street Hospital for Children from 1991 as a consultant nurse. She works into outcome research in hemophilia and bleeding disorders, continues and includes supporting PhD students in health outcomes and research. Welcome, Dr. Kate.
I was formerly the haemophilia nurse consultant at Great Ormond Street and also the... So starting off with a historical perspective of nursing, it was our friend Florence Nightingale who defined nursing as the act of utilising the environment of the patient to assist him in his recovery. And I think this is something that we still very much do as we work with patients with haemophilia and other bleeding disorders. We now work within a comprehensive care service, and within that team, which is multidisciplinary, there will be a haematologist, a nurse, hopefully a physiotherapist, perhaps a social worker and dentists. And we all work in collaboration with ourselves, but also with the patient and his family, to minimise the effects of haemophilia on them. And we do that using preventive strategies such as prophylaxis where we're able to, and enlisting community support, so perhaps through a local haemophilia society, and trying to maximise quality of life for the person himself and his family. So in that comprehensive care model, you can see here that the patient is absolutely in the centre and is surrounded by those of us who provide care to him and his family. And here on the right-hand side at the bottom, we have the people who I think are the most important, who are, of course, nurses, who are very key in supporting the patient and his family as they progress through from diagnosis to starting treatment, to being able to self-infuse, perhaps to having surgery, and everything else that happens to patients along the way. The role of the haemophilia nurse in that patient's journey will vary depending upon where you are in the world and the access that you have to healthcare. So it may be that in your region of the world, prophylaxis is not available, in which case you'll be treating patients on demand. It may be that you have limited resources, that you don't have a full comprehensive care team, that access to healthcare is difficult based on where the patient lives and geography, and whether or not your factor and care is provided free of charge, as it is here in the UK, or whether there has to be some form of insurance to pay for some of the care or all of the care, and whether some or all of that care can be delivered to people at home as well as in the hospital. So in Europe, we have something called the European Association for Haemophilia and Allied Disorders, or EHAD, who have a nurses committee and who have just published, literally this week, on the role of the specialist nurse in comprehensive care for people with bleeding disorders across Europe. They have done a massive literature review and have come up with 5 key roles for nurses, which are being the educator, a coordinator, a supporter of people with haemophilia, obviously, a treater of them, and a researcher. And all of you, even if you're not in Europe, will be doing this, I'm absolutely certain. Haemophilia nursing has 2 key parts, I think. The traditional roles of teaching people how to self-infuse and treating bleeding episodes when they occur. But also now, and this obviously depends on where you are in the world and what you're allowed to do legally, are extended roles. And these may include history taking, assessing bleeding episodes, participating in or even making treatment decisions, providing independent follow-up. Very often this is done by telephone, so even pre-COVID and being able to use telecommunications to assess patients, I think we were doing that already. And of course, coordinating the care of people throughout their life. To do that, we need those 5 key roles that the EHAD nurses came up with to support our patients and their families. And the first and most important of those, I think, is education. And that is around teaching patients and their families from the day they're diagnosed to help prevent bleeding, be that prophylaxis or limiting some of their activities, or thinking about how safe it is to undertake those activities on particular days if they're able to access treatment. Education about treatment choices, and that's never more important than it is these days, when it's not just a decision about you have factor 8 or you have factor 9 because you have haemophilia, but there are so many different ways of being able to treat haemophilia. And building skills to assess and treat people at home. We need to be able to teach other nurses and physicians and clinicians to act as that resource for the hospital nurses about how to reconstitute factor, how to dose and administer it, particularly if you have patients having surgery and they're needing dosing out of normal office hours. And for children's nurses to teach school staff and perhaps employers of people with haemophilia or parents of children with haemophilia about the impact that it has on a day-to-day basis, and perhaps why children are late to school, can't attend school, or why the parents need to miss time from school to attend the hospital with their child, and also for adults then with haemophilia, if they're having bleeding, why they perhaps can't attend work. A really key part of being able to do that is to have a history and assessment skills. We know that an accurate, detailed history and assessment for bleeding episodes is really essential as we plan the care that the patient is about to receive. And you will all, I'm sure, be asking these 5 questions every day of the people that you see. So, what are your symptoms? Is it your knee, your elbow, your ankle? How long have you had those symptoms for? What treatment have you already had, if any? And when did you have it? Is this an injury or a trauma? So is it a haemophilia bleed, or is it a different thing that is causing a problem with the knee? Is it a routine normal musculoskeletal injury that is enhanced by haemophilia? Has this happened before in the past? And if it did, what did you then do in terms of treatment to make the problem better? This process is continuous from the very first notification. So when perhaps the patient phones you up to say, I can't walk today, I've got a problem with my ankle, through to seeing them in the centre, treating them and following up that episode. And I would just stress here that analgesia use is key. So we're not very good at getting parents particularly to treat their children's pain as well as treating their children's haemophilia. A key part of our assessment is reviewing the patient and family repeatedly throughout their journey with haemophilia. So that means to think about whether they're still on an effective dose, whether they are treating around activities, whether the response to treatment is as expected, and if it isn't, what should we do about it? If when they have bleeds, have they used splints or crutches? And are recommendations about treatment and management being followed? And if not, what can we do to re-educate the patient or to change the recommendations to something that they can follow? Each time we see them, we should be reviewing the dose and the product that they're on, reinforcing early treatment for any bleeding, reminding the family to call at the first concern about possible bleed or any questions or concerns that they have about their child or themselves, and to educate community providers if care is being given somewhere that is not in the haemophilia treatment centre, so perhaps at a local hospital, a paediatrician, a local provider, or in another hospital that is not your hospital but is also a haemophilia centre. Another key role for us as nurses is to coordinate the team, and that is to collaborate with the medical director, who is usually your haematologist, in development and implementation of treatment guidelines for patients, be that prophylaxis or for surgery, and to distribute that information to the patients and families themselves, to the rest of the haemophilia treatment team, so to your physiotherapist perhaps, also to other hospital staff that are impacted, so maybe your patient is having dentistry or surgery. You need to make sure that the surgeon and the dentist understand what's happening, as should the nurses on the wards where the patients are being nursed. And of course, if there's follow-up out in the community after the patient is discharged, there should be good coordination and communication with them. I'm going to use the big scary R word here now, and that is research. And haemophilia nurses are doing research all of the time. I think sometimes we get a bit scared by the word, but actually you're doing it already. You just need to be braver about thinking about and saying that you do it. So we do that through data collection, so registry of patients, our treatment records, surveillance of the blood results coming back from your laboratory for individual patients, and that can all then be aggregated data for patient populations. So you can say that in your treatment centre, X% of patients are on prophylaxis. That is research, and you are collecting that data. You're also taking specimens, which will give you that data. You might be part of an actual clinical research study, but everything that you're doing complements the research for all of the patients that we're looking after and adds to the evidence for the care that we give now and moving forwards. Treatment success, I really think, is our role. I think we have the best, closest relationships with patients and their families. So we can have the most honest and open conversations with them, and we can acknowledge that it is difficult to live with and to treat haemophilia. We can initiate follow-up and review progress perhaps outside of normal routine haemophilia clinic visits. We can talk to people about the challenges that they have in their lives. So perhaps a mum has 3 children with haemophilia and we're saying please treat them all before they go to school. Actually, that's really difficult. It's difficult enough to get your 3 children to school without them having haemophilia. So we can perhaps think about how that is difficult for individual families and then collaborate on strategies to improve how it is for that individual family and how that plan then fits into the lifestyle of the patient and family. We can provide thorough education and skills training to individual patients and families. And to remember here that children quite often learn things from their parents. Their parents will have learnt things about haemophilia perhaps 10 years ago when their child was diagnosed, and things change. So treatments change, our thinking about how we treat haemophilia has changed. And so it's really important that we continue to provide that education whenever we're seeing patients, talking to them about new ideas, new ways of training, new ways of teaching, new ways of treating, and to review whether the patients are on the treatment that is still best for them or whether there are things that might be a better treatment option that might make them more compliant if they're not compliant, and to think about how the children in particular are learning that education from us and not just from the parents, so that they're getting the most up-to-date, accurate knowledge that is available about haemophilia care. Of course, reviewing skills around injection technique, but throughout all of that remaining professional and supportive. So in summary here, I'm going to say that I think nurses are the key members of the team, providing that link between patient and medical providers. And as I've already said, we have key important roles. The World Federation of Haemophilia guidelines for the management of people with haemophilia, which were published back in 2020, talk about the role of the nurse 13 times. So that shows that across wherever you are in the world, you are recognised as being an important member in the team that manages people with haemophilia. But all of that is only based on being competent, so having the skills and knowledge to be able to deliver that care effectively. So on this slide now, I'm just going to show you a little bit about competence in haemophilia nurses. So here in the UK, 10 years ago now, we first published a core competency framework for nurses working in haemophilia care. That was quickly followed by a European curriculum for nurses working in haemophilia, and then updated in 2020, a UK specialist framework. Now, I'm going to talk a little bit on the next few slides about what this means, and I'm very aware that this is very Western, very North Europe focused, and this might not be fully relevant to what you have in your treatment centre or what you can do. But you have competence at every level of everything that you are able to do, so please just bear with me. So competency, and that might be in a framework, it might not, is underpinned by education and training. So the formal education that we all had as basic nurses, we're competent in many things, even if we know nothing at all about haemophilia. So you know how to give an injection, you know how to talk to patients, you know how to take bloods. There's lots of things you can do. Then you might have haemophilia specific education, and that could be local, regional, national or global, and you're participating in that right now. But you might also have non-haemophilia specific education, so perhaps things about thrombosis or research or budgeting, things that are important to you in the job that you're doing right now. Then you can have on-the-job learning, so clinical assessment, so seeing a joint bleed, feeling it perhaps with your physiotherapist, learning those new skills. And we have a saying in the UK where we say, you see one, you do one, you teach one. So you see one horrible knee bleed, you see it again, and then you can teach people about a horrible knee bleed. You're learning about new therapies as they're introduced, and all of that is at a multidisciplinary level. So you could be learning from your lab staff, your dentist, your doctor, your physio. And of course, the self-directed learning by reading journals, online courses that you might do, and that might be the mandatory training that you have to do in your hospital. But also think about who you follow on social media. Are they the influencers of haemophilia care? And what are you learning from just reading what they've tweeted or put out through LinkedIn, etc.? A framework allows nurses to read and reflect upon the content of the units, and I'm going to come on to some of the units in a minute, to decide where your level of competence is, and then whether you need to have some specific educational training so that you improve your competence, so that you have your own educational journey to being fully competent. Now, I'm sure you will all remember the great work of Patricia Benner, her work from novice to expert, which shows how as nurses, the very first day we ever stepped foot on a ward, we knew absolutely nothing about anything. And wherever you are now, you're on some journey to becoming an expert nurse. And I'm sure that you're all on that journey to becoming expert haemophilia nurses. So here is a couple more slides about the UK Haemophilia Nurse Competency Framework. So we have 5 core units, and they are very similar to the 5 key things that the EHAD nurses group have just come up with. And they are that we are good at communication, research, education, support and treatment. And they're in that order because it was called CREST. So you had to become CREST competent. It made a word. There's no particular order for them. You can be good at one and not so great at another. We then also have 6 satellite units, which might or might not be relevant depending on where you work. So there's a unit around women, there's a unit around children, leadership, inhibitors, genetics and physiotherapy. And each of these units has 4 domains, and we'll see those in just a minute. And each of those domains has got up to 4 levels of competence, and they all link together into something which is very English, called the Department of Health, Knowledge and Skills Framework. So you can ignore that, but just think about how all of those things link together to make a whole. So on the next 2 slides, I'm just going to show you an example of the core unit here, which is treatment, and then on the next slide, one of the satellite units. So here you can see in core treatment, we have diagnostic skills, factor replacement skills, and clinical decision making. And you can see how, if you look at diagnostic skills, you can work through from recognising the signs and symptoms of bleeding to being able to determine a differential diagnosis. So perhaps it's not a bleed, it's an injury caused by falling down the stairs and you've torn a ligament. Factor replacement goes from being able to take bloods to being able to prescribe replacement therapy. In the UK, we can independently prescribe as nurses. I appreciate you might not be able to do that where you are, but you will be helping your doctors or clinicians to prescribe the right treatment for the right patient. Let's move on now to the satellite unit. I've picked children and young people because I am a children's nurse. And again, here you can see those 4 key areas, from monitoring health through to supporting transition. And within each of those, there are 4 key areas. So communicating with children and young people in an age and developmentally appropriate manner, through to recognising consent processes and acting as an advocate for children. And of course, within paediatrics, a very key area, whether you work in a children's hospital only with children, or whether you are in a combined centre or service where you have children and adults, it is around moving those children on from being a child into a young adult so that they're able to advocate for themselves. So that's about providing information, supporting them in their own decision making, reviewing their self-management skills, and then transitioning from paediatric care to adult care as necessary. So in summary, competency frameworks allow nurses to assess our own level of professional development and recognise areas where we perhaps need further development so that we can hone our skills further. And you can use a framework, if you have one, to track your journey. So these are really useful in having annual reviews with your managers to say, I need to learn more about something, perhaps genetics or counselling, so that you can provide a better care to the patients that you're looking after. Those competency frameworks, if you have one, should be really adaptable, because we have new and evolving treatments coming all the time, so we have to be able to adapt them for that. But also your local regional rules and policies will be very different. So what works in the UK might not work in Holland, it might not work in America. But what does work across all of those countries is nurses providing really good nursing care to people with haemophilia and other bleeding disorders and to their families. So I'm just going to stop talking now. Questions and answers are coming up in a minute, but I'm just going to leave this slide here for some resources for you. So the slides have got references on. Hopefully, if you want them, you can find those references. If not, please just email me. That's kate@hemnet.com. I'm very happy to support you. But also here to draw your attention to the resources that the World Federation of Haemophilia have on their website, particularly this new project that they've got, which is the WFH Shared Decision Making Tool for Haemophilia Treatment, which is a really interactive tool that you can use with patients, from plasma-derived on-demand treatment through recombinant, through extended half-life recombinant, through non-factor replacement therapies, through to gene therapy. They're there to help you and help your patients make decisions, so please do use them if you can. Thank you very much for listening, and we'll be open for questions any second now.
Thank you so much, Dr. Kate, for the excellent and comprehensive review of the nurse's role in hemophilia management. As we all know, the nurse is the most important person in the hemophilia team. She's the direct contact with the patients, and she's the one who really helps the patient through his journey.
Thank you, Dr. Najat.
Yeah, please.
Thank you. Thank you all for listening.
Okay, there is no question, so thanks very much for joining us. And now we'll break for the lunch and prayer. And kindly, we need to restart at 1 p.m. sharp, because still we have many excellent speakers with us, and will join us after 1 p.m. And we have a lot of interesting and important topics to cover. So kindly be back by 1 p.m. Okay, so bye for now. We'll come back after the break. We'll start now with Mrs. Mariam Ayash. Mrs. Mariam is a clinical nurse educator in pediatric hematology, oncology, and polyclinic from February 2019, qualified with BSc nursing and has 17 years of experience in clinical nursing. She joined TAWAM in October 2005 as GNI in pediatric medical and moved to pediatric oncology until 2006. Being an educator role, actively participating in all educational activities like hospital orientation programs, workshops, competencies, simulation, grand rounds, etc. As per learning needs, identified the gaps, conducted teaching session by liaison liaisoning with the nurse manager. Welcome, Dr. Mariam. Mariam.
Thank you very much. Good afternoon, everybody.
Good afternoon.
I can start.
Yes, please.
My presentation.
Please start, Mariam.
Can you see the presentation or not yet?
We cannot see your presentation.
Yeah.
Could you please share your screen?
I'm trying to share the screen. What about now?
Still we not see. Just open your slide first and close the menu of sharing screen and open it again. And you can see and share.
What about now?
Still not showing as you sharing your screen. It's not showing.
So you want me to show the share the screen or the presentation itself? I'm trying both ways. It's not.
Just from the menu, you can see share screen.
Yes, I click on that one.
Okay, it should open a menu.
Yes.
You
Chrome
can,
tab, window, and entire screen.
yeah, you just select your, if you can see your slide on this menu.
No, I can share the entire screen.
You can share, if you open your presentation, you can see it inside this menu. Before you start sharing screen, just open your presentation, then select share screen. You will see the presentation inside the menu itself.
I cannot see it. I don't know why. Even my presentation is open.
You minimize it or it's open?
I minimize it.
Open it, please.
Now.
Maximize, yeah.
You can see it now?
Close the menu and open the menu again, and you can see the slide, it will be inside. You can select and share.
Sorry. What about now?
Still, if you can, I will share my email to direct message to you. Send it to me. I will give you the control so you can control from our side. I will share from my side. Okay?
Okay, I'll email it to you. You send me the email.
You sent your presentation?
I didn't receive any email.
I send you direct message through Zoom.
I thought through to the email. I opened my email.
You can see the chat.
Okay, questions and answers.
Chat.
Okay, I opened the chat.
You will see my email.
Ahmed?
Ahmed@educationplus.me.
Okay. I sent it already.
Okay, just a second. So I share my screen now. You can, I will give you the remote control. You can move your slide from your end. Okay, doctor?
Okay, so I have to open the presentation here at my side or what?
No, I already shared from my side. I just give you the control. You can see, you can use the control to move your slide only.
Okay, that's fine. Okay, thank you very much. So good afternoon, everybody, and assalamu alaikum. In this coming 30 minutes, we're going to talk about the thalassemia and the nursing impact for these types of patients. Okay, so the objectives is we'll identify a thalassemia, we'll talk about the background, types, diagnosis, clinical manifestation, treatment, and nurses' role in the management during the treatment of thalassemia patient. So the thalassemia is inherited disorder characterized by the reduced or the absent amount of hemoglobin, and you know that the hemoglobin is the carrying protein that carries oxygen to our body. Thalassemia was diagnosed in Cyprus in 1944, and in 1948 thalassemia is determined to be caused by abnormal hemoglobin. And in 1964, the thalassemia mutation is found to protect against malaria, which was spreading worldwide. And yearly, there is a new 127,000 births of people with thalassemia. So as you can see here in the image, the red blood cells, and inside and under the blood cells, we can see the hemoglobin molecule, and in that hemoglobin molecule, we can see the beta chains and alpha chains, which are the one who are affected if the patient is having thalassemia. This is how the normal red blood cells looks under the microscope for patients who don't have thalassemia, and you can see the differences between them and the abnormal thalassemia red blood cells. You can see how they look different. Because it takes time to move to the second screen. So there are different types of thalassemia. So hemoglobin is made up of two parts, as we've seen in the previous image. We have the alpha and the beta. So thalassemia occurs when there is defect in the genes that helps to control the production of one of these proteins. So we have the alpha, which occur when a gene related to the alpha globin are missing or changed. And when we have the beta thalassemia, if the affected gene is the beta genes. Thalassemia traits, which is one of the types of thalassemia that patient might have. And these patients, they are having very minimal clinical presentation, or almost normal patients. We have beta thalassemia trait, which result from defect in single beta gene. And if we compare it to beta thalassemia major, it is because of the defect in both genes. When we talk about alpha thalassemia, it results from the deletion in one or more of the 4 alpha genes. This will be explained here, as you can see here in the alpha thalassemia. This is the first one, which is 4 alpha genes are in blue. This is the normal. And so if we have any of the 4 genes affected, this patient will end up with alpha thalassemia trait. The beta is different, so this is the beta thalassemia genes. So if you can see the two blue genes, which is the normal patients who don't have thalassemia or beta thalassemia, if the patient have a defect or issues with one of the genes, then patient will have a beta thalassemia trait or beta thalassemia minor. And if the defect happens in both genes, then patient will be beta thalassemia major. And these are the patients that we see in the clinical area, and they come to the hospital with frequent visits. In this image, it is explaining how patient might have the thalassemia. So if we have the two parents here, and each one of them is thalassemia minor, with each pregnancy, the family should understand that there is 25% to have a normal child who does not have even a trait or minor of thalassemia, 50% patient or the child that is being born might have thalassemia minor, and another 25% to have thalassemia major. So it depends on what are the gene that was moved from the parents into the child, and this is with each pregnancy, and this is one of the important education and counseling that should take place for the patients who are thalassemia minor. Three types of beta thalassemia. So the beta thalassemia minor, when we have heterozygous condition and patient will be asymptomatic, patient might have mild anemia, which really does not require transfusions unless there is emergency or patients going for major surgery. Then this is the time that patient might require transfusion. And here is very important to conduct genetic counseling for the patients. And we start from early stages of life, and when the patients start to think about getting married, to find out the appropriate couple if they are beta thalassemia minor. Patient with beta thalassemia intermediate, there will be various genetic interactions, and patient will have mild to moderate anemia, and the diagnosis will not be in early stage. It will take time, and it might be discovered in late stages of childhood. Patient might require transfusion from on and off time. And of course, maybe if they go for some surgery or ladies who give birth, they might require blood transfusion. When we talk about beta thalassemia major, these patients, they have homozygous disorder, and there is significant imbalance of the alpha or beta globin chains. For sure, patient will experience severe anemia and will be discovered in early stage. So we usually diagnose them at the age of 6 months, 7 months, or 8 months, as early as this. And they will require lifelong red blood cells transfusion, RBC transfusion. And if not monitored, patient might die in early stages of life. How we get the diagnosis of thalassemia? Patient will do CBC and hemoglobin electrophoresis. So with the CBC, the lab technician, they will look at the size, number, and maturity of different blood cells, and they will look at the shape of these red blood cells to find out if there is modification or deformities in these red blood cells because of the thalassemia. And the hemoglobin electrophoresis with A2 quantitation, again, the lab technician will look at specific red blood cells and hemoglobin and how they look like under the microscope to reach into diagnosis that this patient is having thalassemia, in addition to family history. Of course, we go and interview and we look at the family history. If the two parents or the parents, they do have thalassemia or they are thalassemia trait or not. And I think in majority of the countries, premarital screening is mandatory, and they don't allow to go for like court marriage unless the two couples have done the screening. This is to try to prevent such type of chronic diseases from spreading. Clinical manifestation: patients will have anemia, failure to thrive, frequent infections, hepatosplenomegaly, bone marrow hyperplasia, shortness of breath, growth failure, face bones, deformities, fatigue, and jaundice. Here, as you can see, this is some of the photos for patients. For patients, anyway, it doesn't want to move back. Anyway, so it was a photo for a patient who is beta thalassemia major and who are receiving blood transfusion frequently. There is already start to have face bones deformities and changes. In addition to jaundice. Treatment for beta thalassemia. So, of course, regular blood transfusion is the main concern and the main treatment for this patient. So we give them a blood transfusion to help to prevent the severe anemia and the side effects of severe anemia, and to try to allow them to have almost normal growth and development and life. Because as we mentioned, it is lifelong disease that patients and parents have to understand and accommodate and change their life according to it. We start the transfusion when the patients start to have drop in the hemoglobin and start to have clinical manifestations of low hemoglobin. The aim is to maintain the blood hemoglobin around 11 and not to exceed 15. Usually, patient will have blood transfusion or RBCs transfusion every 2 to 4 weeks. It depends on how long patient is able to maintain the red blood cells. And we don't give them an old blood, maximum of 7 days old blood. This is to help them to have the hemoglobin maintained for longer period of time, and to try to minimize or decrease the frequency of the transfusion. And of course, we give them washed and irradiated red blood cells to help them if they plan to go for transplantation, and to minimize the risk for, or to minimize the antibodies formation. Other treatment that we have that is being taken in consideration is splenectomy, and it's done for these patients who have very frequent blood transfusion, patients who cannot maintain their hemoglobin level. So splenectomy is one of the options that's been taken in consideration. Majority of patients with thalassemia, they do splenectomy at one stage in their life. Iron chelation, which is very important to educate patient about it and make sure that patient is compliant with it. Because due to repetitive blood transfusion, patient might have iron loading, and this loading can affect and accumulate in some organs and can lead to some organ complication and damage. Bone marrow transplantation is a great option for the patient if they can and they can find an unaffected sibling who match after HLA typing is done, or matched unrelated donor. It is a good option to help patient not to solve the issue or the problem of beta thalassemia, and not to go for frequent transfusions. Gene therapy is also a new treatment modalities, which it is still under trials and clinical trials and investigation, which is also might be available in some countries. Iron overload, this is what we were talking about. It's one of the side effects that the patient might have because of the frequent blood transfusion. So there might be accumulation of the iron because of the frequent transfusion. So the major organs and sites that the patient might have iron loading and being affected is the pituitary gland, parathyroid and thyroid gland, heart, liver, pancreas, and gonads. So if we have the pituitary gland being affected, patient will have impaired growth. Heart will result into cardiomyopathy and cardiac failure. If the liver is being affected, patient will have hepatic cirrhosis. Pancreas will lead the patient to be diabetic and start another journey with the treatment of diabetes mellitus. Gonads, patient might have infertility. Nursing management. So we as nurses, we play an important role in the management and education of these patients. So some of the important nursing diagnosis for these patients is ineffective tissue perfusion related to reduced cellular components, and our goal will be improve the tissue perfusion. So as nurses, we monitor the patient vital signs and monitor the patient for signs and symptoms of hypoxia, such as cyanosis and hyperventilation, and we administer patient oxygen for the patient as required. Another important nursing diagnosis, activity intolerance related to the imbalance of oxygen supply and consumption. So these red blood cells, they don't carry the oxygen like the regular red blood cells. So there will be a gap between the supply of oxygen and the consumption of the patient. So we aim to improve the activity tolerance for the patient. So we educate the patient and we assist the patient to be engaged in some activities, take frequent rest if he requires to have oxygen in between, and to assess the vital signs of the patient, and of course give blood transfusion as required. Imbalanced nutrition related to lack of appetite. So nutrition also might be an issue with these patients. So the goal is to maintain nutritional level. So we instruct the patient to take food as tolerated. So they might have low appetite. So we encourage them to take the food as they tolerate, and frequent food or frequent meals. We encourage them or we advise them to take high protein and high calorie diets to help them to maintain their health, and we monitor their height and weight whenever they on their regular visits to the clinic. Might be referred by the physician to the dietitian, and she might advise some supplement for them. The nurse's role during the treatment is, of course, one of the major treatment modalities for these patients is blood transfusion. So the nurses are the one who handle the transfusion from A to Z. So starting from the order by the physician, so preparing the blood, giving medication for the patient pre and post, preparing the patient for the transfusion, monitoring of the patient during pre and post transfusion, education of the expected side effect, monitoring and maintaining the confidentiality of the patient, And in addition to that, helping the patient and the family to be aware of the disease and the disease-related issues and side effects that the patient might experience. So maybe the patient will report some side effects that they have, which was not in the previous time. So we have to be aware and educate the patient about these side effects, and of course refer them to the physician and other specialties if it is required. We as nurses, we do comprehensive physical assessment to the patient and assessment including the psychosocial and psychological, spiritual and cultural assessment for these types of patients. Lifestyle is another issue that might be raised, and nurses have an effect to it. So we try to manage the treatment plan for the patient, and we monitor the schedule of their visits to the clinic. We want them to try the best to maintain almost normal lifestyle. We don't want them to feel that they are different from other people, or this disease really stop them from doing so many activities. So we give them the option to go and choose the appropriate time that they would like to come, the date and of the visit, and the appropriate time that they would like to come for the clinic to give the transfusion for the patient. Also, we take care and we understand that there is psychological aspects for these patients. So we take it in consideration, and we understand that there will be a lot of thoughts and feelings from the patient, mainly if we are talking about teenagers and a little bit elder children, so they might feel unhappy. So we might require to let them talk to psychologists or psychiatrists, because this is a chronic disease. As we mentioned, patient might start to have a clinical manifestation like jaundice, like facial bones deformities. So this might affect them, and they might compare themselves with their peers. School is also not a big issue, but families, they might raise it if we like start to handle patients when they are very young and they want to start to go to school. So we will have a lot of questions from parents about the school performance and their academic performance. Of course, it is not a disease that can stop them from going to school. Family, the hospital, and the doctor, the nurses, they can discuss with the school the requirement for regular absenteeism from the school to come for the appointment of the clinic to transfuse blood. But generally, it is not an effect, and we reassure the parents and the children themselves that it does not affect their general performance or their academic performance. So many of the thalassemia patients, they are really clever, and they have high scores and high grades during their academic years. Being at home, so maybe families might be a bit worried about staying at home. Is there any special precaution or anything? So far, there is no special precautions for these patients, but we have to take in consideration if the patient went for splenectomy, this means that he or she is at high risk for infection. So they have to be careful with infectious things, or the things that can cause infection to the patient, such as pets. So they have to be aware about it. If no splenectomy done for the patient, they can live their normal life with no any special precaution. Vaccines, they can go also for the regular vaccines for all patients, but again, if they did splenectomy, then there might be additional vaccines given to them to help them prevent the infection. Dental care, as we mentioned earlier, that one of the side effects or clinical manifestation of beta thalassemia is the facial bones malformation or deformities. So it might lead also to maxillary osteoporosis. So it might be a concern by the family or the patient. So with regular visits to the dentist and discussion between the dentist and the hematologist for these patients, it might be sorted out. So there might be a special treatment required for them, and maybe they might require to have frequent visits to the dentists. Traveling also might be a question that raised to the nurses. If they are able to travel, they can go abroad, they can go outside the country. They can, but there is some few points that they have to take in consideration. Of course, we educate them to make sure about their insurance and the coverage of their insurance outside the country. In addition to that, we ensure or we educate them to receive the blood transfusion before they travel, and to maintain the iron chelation therapy. So if it is oral, to maintain it, to take enough stock to continue with. And if it is IV, maybe it is to be given to them before they go abroad. In addition to that, if they have done splenectomy, they might be advised to take with them antibiotics in case of infection. And we also advise them to ensure that the country or the area where they are going, there is, or they know which hospital is accessible for them, and they are aware about care of thalassemia patient in case any emergency or anything happened to them while they are abroad. Diet is also another point that to be discussed with the patient. So there is no specific diet required for the thalassemia patient. We advise them high protein, high calorie diet to help them to maintain the weight and not to have weight loss, because they do have low appetite in general. There is no evidences or researches that says that low iron diet can help to lower or to prevent the liver overload. So that's why we don't advise them, or we don't push them to take low iron diet. It might be recommended to drink a cup of black tea after the meal to reduce the iron absorption, which help us to decrease the level of iron in the body. We don't advise them at all to take any iron supplement, and they have to be careful when they take any calcium supplement, vitamin D, folic acid, vitamin C, vitamin E, and zinc. They have to be very careful. They cannot just go to the pharmacy and pick it, because these types of this supplement does not require prescription. So we don't advise them to go and just buy any supplement if they would like and just start using it, because it might affect them. So generally, the patient and family education is important. So we sit with the patient and we provide education to the patient about the thalassemia as a disease, its etiology, treatment modalities that's available, and potential complication. And we emphasize the importance of maintaining their appointments, coming to the appointment on time, taking the medication at home if required, and not to miss any. If there is any emergency, this is the only time that they can miss the appointment. They have to take another appointment as soon as possible. But they have to be compliant with their medication at home and compliant with the appointment for the clinic visits and for the blood transfusion visits. Coordination. So as I mentioned, there are so many teams are affected or are involved, with the treatment and the management of the thalassemia patients. So from time to time, there should be a coordination with this multidisciplinary team to assist the patient and plan for the patient. So we start with the hematologist who is supervising this patient. Again, at dietitian if the patient require a dietitian consultation, psychologist or psychiatrist, plus the nurse or the primary nurse or the nurses in the clinic, and a clinical coordinator or nurse coordinator who follow up with the patient and in contact with the patient and ensuring the appointment of the patient, the appointment and the medication of the patient. This is my references, and this is the end of my presentation. If you have any question, please feel free to ask.
Thank you so much, Maria, for the excellent review of the nurse's role in thalassemia. As there is no questions, we'll move to our next speaker. Our next speaker is Professor Barbara Konkel. Professor Barbara is a professor division of hematology and oncology, University of Washington, research director, Washington Center for Bleeding Disorder. Clinical work is with disorders of hemostasis and thrombosis. Her research focuses on clinical and translational research in hemostasis, thrombosis, transfusion, and sickle cell disease. Welcome, Professor Konkel.
Thank you very much. It's my pleasure to talk to you today. Let me pull up my presentation. Okay, so my topic is gene therapy revolution, the promise of a cure for hemophilia. I want to be sure my audio is good. Is that okay? Great, thank you. These are my disclosures. I have for some time participated in gene therapy trials as well as other clinical trials, and also have consulted in the area of gene therapy. So there are two basic approaches to gene therapy. One is an in vivo approach where the gene therapy is given peripherally, and the other is ex vivo, where the cells are removed and treated and then reintroduced. And so in terms of hemophilia, AAV has been for in vivo transfer, but there are some trials with lentivirus and for other therapies for ex vivo gene transfer. So the adeno-associated virus is the virus that's used for the gene therapy trial, the gene therapy medications in hemophilia that are currently have regulatory approval in parts of the world. For this, the DNA is put into the AAV, then infused into the patient, goes to the target cell, which is the liver, and then makes protein. The adeno-associated virus is not associated with illness, although many people have been exposed to it, and that is why it's a reason is chosen for gene therapy. We still have a bit to learn about what happens in the target cell in order to understand some of the variability in gene therapy, which I will show you. So for hemophilia, the codon, the DNA that's inserted. So for AAV, the parts of the virus that allow it to replicate are removed. A liver-targeted promoter, then a factor VIII and factor IX, and then the sequences required for expression of that factor VIII or factor IX are inserted. For factor VIII, it's a very large DNA, and B domain deleted factor VIII, which is also a commercial product. A version of that is used to allow it to be packaged in the AAV vector. And then we'll talk about the Padua variant of factor IX, which has increased its specific activity. We now have 1 factor VIII and 2 factor IX products that have been have regulatory approval in parts of the world, including the United States, where I am. And we have several in multiple phase trials, including different approaches, which we'll get to. So as you know, hemophilia B is due to deficiency or dysfunction of factor IX, which is synthesized in the liver in the hepatocyte. It's less common than hemophilia A, and it's a small gene compared to factor VIII, so it's a good transgene size for AAV. It was the first target for hemophilia gene therapy and followed successful gene therapy in hemophilia B dogs. And we learned from the very early trials, actually, unlike what was found in dogs, that there was could be an initial immune response, a T-cell mediated immune response, which resulted in loss of vector. And that has resulted in very carefully following transaminases with gene therapy and instituting immunosuppressive therapy if there's evidence of a transaminitis. So this is the first long-term follow-up, the UCL St. Jude study, which was presented up to 12 years follow-up last year. And the remarkable thing shown in the figure are the 3 doses, with the teal, the highest dose that was given, and the levels have been very stable over the years. And even those who have low, and particularly if you look at those who have levels of 4 to 6%, they have a marked decrease in bleeding, as shown on the right, even though they're really put into the moderate to mild hemophilia range. And importantly, there have not been any long-term adverse events. So several years ago now, there was a patient described who presented with a very high factor IX and thrombosis, and was found to have one amino acid change in their factor IX, which increased the specific activity of the factor IX markedly, and shown in the right lower panel, the wild type factor IX specific activity, and then the factor IX Padua. And so this was used in transgene constructs in dogs and worked well, and then was allowed to be put in the construct that was then under study by Unicure. So shown in the top 2 panels, the low dose cohort and the high dose cohort, and using their construct, they were getting very stable expression, and just a little bit higher than was seen in that Nathwani study I just showed you, with an average around 10%. So all they did was put in the factor IX Padua change, and with that, they increased the levels to around 40%. And so all of the factor IX constructs now include this Padua variant. So this shows results of the Hemgenix, which is marketed by CSL Behring, and the results of the phase 3 trial that led to marketing approval. So there were 54 men with hemophilia B. Now, of course, all the studies I'm going to talk about are in adults. I know this is a pediatric conference, so we'll talk about implications for that. So they were all greater than or equal to 18 years of age and had greater than 150 days of factor exposure. So they were not at risk for inhibitor development. They had a 6-month lead-in, and this is common now in clinical trials for any treatment for hemophilia, where they follow the patient during their regular treatment. So this was factor prophylaxis, so that once they receive the gene therapy, then they can compare how they're doing to how they did prior to gene therapy. And the primary endpoint was the annualized bleeding rate at 7 to 18 months post-infusion compared to the ABR during lead-in. So they wait till they're stable. So key exclusion criteria were current or history of a factor IX inhibitor or liver disease. So these are the results shown on the left are the factor IX activity. A striking thing there are two really striking things is one, that if you look at the median values, that they're around 30% or so. The one-stage assay at 24 months was 33.9%. So they're achieving not a normal level, but a therapeutic level that appears to be stable. However, you can also note that there's wide variability, and the range was actually from 4.7 to 99.2. There were 2 subjects who did not develop any factor IX activity. One had to have the infusion stopped because of a reaction, and the other had a very high titer anti-AV5 antibody. Shown in the right panel is the annualized bleeding rate, which was 4.19 in the lead-in period and was reduced to 1.51 in the post-treatment period. 42% of the subjects had some increase in their ALT, and 9 of those subjects received corticosteroids. So this is the other product, Bequez, that has some regulatory approval. It's marketed by Pfizer. It was a similar study in terms of requirement, although they excluded individuals with AV antibodies. That's generally been done. Unicure did not, the product that CSL Behring is marketing, and most of the patients had a response. So we're still figuring out why they could receive it with an antibody, and there's some reasons that may have been true for that factor IX product, but probably is not generally true. They received for the BezQuest study, they received 5 × 10⁻11 vector genomes per kilogram, a similar ABR comparative. They had more patients who received corticosteroids, although they checked the levels more frequently, and they instituted corticosteroids more promptly. So when you look at a study and you just look at what percent had corticosteroids, it's important to also look at the triggers for corticosteroids, because that may differ, and the percent who had transaminase elevation may not differ as much. So they did, though, they had also a lot of variability in the levels achieved. They had 6 participants who needed to resume prophylaxis. Their mean ABR was similar to that with CSL Behring. The ABR went from 4.4 to 1.3 after infusion. As I said, 6 individuals had to resume their factor IX treatment, and at month 24, the mean factor activity was around 25%. Now shown, I have 2 in that table 2 on the right. There are 2 different factor IX activity levels with different reagents. And this is important with factor IX therapy, because the factor IX Padua increases the specific activity. It also introduces significantly more variability in the factor IX activity levels depending on which assay you use. So that is another important factor that you have to keep in mind. And as for factor VIII gene therapy, which we'll see, the chromogenic factor activity gives a lower level, and that's also true for the CSL Behring product. So now we'll go to hemophilia A. As you know, it's due to a deficiency or dysfunction of factor VIII, which is synthesized in endothelial cells. So it's synthesized in the liver, but not in the hepatocyte, which is the target of gene therapy, which may be affecting its expression. Although we don't know, there's more of a black box for factor VIII than factor IX in terms of what's happening in the liver. It's more common than hemophilia B, and it's a much larger gene compared to factor IX. So the B domain deleted transgene lets it kind of almost fit into AAV. And studies by BioMarin, who have the regulatory approved product, have documented partial transgene into cells. So there's a lot of reconfiguring that goes on in the cells after gene therapy with AAV due to the large size of the factor VIII. And it's a large and complex glycoprotein that needs to be synthesized. So here's just an overview of the gene therapy for hemophilia. There are a number of trials in China that I am not including here. There's some data on those that have been published and available in clinicaltrials.gov. So Valoctocogene roxaparvovec has some regulatory approval. They had a large study that's been published and will show results of that. Then I'll show you some results of phase 1/2, the giroctocogene valparvovec. The phase 3 trial enrollment is complete. They enrolled 76 subjects, but those results have yet to be published. Then there is a phase 3 trial with Spark, which has not started yet. They have phase 1/2 data that showed an ABR. All of them are showing about the same reduction. They showed a somewhat lower factor IX activity with their phase 3 trial. And then there are studies interesting. There's interest now. We don't have a factor IX Padua for factor VIII. Well, there is a factor VIII Padua, but it is not useful for gene therapy, but there are a number of approaches to improve factor VIII expression. And one of those is a human porcine factor VIII hybrid called ET3, which is in phase 1/2 study with AAV, but it's also being used with lentivirus for an ex vivo approach. And so similar to a bone marrow transplantation approach. And Alex Savastika presented some initial results at the WFH with success with this approach, which may work well in some situations where there is, where individuals can come for intensive treatment and then to need to go home remotely. So this is the Roctavian valoctocogene roxaparvovec phase 3 trial. And what's notable about this is that there are individuals who, overall, there's an increased response often into the normal range, but there's been a gradual response over time. So the figure shows factor activity over time, and this is up to 206 study weeks, and that individuals had decreased. It seems to perhaps be stabilizing at these lower levels, but many individuals will end up in the moderate hemophilia range after this decrease. There is a persistent protection in terms of factor VIII use, factor VIII infusions, and treated bleeding episodes shown in the lower right, which continues to be improvement over time. So similar kind of to the first factor IX studies, there appears to be efficacy at these low levels, although of course this graph doesn't look like a cure. We would want to see sustained levels, and we're not at constant sustained levels for factor VIII yet. This is the results we have, the phase 1/2 from the Pfizer product, and the purple show the high dose cohort. That is the dose that is used in the phase 3 trial. And so that also appears they had individuals, and also in their phase 3 trial, the factor VIII levels initially went higher than shown here, but then decrease over time. There's interesting one individual who has a higher level and is not decreasing. So we look forward to seeing the phase 3 results to see the effect over time. But there are issues with gene therapy. So at this point, few patients are eligible. It's only adults. They need to have a healthy liver. They need to commit to close initial follow-up. They need to avoid alcohol intake initially, particularly initially. We don't really know for sure, but it's always good in this circumstance for them to be kind to their livers. And then many with pre-existing antibodies. And we know that the AV serotypes, the antibodies to that vary. And we have this is for AAV8 and shows the percent of people who are AAV8 positive. So they would be excluded from current gene therapy. And you'll note that in South Africa, it's almost 70%. So another issue is transaminase elevation. And this is not an issue in terms of liver failure. There are reports, a few reports of liver failure with gene therapies that use higher doses than we're using for hemophilia A or B, but we've not seen that. So usually it's a modest transaminase increase, but for some individuals, that can be associated with a decrease in factor. So that we institute immunosuppressants to try to avoid that decrease in factor primarily. And they've been used widely in the clinical trials and, as you know, have their own side effects. The approval, the regulatory guidance have really decreased the steroids you would use, but it's still an issue and we need to understand it better. So what is coming? So we can look at it in terms of gene addition and gene insertion. So when patients with hemophilia develop antibodies to factor VIII, the general approach is immune tolerance, where we give them usually daily doses of factor VIII to induce tolerance. So one could think that gene therapy might be able to do that because there would be a constant expression of factor VIII. And BioMarin has actually treated a couple patients with inhibitors, and at least in one, it looks like he is beginning to be tolerant. So we will look for more results for that. AAV does not work in children, particularly young children, because most of it is we think of it as a non-integrating virus, but actually a little bit integrates, but most of it does not. So as the liver cells divide, you lose the AAV, and that's why it can't be used in young children, can probably be used in adolescents, though we still need those studies. And then we are using, there's a lot of interest in other factor VIII variants, which should increase levels. We still have to get over with this, understand the decrease in levels and the variability that's seen, which is also when we see a patient, they want gene therapy, we can't really tell them what level they'll end up with. They'll probably end up with mild hemophilia, but they could end up with no response, and that is a challenge. So there's lots of interest in different approaches. One is there are two different companies, one doing a factor VIII, one doing a factor IX transgene, that they're inserting into the albumin gene as really kind of a safe harbor for expression. And that then could be used in children. They are currently, one of them is using an AAV, so that would be excluded with AAV antibodies, but there are other approaches to accomplish this. There's a co-encapsulated factor VIII piggyback transposase, which is being studied, which gets away from AAV. There's an interesting approach where they're taking, and this study hasn't started yet, doing a pheresis for mononuclear cells, identifying pre-plasma cells, inserting factor IX, maturing the cells into plasma cells, and then reinfusing them in the patient, which could be a constant product factor IX production by the plasma cell. And then there are companies looking at in vivo correction of premature stop codons and missense variants. These approaches to date would not fix factor VIII inversions, which are the most common cause of severe hemophilia A, but it's challenging. Another nice thing about this approach is that other rare factor deficiencies that are due to these variants could also be treated, and we really don't have treatment, gene therapy treatment for those, and it's unlikely that they would have a unique gene therapy produced for them, but if it can be an overall approach that's also applicable, that is very interesting. So do we have a cure? Well, for hemophilia B, for most individuals, they could have a stable level in the mild hemophilia range. I think the biggest issue there is still the need for steroids in some and the variability in response. For hemophilia A, we have the same issues, but we also have a decreasing level that may stabilize but still have a hemostatic effect. And having individuals who've had poor responses to early gene therapy, it is a disappointment. But I've also had patients who've had very positive responses to gene therapy, and that has really changed their lives. The nice thing, importantly, in hemophilia gene therapy is that no one has developed an antibody to factor VIII or factor IX. So when individuals lose a response to gene therapy or don't have a response to gene therapy, they can resume their prior treatment. So how do we understand this in terms of safety? So one of the big things, gene therapy is a new therapy, and we want to be sure that it's safe. We clearly want to follow and see if it's efficacious, but safety is an issue. And because it's rare, and there'll be only a few participants initially, we want to be sure that we can collect data on those individuals. So the World Federation of Hemophilia has established a global registry to collect data worldwide on patients who undergo gene therapy. And as a disclosure, I am a co-chair for this project. And the primary objective is to determine the long-term safety of these therapies, and then as secondary objectives, efficacy and durability, and impact on quality of life. So we have a global implementation. The blue is where we will link through national registries, and the green is where we will link through HCCs directly. And the latter is particularly true in countries such as Ireland, where they really have one HCC, or Brazil, where all the therapy is given through one HCC, or South Africa. And these countries that are participating will, we hope, continue to grow as gene therapy is given in more countries. So how do we choose gene therapy or other therapies? We have available around the world are excellent non-gene therapy options. We have efficacious factor VIII and factor IX replacement therapy. We have emicizumab, the bispecific antibody. Under study, we have rebalancing agents. One is approved or one is approved in a couple of countries for patients with hemophilia B and inhibitors. And as with gene therapy, they all have low annual bleeding rates, and they continue to improve. So one important thing, obviously, is local availability. The downside of all these therapies is that they are expensive and that they are not available everywhere. So they need to be available, obviously, and they need to meet the needs of the patient and family. The World Federation has developed a shared decision model. This is available at sdm.wfh.org. So it's very easy to find, or just going to the WFH site. And it helps patients and families go through what's available. It notes that not all treatments are available in all countries, and it helps them kind of reflect on what's important for their life and what is important treatment options. This can be done on their own or with a provider. If done on their own, it can then come back to the healthcare provider, and they can discuss it to understand it. Also, it's a great educational tool for providers or individuals in the healthcare team who may not know as much about different treatment options. So which therapy for which setting? As I said, I think the choice is dependent on availability around the world. Is the product available? Does it require laboratory support and specialty support? Laboratory, as many of you know, in hemostasis is a real challenge. And with some of these products, it becomes more challenging because of the variability. But if we had a product that we could give to a patient, and then they wouldn't need infusion again, and we wouldn't need to measure it before they had major surgery, that would be my definition of a cure, and we're not quite there yet. The benefit-risk considerations will vary by resources and country, but what is most important is we want safe and optimal treatment for all patients. So thank you, and I'd be happy to answer any questions.
Thank you so much, Professor Konkel, for the excellent and very impressive presentation. I don't see any questions for you. Yep. Sorry, there is one question. How we apply gene therapy for hemophilia A in surgical practice, and what is the ideal time for the therapy?
So in terms of surgery, it's interesting. I was preparing for a talk some time ago. I mean, now we want gene therapy to last forever, and we want a cure. When they first talked about gene therapy, they talked about if it lasted just a few weeks, you could use it for surgery. And that's not our approach. But I think if there are individuals, what's happening with the gene therapy is that we have a number of individuals who have mild hemophilia. They used to have severe hemophilia. We also know with factor VIII that it decreases over time. So if someone is going to have surgery who's had gene therapy, we still have to check their factor levels to be sure that they have adequate factor, and then treat them before and during the surgery according to that factor level that we would treat. There's nothing to indicate that the factor level they achieve with gene therapy is not the factor level that we would respond as we would see in someone with mild hemophilia, if that's the level so we would treat them on their new level for their surgery.
Thank you. Professor Konkel, another question for you. Are there trials for immune editing to overcome vector rejection using gene therapy combined with gene therapy for hemophilia? I mean, this is the question.
I'm sorry, what was the question?
Question was, and I didn't understand this fully, but anyway, it says, Are there trials for immune editing to overcome vector rejection using gene therapy combined with, I'm not sure what gene
Yeah,
therapy?
that's a good, I think, can we kind of rescue them? I think the question is, to overcome when they're losing the vector. Now, so to understand why the vector is decreasing, BioMarin has done a number of studies. And one of the things they found and published is that there's still DNA in the cell. It's just not being expressed. So and why that is not clear. But if we understood that and we could help them express it again. So there's a lot of interest in that. There is a trial that was published that was sponsored by Baxter, and I had a few patients in the trial where all except one patient lost expression. It was very disappointing. And what they found that was probably due to the transgene, how it was changed. And the one person who did not lose expression and still has expression in the mild hemophilia range had a mutation in the IL-6 receptor. And so the transgene probably induced an increased immune response, and he may not have had that immune response and thus was able to continue expression. So that shows that that was a factor IX gene therapy. So there may be, whether we can use that information to devise a therapy, I don't know, but it's an interesting observation.
Okay, another question for you, Professor Konkel, is what is the maximum duration of effectiveness achieved so far with gene therapy for hemophilia A? And can the treatment be repeated with the same or different product?
So we're now out for over 4 years with the AAV5 B domain deleted, the BioMarin, and the patients have continued to have expression, although it's decreased. Some have had to go back to their therapy before. Unfortunately, with that product, when someone receives an AAV product, they get high titer AAV antibodies. So we can't give them an AAV factor again. So they would need to get a non-AAV gene therapy. The good thing is that there are some under development. And so I think when I talk to patients, they tell them that it's likely there will be other therapies available to them in the future. So that can it be passed on to future generations? So the products we have now are not passed on to future generations. They do not get in the germline. So an important for that is that if we have a man with hemophilia or a child, when we get to that, their daughters will still be carriers of hemophilia, and that's a very important genetic counseling piece.
Thank you so much, Professor Konkel, for excellent and very impressive presentation. And thank you so much for joining us.
My pleasure. Have a good rest of your conference.
Thank you. And we now move to the next speaker, Professor Baba Iniswa. He's a specialist in sickle cell and thalassemia and director of the Comprehensive Sickle Cell and Thalassemia Center, Evelina Children's Hospital, Guy's and St. Thomas NHS Trust, London, the leading centers in the United Kingdom. Professor Iniswa, he was consultant in charge of pediatric oncology, Queen Elizabeth Hospital, Wewen Garden, County, from 1997 to 2002, prior to his current role. Evelina London is the is one of the leading hemoglobinopathy service in the UK, with responsibility for training in stroke screening and sickle cell disease transcranial Doppler, and as the National Secretary for the UK Forum of the Hemoglobin Disorders. Professor Eniswa, please.
Thank you. Good afternoon. We just entered an afternoon here. So I will just try and go to my slides. Can you see my slides? No. Najat, can you see my slides?
No, I don't see them, no.
Okay, so I'm trying to share my slides. Although you have them anyway, so you can share them if you want. I've sent them to you. So we can share this. So okay, let me just try once more, because I tried to go in and I said, okay, I think I should be able to go to the window, and I think I should be able to share, and I think it is coming up now, and I think you can see my slide. Is that okay?
Yes, Professor.
Okay, great. So thank you for the introduction. Thank you, Najat, for inviting me to give a talk. I have deliberately left out the discussion about a lot of detailed new therapies, because I see there's another speaker who is going to talk about emerging therapies. Is that okay?
Yes, you're okay.
Okay. All right. So these are some of my disclosures. This might change very soon. But I'm going to talk about in terms of the progress. Obviously, no need for definitions. I know that has been done over and over, but I'll talk about the burden of disease, but just more emphasis on hydroxyurea transfusion. But again, that's not my major talk, because I know some other people are talking about it. I just want to kind of talk about what is happening and what is next. You are very familiar with the burden of disease, the fact that the majority of patients live in sub-Saharan Africa, India, and that the outcome of patients is actually very different. And basically, you have sickle cell disease, where you live is actually determines the outcome that we get for you, and therefore is something that requires a concerted effort. And the WHO also have clearly defined sickle cell disease as a significant disease, a significant burden. And again, we know the map, we're very familiar with the map, but actually this map is becoming more and more clear that actually some of the countries that we thought maybe will have low disease burden actually have high disease burden. And I know a lot of work has been going on in Saudi to try and understand their numbers. And Bahrain, you've been really in the forefront of really trying to understand sickle cell disease. And because I've listened to Najat presented in the past, the work you've been doing, particularly leading to screening and also leading to the difference in prevalence, but also in terms of the disease phenotype. I'm very, very happy that really listening to the discussion today, I've had people talking about the nursing aspect of management. And without nursing management, I think it's very difficult to provide a holistic care for sickle cell disease. So thank you really for taking account of that. But we also know that apart from indigenous populations, there are a lot of migrations, and therefore disease is actually changing. So a landscape is changing, particularly in Europe. In Europe, there are countries that were completely unfamiliar with sickle cell disease. Now they have a large burden of sickle cell disease, not really compared to the major two, which is the US, which is the UK and France. France probably may have slightly more patients than the UK, but the UK will have about 15 to 17,000 patients living with sickle cell disease. And our birth rate is about 250 to 300 live births per year. And I think a similar number or slightly higher in France. But actually, you know that if you compare this with Africa, particularly in terms of Nigeria, where we have about 150,000 babies born with sickle cell disease per year. And the next one being DRC Congo, and also India being the next most common in terms of countries. But in countries in Africa, there are quite a number of areas that have really paid a lot of attention about trying to understand sickle. So that's what I'm going to talk a bit about the impact and trying to understand the input in terms of management. So this data are just kind of showing the lifespan for sickle cell disease, showing a gradual improvement. But actually, some of this improvement has not really continued quite progressively in the way that it did. Whereas a number of years, probably 1980s, early 80s, there was a report from Nigeria that showed that 5% actually, only 5% survive about the age of 5, but actually that is different now. But there's still patients are still dying with sickle cell disease, die actually at a very young age. And the recent data looking at the DHI's data in Nigeria showed that the death is still very high, particularly in the under 10-year-olds. So the survival of patients with sickle cell disease, we know that it's about 43 in the US. Jamaica had reported slightly about 58, and some papers from the UK have given about 65 years of survival of a kind of a lifespan. But survival into adulthood is actually very high in the US and the UK because of improvement in care. And so this was just basically looking at the 3 countries that I have mentioned, India, Nigeria, and DRC Congo, and the fact that the pattern will continue to increase, except something is done quite drastically to try and address the disease burden in terms of screening, in terms of prevention, but also we know probably because of improvement in treatment, there's going to be increase in numbers as well. But what we need to deal with is to deal with early prompt diagnosis and how to manage those patients with sickle cell disease. So I would actually be happy to discuss some of this as a discussion forum, and so that I can try and address some of your questions about the landscape of sickle cell disease.
Prof. Papa, sorry for interruption. We cannot see your slide moving.
Oh, okay. I will start again. Oh, thank you for really raising that. I will retry, or maybe.
If you want, we can share from our side, and give the control to you. You can move from your side.
Okay, please. Okay. All right, please share, and then I can move them. So, did you see only the first slide then?
Yes.
That is bad. Okay, please. Thank you. Can you put it on the share on the slideshow?
The control with you now.
Thank you very much. So, okay, all right. So that was my. So thank you. That was my disclosure, and this was the format I wanted to. I'm going with the discussion, and I'll discuss about the disease burden in terms of global perspective. And so this was talking about burden of disease, and particularly in Europe, there is increasing numbers of people living with sickle cell disease. Okay, let me just see what happened. Did you touch my slides? Okay, all right. Okay. So let me just. Okay, excellent. Okay, I said majority in the low resource countries, Africa, India, and also this just kind of showing the map and the survival being about 42 in the US for male with SS and 48 with female with SS. Non-numbers really hasn't increased much. In the UK, it's about 65 from a single center report. In Jamaica, it's about 55. And so we think that probably there's an improvement in terms of the outcome. And we're saying that if you projected the numbers from now going to 2050, then there's going to be an increase in the birth rates, sickle cell anemia birth rates, and then there's going to be an increase in the general population as well, because the patient with sickle cell disease probably are living longer, and therefore will have more need in terms of what happens as they survive. Then they have some end organ damage, they have other complications that become very, very vital. But so if you think about the landscape of sickle cell disease, there is an increased movement into high-income countries, particularly in Europe, where due to migration, we have more sickle cell patients than actually now in Germany. And now Germany are now developing a pattern of management. They now have developed newborn screening as a result of the movement of patients into Europe. A number of European countries are actively working on trying to understand the pattern of sickle cell disease presentation and when to make a diagnosis. And some of the challenges actually is when patients arrive in those countries, at what point should they be screened? And that is a kind of a discussion that's actually going on in Europe to make sure that patients that actually arrive are actually properly diagnosed and treatment is started appropriately. What is being done in terms of Africa to try and address the disease burden in Africa? This is coming from different angles, but there is a significant input from global bodies, particularly American Society of Hematology have developed this initiative, which is Consortium on Newborn Screening in Africa, and with a commitment to work with 7 African countries, as you can see them on the map, to provide standard care from diagnosis to treatment to the first 5 years of life. And this program actually has its initial teething problems, but actually is beginning to establish, and there are quite a number of babies that have been screened that are now receiving treatment in the countries that are actually involved. You might notice that the countries here are Anglophone speaking countries, but there's a kind of intention to actually involve French Africa to also, and I know India also are asking why not us as well. So this is the Consortium on Newborn Screening run by America, and these are some of the key things: to detect within 6 weeks and to provide life-saving treatments, penicillin, anti-malaria prophylaxis, immunization, and also to provide a regular follow-up of these patients. And because education is very key and is very important, there is a whole section trying to work on what information is available. And this information is not going to be only restricted to the consortium's members, but actually will be easily available and also probably translated into the various languages. And most of this data, most of this work actually has really advanced, and actually they now have some material now that they're able to share. And I know this is going to be something that we'll continue to present to make sure that people know what is happening. So this was actually quite an old slide. By the time they had screened about 42,000 babies, but actually the number is increasing very high. And the incidence of sickle cell disease remains about 1.1 to about 2% across the different countries that are involved. And the majority of patients in the rest of Africa is SS, except in Ghana, where there's a high proportion of hemoglobin SC disease. And you may be aware that SC disease is predominantly a West African disease, although quite a few pockets coming from other places. So, and they're working to make sure that they can work with stakeholders to ensure a sustainable program in terms of access to medication and also in terms of adherence to therapy and monitoring of patients. But I think you can never overemphasize the involvement of institutions and policymakers. And I think I know that this is kind of thing that actually happens in the GCC countries, and I know that Saudi has done a lot, and Bahrain actually done a lot, and have a lot of engagement from the government and a good directed effort. So I think that's something that needs to really happen. And we have also been leading an African research and innovative initiative for sickle cell education, which is aimed at actually empowering stakeholders, particularly professionals, to really be able to be competent in terms of the diagnosis and especially the improvement in laboratory diagnosis, and to make sure that laboratory scientists and the laboratories are actually prepared to provide a diagnosis, and they are supported through as research staff exchanges from Africa into Europe and vice versa as well. And apart from the staff exchange, we also have an online virtual training program that allow us to discuss, interact on patient results, and looking at the plots that are actually going to be advised by laboratory scientists who are expert on the panel, but also we involve discussion with regards to diagnosis of a newborn screening, what happened to the babies, and actually provide transcranial Doppler scanning training in implementation science, so that these patients, when they are diagnosed, they actually have the appropriate therapies. We also work with Cyprus and also other centers to work on genetics as well as epidemiology. And the genetic research is actually quite something that has really led to some bigger initiative, such as a multinational Inherent, which is a consortium that works with different centers to actually develop a higher proportion, a kind of a high throughput of biorepository, and we aim to have about 30,000 really kind of DNA samples that are going to be looked at together to be able to make some kind of investigation to find out some causative, some kind of genetic determinants of sickle cell severity, determinants of survival, and as we come together, I think that will be very helpful. And I know that I think maybe 1 or 2 GCC countries are already there, but we are really hoping that more participation comes from all over the countries. And then one of the other work packages for our project is actually to support people in terms of research and epidemiology and statistic training. Again, we've done some virtual training, which are actually located on the website. So these are the countries that are involved in the start exchanges. One institution in the US, and then Lebanon, and also African institutions. So just to talk about the standard therapy, again, I know somebody will be talking about it, but I thought maybe it would be good to re-emphasize the importance of standard therapy, how we actually can improve our care and the use of standard medications like hydroxyurea, and also continue to use blood transfusion remains a very mainstay of therapy. And again, we know exactly the new developments that are coming through, but in terms of hydroxyurea, and this has been shown in Africa to be safe, but also probably being something that might reduce the severity of malaria. Again, that question remains to be fully answered, but it's something that is promising. And one of the benefits of hydroxyurea is the affordability of the drug, but that is not a universal position, because people still have lots of challenges in getting access to hydroxyurea and getting the monitoring that is actually required for hydroxyurea. Blood transfusion remains a very mainstay of therapy, but in Africa, really the availability of blood is actually a major challenge, and actually availability of properly safe blood that actually is properly tested and ready for transfusion is something that remains an issue. And we know that one of the main benefit about hydroxyurea, we know that the fetal hemoglobin production is a mainstay, but actually beyond that, there are other factors that might be benefiting from hydroxyurea therapy. So I think it's something that we have found very, very liberating in terms of the use of hydroxyurea. And one of the things for pediatrics is that the response to hydroxyurea is actually very, very good. It might be a reason for adherence, or it might be because of the fact that the marrow is very ready and still available and still able to respond, but actually the response to hydroxyurea remains good. But actually, where you do not have this appropriate response, then we can think about other alternative agents. But obviously, hydroxyurea on its own is not a panacea, but it's something that does kind of lead to a significant improvement. And then we have a number of attempts to actually do. So obviously, this is just to kind of highlight the way hydroxyurea came into being, and the MSH trial, which was the mainstay that actually showed a kind of a twice effect of hydroxyurea in terms of increasing the time from starting hydroxyurea to having another episode of pain. And whereas in the placebo, you would have a reduced interval of 1.5 months, and hydroxyurea, that interval will increase so that you have a more period of free of pain and actually free of symptoms, and also having a longer period to have the next episodes of pain. So somehow this has improved, but we still want to make sure that we can abolish or probably reduce this to the minimum, reduce pain to the minimum, and that is really what we know. But blood transfusion again remains a very mainstay therapy, and the use of blood transfusion in CNS complications remains a very, very important component. Although we now know that we can also use hydroxyurea as a primary prevention for those who have a high transcranial Doppler scan velocity if you have assessed them. But blood transfusion remains very useful, and actually, and it's something like, yes, you can continue up to adult age. And then pulmonary damage, pulmonary complications. Again, blood transfusion is something that really can reduce some of these consequences, as well as cardiac anomalies in sickle cell disease patients. So if you actually just review blood transfusion, it's something that you should think about using that in a way that is judicious, in a way that is actually very positive. Actually, you are fully aware of the complications, but the benefits are actually quite substantial. But obviously, it leads to the iron overload and obviously the alloimmunizations that might happen. So you need to really be very careful to proceed with that. We do have our challenges sometimes when you have some of the patients become non-transfusible, in the sense that they react or they have hyperhemolysis and also developing a delayed transfusion reaction. So these are a number of complications that we need to bear in mind. But also we are fully aware of the benefit of transfusion in stroke prevention, which is definitely a standard process. So I think something can only be can only be emphasized. Again, new therapies, I know somebody's going to talk about this, but I just kind of have an oversight, a high level discussion that we know about the progress in the hemoglobin F induction and the hemoglobin F induction through hydroxyurea, basically, but actually the hemoglobin induction through genetic gene therapy as well. And I think some countries, 2 or 3 countries in GCC, have actually approved the Vertex gene editing, and also we are also at the cusp of actually probably approving that in the UK for thalassemia and for sickle cell disease. But we're waiting for the final comment based on the NICE evaluation. NICE has to approve the medication for us to be able to access that. So hemoglobin F would be something that really we need to think about. And then the cell adhesions, again, I might just mention about the crizanlizumab, but you know about some of the other selectin inhibitors that actually have been really a point of focus, and the challenge that has happened with the crizanlizumab. And then the cyclin, particularly talking about voxelotor, again, which has FDA approval, and we know the challenge about patient-related outcomes, which is something that is yet to be proven, even though the laboratory improvement are absolutely outstanding and quite very, very clear. Oxidative stress, I'm talking about glutamine, which has been approved, and I know some countries are using it. I know Dubai are using it as well. So I think the progress continues. Obviously, you know the promise about crizanlizumab. Unfortunately, this was not proven in the definitive trial. Unfortunately, some countries, Europe and the UK, have withdrawn it. But some of our patients actually wanted to continue on it, and I know the US are still using it, and also some of the countries. I'm not sure whether you're using it in Bahrain or not, but I think the fact that it is safe to use, and the fact that some patients report significant improvement in their symptoms and they want to continue the medication, I think is something that probably needs further evaluation and also further observation, so that we can see if there's some kind of a different response. But we still have some of the trials in pediatric patients anyway. So the STAN trial was in adults, so we're waiting for some of the pediatric trial to actually end. And this was just what I mentioned in terms of the voxelotor therapy and the current trial that are going on looking at the effect in terms of TCD. I know the trial has been suspended, but we're waiting for more information to see exactly what is the outcome. But we have just got in the UK an approval for us to use voxelotor. So we're now trying to select the patient that actually can benefit from voxelotor treatment. There are patients that are going to be non-transfusible, but also there are patients that have severe anemia, and maybe think about using it as a rescue therapy. And the hope is that this will have an effect on organs, will improve fatigue, and also should improve pain. Again, and if it reduces this, probably should improve mortality. But we're yet to see these features. But it's something that we will continue to observe, especially as we are starting treatment. And in the UK, we're starting that treatment within the NHS, and that allows us to monitor what happens to the patients, and also we can really come together and be able to evaluate and see what is happening. So monitoring, evaluation was something that is going to be very important. And again, so just by way of looking at the mechanism, and then really a number of that nitric oxide is very important, vasodilator, very important in reducing and improving the blood flow. So somehow, various areas actually could be a target for development and to improve the oxygen and reducing vaso-occlusion is something that will remain important, because the bioavailability of nitric oxide is important for some of the key end organ damage, priapism, leg ulceration, pulmonary hypertension, and non-hemorrhagic stroke. And then the pyruvate kinase activators, again, I'm sure you're going to hear more information about that. But this reduces polymerization by decreasing 2,3-DPG, and by stabilizing it by also increasing stabilizing ATP increase, and this reduces hemolysis, improves anemia. And so the primary endpoint is an increase in hemoglobin, but a number of information have been reported as showing improvement in patient-related outcomes in some of them. So we'll wait to hear exactly what happens. So mitapivat and etavopivat are the two drugs in clinical trials now, and I'm sure some of this result will be coming out very soon. So we just kind of watch the space. I think there's a lot of excitement that this might be something that actually will have another very important outcome in sickle cell disease patients. So I think one of the things I want to say about, again, I expect there's going to be somebody talking specifically about bone marrow transplantation. But I think, I don't know whether some of you attended the ASH conference in 2023, whereby there was a kind of a very, very positive response of haplo match transplantation. And the fact that it's actually a lot cheaper than the gene therapy that we know are actually coming on board, and also the two gene therapies that were approved on the 8th of December, but the Vertex and the Bluebird gene therapy that were actually approved, again, are very expensive. But I know I had the person speaking about hemophilia. We still remain about clinical cure, actual cure, but obviously, if you have the symptoms reduce or probably almost disappear as a result of increasing fetal hemoglobin, the question is how long would that last? But actually, I've discussed it a lot with the sponsors, and they're assuring us that, because the editing has already taken place, that should be there. But the question is that if you have fetal hemoglobin alone, why is it that nature allows to have fetal hemoglobin to soar back to adult if actually it was the right thing to do? But again, watching these patients for a period of time will be something that will help us to understand the benefit. So the others are the less gene editing seems to be more advanced than most of the other mechanisms of gene therapy. But again, there are a lot of work going on in different centers and different laboratories, but also pharma industry are also involved in looking at how to make this progress. I wanted to talk about a UK particular example about how we responded to some adversity. And I think it's a lesson that I think other people should think about. So if you think about sickle cell treatment, and you think about the sickle cell population, and then you think about the fact that a number of these patients may be disadvantaged, maybe less so for you, but for us, it's something very starkly, very clear. And that's what happened to the report, which if you check it online, no one is listing the report. In the UK was a scenario whereby a young man over 20 who had pain was admitted in the hospital and was calling for attention. They didn't come. He had to call the ambulance through a 999, which is our own emergency call. And unfortunately, he died. But because he died, there was a significant work to look at why he died, why his care wasn't good enough. But out of that has come significant changes. And some of these significant changes actually have a very significant impact on the services for patients with sickle cell disease. And I think it will also benefit patients with thalassemia because we manage the two conditions particularly within the same consortium, and the same networks are involved in this management. So I think that the lessons we learn and what we've done will be a good lesson for other people to think about. So we've established a national MDT, a national MDT. Some people might have come to the UK. So we have a national MDT that has a monthly meeting, a presentation of severe complex patients to discuss those complex patients and say, what are the issues that these patients are presenting with and how can we address their management? So, and here it's just a summary about the cases that we've gone through in 2020 to 2021, 2021, 2022, 2022, and 2023. So we discuss an average about 4 to 5 patients during the meeting, and we have all the experts across the country. And sometimes actually we invite experts coming from elsewhere to contribute to the discussion, to the outcomes, and so this is a kind of a summary about some of the main presentation and the conditions which the patients are presented with. There are CNS events, there are transfusion problems, and also there are patients that are being discussed because there's a decision with regards to the decision for bone marrow transplantation or gene therapy. Out of this has come what we now have a panel that actually will look at cases that are being referred for gene therapy. They will discuss them from an expert point of view, and then they'll present the outcomes to the national panel. The national panel is NHP. And so I was chairing the NHP for the first 4 years until March, because I'm changing kind of my role as well. So, but the NHP allow us to bring experts, discuss cardiac expert, renal expert, and other people to make to give us opinion, and really that helps in the decision. And also, as a result of this work, this report, there was a whole commissioning of a national response. What do we do with sickle cell disease? Thinking about it from birth to treatment, to primary care, to the community. And so, for example, like making sure that GPs are advanced and very clear and able to provide the advice during screening, but also making sure that when parents and pregnant mothers are actually to be seen very early on, and then they'll have antenatal screening, and then they have the option of prenatal diagnosis, and so they will get some better understanding about what is their decision, what is their choice. This is non-directive counseling, but also some patients, because of the fact that I've had another child with sickle cell disease, they don't want to stand the chance of having a child with sickle cell disease, so they'll go for the PGT, which is actually something that's available again on the National Health Service, and it's free, particularly for the first two attempts to make sure that that family are able to have a patient that do not have sickle cell disease through the pre-implantation genetic testing. And we know that we have in our own system, we have the primary care, secondary, tertiary care. So we want to make sure that the primary care are very much involved in the management of their patients, and make sure that patients receive education. And therefore, there is a strengthening of the community management to make sure that they provide treatments that patients can use at their homes, including oxygen monitors, because this is actually requested for by patients. They feel that that is something that they want, but also give them opportunity to discuss the patients, to interact with the patients, either by virtual ways or probably by visiting the home as well. And then here, because acting in an emergency sometimes is a kind of a major challenge for patients, they can wait there for too long. Because of that, we now have an emergency bypass. So bypass the A&E, and they can go to a special emergency care so that they're actually seen and managed. And we also make sure that we have really various ways of offering and delivering blood transfusion. Make sure that all centers have the capacity to deliver this. I'm talking about the UK. And so digital universal care plan, so that if a patient comes from the north and gets to the south, then you don't have to really go through lots of trying to find out who is this patient. You can just use the universal care plan, which is digital, and then you can understand what is the issue in order to actually address their management. So this is something that we've done in the UK to respond to a challenge and also to kind of address some of the issues. So I thought maybe it's good to just kind of share the experience in the UK so that you can see some of the things that we've done. So in summary, I just try to kind of say, okay, we need to recognize in terms of the disease burden, yes, we know predominantly Africa and India, but actually the disease is now moving. It's been moving for a while, but actually it's now a reality in a lot of European countries and the US. But actually, the other countries that I know have high numbers and actually very good management are Cuba. We don't seem to have them together in our discussion, but I think they have a very good program. I can only suggest and support and say that the development of a regional or a national or a local network of care is very important to assess, to provide the expertise that people can access, which is not based in their own center, but also to have opportunity to discuss complex patients and arrive at some kind of agreed treatment. And you can use various methods to actually agree that. It could be using a Delphi, or probably to use just what the expert think, but also using evidence based as well. And we can continue to optimize hydroxyurea therapy. I know in pediatrics is much better because I'm a pediatrician, but I know pediatrics is much better in the sense that we are very happy to provide adequate dosing and make sure we can achieve maximum tolerated dose for hydroxyurea. But transfusion is something that also we really cannot ignore its importance. Gene therapy, again, is something that is now really coming and now been approved in a number of centers, but actually the selection of patient remains an issue. How do we select who goes for gene therapy? Apart from the cost, but also in terms of the appropriate nature of the patient. But also we need to make sure that we can get the patient to participate with us in those decision making. And new therapies in development, and again, and one of the things that is changing is the fact that the drug development now takes into account what the patients think, what the professional can contribute, and it's not just going to the lab or to the laboratory and trying to find out what works in sickle cell, but actually to see what is it that is your priority. So thank you for the opportunity to talk, and sorry for the slide miss out with the slide. So thank you, and I will welcome questions and comments so that I can try and address it as you wish. Thank you, Najat.
Thank you so much, Professor Eniswa, for the excellent presentation and very impressive review of the landscape of sickle cell disease. I don't see any questions for you. So thank you so much.
Thank you very much.
We move now to the next speaker, Dr. Sital Jacob. Dr. Jacob is an assistant professor of pediatrics at the Indiana University Raleigh Hospital for Children. She joined as part of the Pediatric and Adolescent Comparative Effectiveness Research Group. She is the director of the Comprehensive Pediatric Sickle Cell Program at Raleigh. Her research focuses on developing and evaluating interventions such as telehealth to improve access to and quality of care for children living with sickle cell disease. Welcome, Dr. Jacob.
Thank you, everyone. Thank you for having me. I'm going to see if I can share my slides appropriately. There we go. Okay. Well, it's a pleasure to be here with you all today. Thank you for having me. And I'm hoping I'll be able to touch briefly, I know we have a short amount of time, on the neurologic complications in sickle cell disease and what we already know, and some new data related to treatment impact on some of these complications. I do not have any relevant disclosures. I do receive funding from the National Institute of Health in the US, but today's talk does not relate to that work. So the majority of us are, I know, familiar with this image from the article by Dr. Frederick Peel regarding the global incidence and prevalence of sickle cell disease, knowing that a child with disease is born every 2 minutes in the world, approximately 300,000 new births across the world each year. And we know that 90% of those new births actually occur in Africa, the Middle East, and India. And based on estimations done by Dr. Peel and his colleagues, this number is expected to increase by nearly 30% by 2050, which really demonstrates the global health burden of sickle cell disease and the need for continued advancements in clinical care and research in this space. And we know that the complications of the disease are vast and include things like sickle hepatopathy, pulmonary hypertension, kidney disease, and of course, stroke. And we've made a significant impact on survival in childhood when we are able to implement the preventative screenings and treatments that have demonstrated to be effective in clinical trials. However, neurologic complications of sickle cell disease are an area we gained rapid knowledge in through various stroke trials several decades ago, but continue to have a significant gap in our understanding of the entire landscape of problems that can occur. And this image by Stokesbury and colleagues, I really like because it depicts the multitude of neurologic complications that we can see in sickle cell disease, some of which we are more familiar with, such as ischemic stroke or silent cerebral infarcts, but also includes lesser known sequelae such as aneurysm development or cerebral volume loss and cortical thinning, and many others. So today I'm going to be focusing on 4 categories of neurologic complications, as you see here, because we do have a limited amount of time. And these tend to be the most common complications that we come across. And I'll review a little bit about what we know, what the guidelines recommend, and a little bit of new data that's been presented in the last few years. So we believe the underlying mechanism of CNS injury in sickle cell disease is really cerebral oxygen demand exceeding its supply, which we presume is multifactorial due to poor autoregulation of the vasculature in the brain, the contribution of vascular lesions such as stenosis caused by chronic endothelial damage, and other medical events like acute chest syndrome or aplastic crisis, limiting oxygen delivery to the brain. And this is an image that sort of depicts the various stroke syndromes that we can see in sickle cell disease, such as ischemic stroke, posterior reversible encephalopathy syndrome, hemorrhagic stroke, as well as other forms of infarction or thrombosis. This is another image from the same article by Stotesbury and colleagues, where we're really seeing the complexity of the pathophysiology that contributes to the development of the myriad of complications, neurologic complications in sickle cell disease. And you can see how vaso-occlusive factors such as sickling due to polymerization, hypercoagulability, endothelial adhesion and dysfunction really complements the hemodynamic factors that are in play when we see neurologic complications, such as decreased nitric oxide as a result of hemolysis, vasodilation that leads to changes in cerebral blood flow, and a decrease in oxygen extraction, resulting in vascular instability and the neurologic consequences we're most familiar with, such as stroke and silent infarcts. We know that stroke is the most common permanent sequelae of sickle cell disease. And we can see in this chart from an article by Dr. Frempong that the incidence is significant in those with SS disease as they age into adulthood. Now, this is also dependent on survival into an older adulthood, but you can see that neurologic morbidity is significant for those that do, not just with SS disease, but also with SC disease. We also know that infarctive stroke is more common in early childhood, with what seems to be a reprieve in early adulthood, but actually is replaced by an increased incidence in hemorrhagic stroke. Now we have evidence that suggests some of this increase in hemorrhagic stroke is actually due to the development of aneurysms from recurrent endothelial damage that subsequently rupture. And as I mentioned, there were several trials in the 90s and early 2000s that showed us that transcranial Dopplers are effective in identifying stroke risk, that chronic transfusions are effective at primary and secondary stroke prevention, as well as secondary prevention of silent infarcts, and that patients can be safely transitioned from chronic transfusions to hydroxyurea for primary stroke prevention, as demonstrated by the Twitch study. These are well-accepted management strategies for stroke prevention in sickle cell disease, as Dr. Inasu mentioned in his talk, with actually little new data on alternate primary or secondary prevention strategies since this time, though there are multiple drugs in the pipeline or in clinical trials that are hoping stroke prevention can be a secondary indication for their new drug. One drug that we know does work for the primary prevention of stroke, as I mentioned, is hydroxyurea. This table here on the left comes from Dr. Ware's publication of the Twitch trial in Lancet back in 2016. And you can see that children who were switched from chronic transfusions to hydroxyurea after a year of transfusions maintained normal transcranial Doppler velocities, and that over time they continued to maintain normalcy in those values. This graph here on the right comes from a study in Tanzania that was published actually this year that shows that children who were placed on hydroxyurea after having abnormal TCDs actually were able to decrease their TCD velocity, and the majority reverted to normal TCD flows. So a very important study where transfusions may be limited and hydroxyurea access can be improved. So we know that TCD screening, when implemented, can reduce the incidence of stroke in children from 10% to less than 3% with treatment, which is why multiple governing bodies recommend annual TCD screening for children with sickle cell anemia between the ages of 2 and 16 years of age. It's also why children with abnormal TCD velocities should initiate a chronic transfusion regimen in research available settings, or as we saw, hydroxyurea, with specifications if they are on a chronic transfusion regimen of what hemoglobin S levels should be and what hemoglobin should be as part of their chronic transfusion regimen. However, the display study, which was recently conducted and led by Dr. Julie Cantor here in the US, showed that despite very strong recommendations for the use of TCDs as a preventative measure in sickle cell disease, they were not being completed as recommended. In fact, only 30 to 50% of children were receiving annual TCDs at over 27 centers of various sizes in the US that were included in the study. And the image on the right depicts the many barriers to appropriate implementation of TCDs that they discovered as part of this study, including significant variability in the training, the reporting, and the quality of TCDs that were being done. As part of the study, they were able to show, however, that significant improvement in screening rates was possible at each of these centers, regardless of their size, through implementing standardized and coordinated care. In other words, people needed to be aware of how infrequent TCD screening was happening so that they could appropriately flag those children who needed to have their annual screenings done. So still lots of work to be done to better understand how to implement this more broadly across all sickle cell centers, how to decrease variability in TCD training and reporting, as well as how to ensure TCDs are accessible in countries that have a much higher prevalence of the disease than here in the US. The next complication, silent cerebral infarcts, we know continues to impact a considerable number of children. In fact, close to 30% of children with sickle cell disease will have a silent infarct before their 6th birthday, and nearly 40% by their 15th birthday will have experienced a silent stroke. These typically occur in the frontal and parietal lobes of the brain, affecting executive functioning, IQ, and processing speed. This graph is again depicting what I just mentioned, but is a compilation from several cross-sectional studies and actually one longitudinal study. And you can see that almost 40% of children will have a silent stroke before the age of 20, and that more than half of adults by their 30s. It's a significant burden, morbidity burden. Work by Dr. Melanie Fields and colleagues at Washington University gives us a bit more insight into why this may be occurring. Here we see an MRI mapping of brains from about 25 children with sickle cell anemia. And in the top picture, we see actually different degrees of oxygen extraction, which is how much oxygen the brain tissue is pulling from the blood that's flowing by. And the darkest blue here has the greatest oxygen extraction. In the middle picture, this same area is outlined in blue and is actually overlying images of cerebral blood flow, with the least amount of flow indicated by the darkest shades of red. And the bottom picture shows that this region of high oxygen extraction, again outlined in blue, also correlates with regions of highest silent infarct density. In other words, silent strokes are happening where cerebral oxygen demand is exceeding what is supplied. We know from the SIT trial that chronic transfusions are effective at preventing additional silent strokes. And this study, again by Dr. Fields and her team, provides additional insight into why. On the left-hand side, we see a child's brain that is not receiving any type of disease-modifying therapy. And you can see the significantly high oxygen extraction that's occurring in pink. When treated with hydroxyurea, this is drastically reduced, suggesting that there's balance in the oxygen demand and supply of the brain tissue. And this is actually even further reduced when this child is treated with transfusions. So together, this is demonstrating that hydroxyurea is effective in reducing oxygen extraction, and thereby may be effective in reducing the incidence of silent strokes, potentially preventative, though does not have as large of an impact as chronic transfusions do. So the question is, does hydroxyurea prevent silent strokes? Well, the answer is we think so, but we don't entirely know. So there were two sort of primary studies that looked at this so far. One was data from the long-term hydroxyurea study, or HUSTLE, and one was a 15-year retrospective study from Alabama. And together they noted that the combined incidence of silent infarcts for children on hydroxyurea was similar to the observation arm from the SIT trial and slightly higher than the transfusion arm. But questions about optimal hydroxyurea dosing and adherence, as well as whether patients had underlying vasculopathy in these two cohorts, makes it difficult to interpret these results and compare to the very structured, scientifically rigorous SIT trial. So we need additional longer-term studies. Now, if we recall the figure of the complex pathophysiology of neurologic complications in sickle cell disease, the ultimate endpoint of that diagram was cognitive sequelae. And there is growing literature to support the significant neurocognitive impact sickle cell disease has in children from a very young age. Specifically, deficits in intellectual functioning, visual motor and visual spatial skills, and executive functioning at higher rates than age-matched peers without disease. We know that 60% of children with sickle cell disease will report academic difficulties, and these concerns do increase with age. We know some of the contributors of this are disease-related, such as strokes or silent strokes, but school absenteeism due to recurrent hospitalizations or pain lead at higher rates than their peers, leads to a significant neurocognitive impact. And we also know that pain, a hallmark complication of sickle cell, is associated with poor working memory and processing speed. Dr. Michael DeBon and colleagues demonstrated this concern about 10 years ago, actually, where they found that children with sickle cell disease, whether or not they had had a stroke, had lower IQs than their siblings, the controls in this graph, that were unaffected by sickle cell. This also translated into children with sickle cell disease requiring higher rates of special education services or needing to be retained a grade compared to their siblings without disease, as you can see in this blue graph on the right. And this again was whether or not they had a history of silent infarct. And Dr. Andrew Heitzer and colleagues from St. Jude actually demonstrated with a large cohort that there are various aspects of executive functioning and IQ that are affected, particularly reading and math fluency. And this impact or these deficits increases significantly with age, with the red bar being those in young adulthood and the yellow bar being school-aged children. So we think that the impact of sickle cell disease on neurocognitive development is so grand that the American Society of Hematology, in its most recent cerebrovascular guidelines from 2020, actually recommends standardized screening for developmental and neurocognitive needs in children with sickle cell disease in sickle cell clinics, and specifically state that pediatric sickle cell providers or teams should perform screening for preschool and school-age children through what they call signaling or parent signaling type questions due to the high risk of neurocognitive complications in this age group. And that if a child were to screen positive, then that should prompt a referral for formal screening either by a psychologist or a primary care provider, a general practitioner who is certified to do so. Here's an example of some of these parent-directed questions that they recommend. This is just a sampling of some of the age groups. So if for a child who's 4 years old, for example, you may ask parents, do they play imaginative games with you or their friends or with toys? In regards to school readiness, you may ask, can they speak clearly enough so that strangers understand them almost 100% of the time? Or do they use sentences that are 4 words or longer? I won't go through all of these. There are many, and there are many more based on age. But if you're interested, you can find these online with the American Society of Hematology guidelines. This is in the supplemental file number 5. And while we don't have trials that specifically provide us information on how transfusions may impact neurocognitive outcomes, there is a growing body of literature to support the effect hydroxyurea has. So this is again from Dr. Heitzer and colleagues at St. Jude. And in 2021, they showed that hydroxyurea had a significant impact on future cognitive abilities. That is, those who started hydroxyurea at an earlier age were able to prevent some of the degree of neurocognitive deficits that happen over time, particularly when you look at math fluency and reading fluency. Even a delay in just a few years of initiation of hydroxyurea can have a significant decline. So while Heitzer and colleagues were looking at the preventative effects of hydroxyurea, Nigei and colleagues from Uganda actually recently presented at this last year American Society of Hematology meeting results from their follow-up study to BrainSafe. BrainSafe 1 actually looked at the incidence of neurocognitive complications in a large number, over 250 sickle cell children with sickle cell disease. And BrainSafe 2 was actually looking to see if hydroxyurea could reverse any of that impact. And they found that it did, actually. So in a cohort that was receiving dose escalation of hydroxyurea to optimal dosing, they did see an overall improvement in neurocognitive functioning compared to baseline for children with sickle cell anemia after just 18 months of treatment. This might be related to the change in oxygen extraction that hydroxyurea has, that Dr. Fields and her lab demonstrated, suggesting that if permanent damage hasn't been done, hydroxyurea may be able to change cerebral blood flow and the supply that's provided. So the last complication I will touch on is related to headaches, primarily because this is such a common complaint for children and adults with sickle cell disease, with multiple studies demonstrating that almost a third of children complain about headaches, whether that's acute or chronic headaches. The good news is this is rarely associated with any sort of CNS pathology. The table on the right comes from the largest cross-sectional study regarding headaches in sickle cell disease that was done by Dr. Dowling and colleagues in 2014. And you can see there was not a statistically significant difference in silent infarcts between those that did complain of headaches and those that did not. Unfortunately, we don't have any guidelines for management of headaches in sickle cell disease, and there's actually been very little research in this space since. But from what we do know, we think that most children with complaints of headaches probably do not need head imaging, particularly in the setting, in the absence of any sort of neurologic signs or symptoms. And we also think that usual headache management is probably appropriate for this age group, either with supportive care, such as increasing hydration, focusing on sleep habits, or through common headache therapy options. So in summary, we do have established standards for the most common of neurologic complications, such as stroke or silent infarct, but we definitely know that there are challenges in implementation of some of our preventative screening methods, such as transcranial Dopplers, including challenges with accessibility in countries where sickle cell disease is the most common. There is some newer understanding on the multitude of neurologic complications that affect children with sickle cell disease, especially as they age into adulthood, but we are in desperate need of further research and literature as to the pathophysiology, the incidence and prevalence, as well as potential treatments and preventative options in this space. Thank you to everybody. I, again, really appreciate being here with you today, and I'm happy to answer any questions that may come up. But if nothing at this point, feel free to reach out to me, and I'm happy to also answer questions by email.
Thank you so much, Dr. Jacob, for the excellent review of neurological manifestation or complications in sickle cell disease, which is common problem, and it is disturbing for the kids' education and academic future. Thank you so much. I don't see any questions. Thank you for joining us.
You.
Our next speaker is Dr. Charles Azar. Dr. Azar is a hematologist at the Massachusetts General Hospital and Harvard Medical School and the medical director of the Comprehensive Sickle Cell Disease Treatment Center. He received his medical degree from Orange Health and Science University, where he also completed his residency in internal medicine and his fellowship in hematology and medical oncology, while he also serving as chief fellow. He went on to complete his an advanced fellowship in hemostasis and thrombosis at the University of California. Azar is a passionate about the care of patients with sickle cell disease, thalassemia, and other hemoglobin disorders. His work focuses on improving system of care and political advocacy for patients living with sickle cell disease to build a true medical home while combating inequities in healthcare. Welcome, Dr. Azar, and I apologize for keeping you waiting.
Not a problem at all, and thank you so much for inviting me. It's a pleasure to be with you all. Thank you so much for inviting me to give this talk. Let me go ahead and share my screen and get my slides up here for you.
Thanks so much.
Thank you so much. All right. Let me get my... there we go. Hopefully you all can see my slides. It's a pleasure to be invited, a pleasure to give this talk this morning. You've already heard from two of my colleagues about the backgrounds in sickle cell disease, but my hope this morning is to be able to talk a little bit about some of the emerging therapies and some of the changing landscape that's occurring in sickle cell disease. And I start with one of my favorite quotes, this quote by Nat Turner, that the time was fast approaching when the first should be last and the last should be first. Such a relevant quote as we talk about these therapies, because as everybody here knows, sickle cell disease has always been regarded at the bottom, always at the last. And we are very excited to begin to see some emerging therapies that allow the disease to sort of step to the forefront. Unfortunately, as we are becoming the first to engage with certain classes of therapies and certain interventions, we are once again having to sort of blaze the trail for other disease processes around the world. So over the course of the next few minutes, I want to talk a little bit about the understanding of the disease, and I won't belabor this too much because you've just heard two great talks from my colleagues around the world about sickle cell disease in general. But I want to emphasize some key points about the current treatment landscape that have given rise to some of the emerging therapies that I'll spend more of my time discussing. Then we'll move into a discussion about the new emerging therapies. And because we have a limited time this morning, I wanted to focus on just a couple of key areas. First, talking about two exciting potential new approaches to disease modification itself. And then, very exciting to me, a potential new approach to the management of sickle cell pain that I'm hoping to see emerging over the course of the coming year. And then lastly, we'll delve into some of the excitement and anxiety around the transformational therapies, gene therapy, talk a little bit about how these therapies are being used now and the way that our center here in the United States is beginning to roll out these interventions now that they have been commercially available. So first and foremost, I won't delve too deep into this section, but I think as everybody here knows, and as we've heard, sickle cell disease is the most common inherited life-threatening blood disorder. Here in the United States, it's estimated to impact about 100,000 people, but around the world, it seems to impact about 8 million people. And as Dr. Jacob mentioned, one new baby is born with this disease every couple of minutes. Unfortunately, here in the US, the numbers telling us how many people live with this disease have not changed in over 3 decades. And the reason for that, the reason we are so behind in our understanding of this disease is because of the racial biases associated with the illness, because it is one of the only diseases that predominantly impacts Black and brown people. And you can see on the screen some of the statistics related to the birth rates of sickle cell disease here in the United States. 1 in every 365 Black Americans will be born with sickle cell disease in the US. And because our healthcare system here is so intrinsically biased, we are sadly years behind in our understanding and ability to manage the disease. Here is a map that sort of demonstrates the prevalence of the disease as it spreads across the globe, a fact that my colleagues around the country have already elucidated to you. I think that the numbers that we're seeing here are also gross underestimations, even when you travel outside the United States. And as Dr. Jacobs so beautifully pointed out, this is a disease that really touches every organ in the body. We know that I am an adult hematologist and focus on blood disorders, but really and truly, this is an internal medicine disease. It does not spare a single organ, from the painful osteonecrosis that impacts our patients in their 2nd and 3rd decades of life, to the progressive renal failure that can eventually lead to dialysis dependence, through the history of stroke and other neurologic complications that you just heard about, along with the increased complications that we're seeing cardiovascularly as our patients are now living into older ages, the ongoing need for annual retinopathy screening that will hopefully prevent blindness, the painful skin ulcers that are so difficult for us to be able to manage, and the ongoing severity of priapism and infertility that impacts our patients' quality of life. Now, let me talk very briefly about where we are at in our current landscape of management and touch on some of the things that Dr. Anusa had talked about earlier today, but kind of expand on some of these as well as they foray into some of the newer treatments that are coming down the pipeline. First and foremost, it's important to emphasize the role of hydroxyurea. As both of my prior colleagues have described, hydroxyurea stimulates the production of hemoglobin F. How it does this, we're not entirely sure, and what other mechanisms are playing a role in the way that it works, we're also not entirely clear on, although there are several ideas that have postulated it. But hydroxyurea became available here in the United States in the late 1990s because of the MESH study, which is to date, sadly, one of the few multi-center, 2-year, double-blinded, randomized, placebo-controlled trials that we have in sickle cell disease. And this study demonstrated a marked reduction in painful vaso-occlusive events, but also, importantly, an overall reduction in mortality. And sadly, even though it has now been nearly 3 decades since this medication first came onto the market, it remains the only therapy that we have that has been shown to reduce the overall mortality. Over the course of the last 4 to 5 years, newer therapies, as Dr. Anusa had alluded to, have come onto the market. L-glutamine was the first of these to come onto the market in 2018, 2019. But the effect of L-glutamine has been sadly modest. Here in the US, many insurance companies still struggle to pay for it. And when our patients get it, they have a difficult time taking it because it is a powder that they have to mix into a liquid that they then have to dose twice a day. It has been shown to reduce the rate of hospitalizations when used with hydroxyurea by a modest amount, reducing the average number of hospitalizations from 4 to 3. We were very excited when the first of its class anti-sickling agent, voxelotor, an oral agent that was demonstrated to the phase 3 HOPE trial to reduce the polymerization of hemoglobin S, came out as an oral therapy. Unfortunately, the study demonstrated that it raises the total hemoglobin by only about 1 gram per deciliter, which is an important improvement in patients who are suffering symptoms as a result of their anemia. But most importantly, it has not been demonstrated, at least not in clinical trials, to reduce the rate of painful vaso-occlusive events, the complication by which most of our patients are seeking medical care. And then I think everybody here on the meeting knows about the sad story with crizanlizumab, which was approved out of the phase 2 study that was done here in the United States, the first of its class p-selectin inhibitor that actually demonstrated what appeared to be a very real reduction in painful vaso-occlusive events. But then in the last few months, the recent data from the large European STAND trial demonstrated that the drug may not be any better than placebo. And that really has thrown into question the role of this therapy. I know that my colleagues in Europe are no longer able to use this drug. Here in the United States, we still have access to it. And as Dr. Anusa had mentioned earlier today, there are many patients that will anecdotally tell you that they feel better being on this medication. So I have opted to keep those patients on the drug, but have not started any new patients on crizanlizumab. Hematopoietic stem cell transplant remains the only potential curative treatment option for sickle cell disease. And many trials or studies have demonstrated the significant impact that this can have on the disease, with a marked improvement in 5-year survival and overall survival. However, where to bring allogeneic transplant into the mix for a patient with sickle cell disease is challenging to understand, because there are many limitations against its wide use. And this is one of the many reasons why we don't just transplant every child with sickle cell disease. Here in the United States, the American Society of Hematology rolled out the first guidelines around the use of hematopoietic stem cell transplant only about 2.5 or 3 years ago. And in those recommendations really implied that the optimal time to do this is at a very young age, given the fact that the complications that you walk into the transplant with are the same complications that you will walk out of the transplant with. So trying to do this intervention before a lot of those major end organ complications set in is prudent. But those same guidelines also recommended the use of a matched sibling donor, and considered any transplant not done with a matched sibling donor to really be considered experimental and shouldn't be done outside of a clinical trial. That makes it very challenging, because access to a donor, if you don't have a matched sibling, is also very challenging, given the number of people of color in the national donor pool. We also know that in sickle cell patients, there's higher rates of graft failure, there's higher rates of graft versus host disease, and of course, the conditioning chemotherapy can often give rise to side effects that are very much undesirable to most patients. All of these things have made it very difficult to be able to pursue allogeneic transplants in patients living with the disease, not to mention the significant cost and resource intensity. So let's move on to talk about some of the emerging therapies that have gotten me the most excited. And again, because of our limited time, I will really focus on just a couple of new mechanisms of action that I think are showing some great promise. The first of these is a mechanism that Dr. Anusa briefly touched on earlier today, and this is the idea of targeting pyruvate kinase. So mitapivat is an oral small molecule allosteric activator of pyruvate kinase. It's actually already approved here in the United States for certain disease states, and it's currently being widely evaluated by the manufacturer for all sorts of hemolytic anemias, including thalassemia and PK deficiency. In the United States, it's being targeted because of its ability potentially to increase ATP in the red cell. and thereby improve the overall red cell survival. At the same time, the drug has been shown to reduce 2,3-DPG, which then increases the oxygen affinity of hemoglobin, reducing the polymerization of hemoglobin S and potentially serving as another anti-sickling drug akin to the type of mechanism that voxelotor had demonstrated. Currently, mitapivat is in phase 2-3 double-blind randomized placebo-controlled trials here in the United States and around the world. The results of the phase 2 study were shared at the American Society of Hematology conference in 2023, just a few months ago. And what that study demonstrated was that patients were eligible to enroll if they were over the age of 16 and if they had a hemoglobin of 5.5 to 10.5 grams per deciliter, along with 2 to 10 painful vaso-occlusive events annually. They were randomized in the study to receive one of two doses, 50 or 100 milligrams, or placebo. And the study looked to see what the rates of hemoglobin, total hemoglobin change were in these patients from their baseline. Secondary outcomes were looking at markers of hemolysis and erythropoiesis, as well as fatigue and rates of painful vaso-occlusive events. And here on this slide, I'll just share in words what the study demonstrated, but I'll show you the data on the next slide. What the study demonstrated was that about 79 patients were enrolled. 26 patients were put in each drug arm. Remember, there were two doses that were given, and then 27 were enrolled in the placebo arm. And what the study demonstrated was a statistically significant increase in the total hemoglobin by greater than 1 gram per deciliter compared to the patients who were on placebo. 46% of the patients on the lower dose arm and 50% of the patients on the higher dose arm achieved this hemoglobin response, which the study defined as greater than 1 point, compared to about 3.7% in the placebo arm. And what's interesting is that you can see that over the 12 weeks of the study, there wasn't a decrease in the annualized rate of painful vaso-occlusive events in those patients on both the low and high dose arms of the study compared to those on placebo. There were no adverse events that were reported in this preliminary data that was shared, and the most common adverse effects were things that were largely tolerable, mild to moderate in patients overall. And here you can see that data in graphical form. On the screen, you'll see the blue line representing the higher dose of mitapivat, the orange line representing the lower dose, and the green line representing placebo. And then you can see that on the x-axis, we're demonstrating the change in total hemoglobin from the patient's baseline. And you can see a change of somewhere between 1 to 1.5 points from their baseline. So an exciting laboratory intervention here demonstrated by this drug. But then when you look a little bit deeper at some of their secondary outcomes, I think even more exciting here is the fact that you can see that at the higher dose of mitapivat, there was clearly a reduction in markers of hemolysis, and then a trend towards a reduction in painful vaso-occlusive events. So while it's very exciting to be able to have a drug that might be able to help improve anemia, especially considering why so many of our patients suffer from the side effects of that anemia, it's also great to be able to have another therapy that may potentially be able to reduce the rate of painful vaso-occlusive events, although we definitely need more complete data to be able to see that these trends continue. If we then move past the mechanism of targeting pyruvate kinase and look at the idea of targeting fetal hemoglobin, we know that looking at fetal hemoglobin is an interesting target because we think that that's how hydroxyurea has done its great work over the course of the last 3 decades. We can understand just observationally that patients who have sickle cell disease, but who retain the ability to have an elevated fetal hemoglobin, those patients who have the so-called hereditary persistence of fetal hemoglobin, have an overall better prognosis. And there have even been asymptomatic phenotypes of patients with SS disease that have been reported when those rare few have fetal hemoglobin levels that exceed 25%. Over the course of the last few years, greater research has been done in trying to elucidate the transition from fetal hemoglobin to adult hemoglobin, and BCL11A has emerged as a very important target, a great regulator of fetal hemoglobin that suppresses the transcription of the fetal hemoglobin gene. So if we can turn off BCL11A or modify its effect, we may be able to turn on the ability to further transcribe fetal hemoglobin. And we're going to revisit this as we talk about our approach to gene therapy. But one drug company in particular has been looking at the role of targeting the polycomb repressive complex, or PRC2, which regulates BCL11A expression in progenitors of red blood cells. And what they postulate is by knocking down PRC2, you can decrease the expression of BCL11A, which then flips the switch back on to allow fetal hemoglobin to be transcribed in both in vitro and in mouse models of sickle cell disease. So the experimental therapy, FTX6058, was demonstrated to be a potent reducer of BCL11A activity. And here on the screen, you can see some of their early preclinical data that demonstrates that when compared to a vehicle, in this case it was DMSO, in a mouse model of sickle cell disease, you can see a significant reduction in BCL11A expression, which then in turn leads to greater transcription of the gene that leads to fetal hemoglobin and hopefully helps then raise fetal hemoglobin levels. So with this animal model data in place, they went on to do a translational research project, and the interim results of that phase 1b trial were shared just a couple of years ago, the year before last. This study of FTX6058 took 3 cohorts of healthy volunteers that were dosed daily with the drug for up to 8 weeks. This was a phase 1 study, so they were mostly focused on safety and tolerability. But they did have a secondary endpoint of looking at the induction of fetal hemoglobin in the peripheral blood. At the time that this interim data was shared, 12 healthy volunteers had been enrolled with 2 different dosing cohorts. There were no severe adverse events, and there seemed to be a dose proportional increase in fetal hemoglobin mRNA. And you can see that here in the data that they shared from that interim analysis, demonstrating the rise in fetal hemoglobin levels from baseline as they increased from 2 to 6 to 12 milligrams of their experimental therapy. In February of 2023, unfortunately, the FDA placed a clinical hold on this trial. And the reason for it was because there was clinical and non-clinical evidence of an increased rate of hematologic malignancies that were being observed in other therapies that were targeting PCR2. Those therapies were targeting the molecule at a different location in a different place, but because there was concern that this could be a class effect, the FDA put a hold on the trial. In August of 2023, they reopened the trial. They lifted that hold, but they imposed some changes in the inclusion criteria, asking the company and the participating centers to enroll patients that had a greater severity of disease, given the still unknown component surrounding the potential of hematologic malignancies long term. It's important to note that as we've talked about other therapies for sickle cell disease that have attempted to target fetal hemoglobin, including hydroxyurea, there's always been this concern about increased rates of hematologic malignancies. And thankfully, those have not been borne out in hydroxyurea, but it remains to be seen how this may bear out with other more potent targets of fetal hemoglobin. The new FDA guidelines recommend that patients now need to have failed hydroxyurea or other disease-modifying agents, need to have a higher rate of painful vaso-occlusive events, or need to have some other severe complication of their disease, including acute chest syndrome, hepatic and splenic sequestration, or priapism, or pulmonary hypertension or chronic kidney disease in order to be able to enroll in the study. This study is ongoing. And then lastly, I really wanted to talk about something that's very exciting to me because, as you all know, we have had very little outside of opiate therapy to be able to manage the pain of sickle cell disease. And as opiate therapies can come with more than their share of complications, are highly stigmatizing, and lead to a lot of our patients having to suffer significant complications on their own when even just going to the pharmacy to pick up these medications, having something that is a non-opiate intervention for the management of sickle cell disease is particularly exciting for me as an adult hematologist. So I've become very interested in this study that has been going on, looking at a new novel NaV1.8, a sodium channel blocker that looks at NaV1.8, which is expressed on peripheral nociceptive neurons. It is known, this sodium channel is known to play a key role in transmitting nociceptive signaling. And so as a result of this, VX548, a novel target, a selective inhibitor of the sodium-gated channel NaV1.8, has been developed. And the data was demonstrated from two phase 2 trials that were conducted in patients who were suffering from post-operative pain. It's important to emphasize, this is not sickle cell pain. These studies were done in patients with post-operative pain, those who had undergone abdominoplasty or bunionectomy. But I bring these up because they're going to potentially give rise to the commercial release of this medication even before the trials looking at this drug for sickle cell disease have even been completed, which may allow us access to this medication even before then. Both of these trials randomized patients to receive one of two different regimens that consisted of a loading dose and then a Q12-hour maintenance dose of this new novel pain medication. And they compared it to placebo or to hydrocodone acetaminophen in the management of pain. The primary endpoint was a time-weighted sum of the pain intensity difference, and they derived this from numeric pain scales at 19 different time points. 303 patients were in the abdominoplasty study, 274 in the bunionectomy study, and when they compared them to placebo, the experimental therapy at a higher dose reduced the acute pain over a 48-hour period following these two surgical interventions. The adverse events were largely limited to nausea, vomiting, headache, and constipation. There was one patient who had suffered a PE, although it was thought to be more related to the surgery and not to the drug itself. And here you can see some of the data. First, the data from the patients who had undergone abdominoplasty, the black line representing those who had received placebo, the blue line showing the experimental therapy, and the orange line demonstrating those who had received hydrocodone and Tylenol. Though you can see that the experimental therapy seemed to reduce the mean rate, the mean pain score, akin to those patients who were receiving hydrocodone acetaminophen. And similar data was shown in the phase 3 study that was done in those patients following bunionectomy. Now, again, these are not sickle cell patients, and we know that there are differences in sickle cell pain, but it is exciting to be able to see the first new class of pain management medication that is coming potentially on the market because of these studies. This drug is likely to be available here in the United States in the coming year, we hope. And then there will be additional studies done forthcoming that will actually be looking at this in sickle cell patients directly, but we will be able to have it commercially available even before then. And it may pose an interesting alternative to patients, especially those who do not want to take opiates or don't have access to opiate therapy to be able to get their pain under control. And then for the last few minutes, I just very much want to talk about gene therapy. Dr. Anusa had begun this conversation earlier in the day. We had talked earlier about the important role of fetal hemoglobin, and the two therapies that came out and were commercially available in December of 2023. One of them targets fetal hemoglobin, and the other one helps to build a modified form of hemoglobin A. I'm going to focus, just for the sake of time, on the studies that looked at fetal hemoglobin, especially as they utilized the CRISPR-Cas9 technology, the first time ever that a therapy globally has used CRISPR-Cas9. And this therapy, again, targets BCL11A, which we had talked about earlier. The gene therapy approach, whether utilizing the CRISPR-Cas9 technology, Casgevy, or using the lentiviral transfection approach, Lyfgenia, both have very similar and lengthy treatment journeys. The patients we prepare our patients for a treatment journey that may take up to a year. The patients have their stem cells mobilized. They then have to be sent off to the manufacturers. That manufacturing process currently is taking up to 6 months. And when the cells are returned, they're then admitted to the hospital for an autologous transplant where they receive busulfan conditioning therapy and then receive their own cells with hospitalizations of 30 to 45 days waiting for engraftment. The concern is that busulfan itself brings its share of toxicity. Most important to our patients is the toxicity around fertility. And here you can see some of the data that was shared with what is now known as Casgevy, Vertex's product, showing a significant decrease in the rate of painful vaso-occlusive events in those patients who were able to be treated with the intervention after the treatment. But this has left a lot of unanswered questions for us. While these therapies were approved about 5 months ago, the FDA here in the United States granted broad approval for all disease subtypes from SC to S beta plus, S beta 0, and SS disease. And the products were approved for patients who are age 12 and older, as long as they had suffered 4 vaso-occlusive events or more. But the question was really what would be covered. And the cost of these therapies is quite high. Casgevy is $2.1 million per patient. Lyfgenia is $3.2 million. This does not count the additional $1 million that is required for the bone marrow transplant itself. So what will be covered here in the United States and then what will be covered across the world remain very important unanswered questions. And the way that we roll out this therapy here in the US and in the UK, where it's also been approved, really is going to paint the pathway for how our colleagues around the world are going to be able to scale this therapy globally. Where most countries have just struggled to access hydroxyurea, how on earth will we get them access to gene therapy? This is at the forefront of my mind as we are rolling out the process by which to standardize this care. Here in the U.S., we have a system of authorized treatment centers. Because this is such a labor-intensive intervention, we want this to be a system that can be accessed as much as possible. So we've created this hub and spoke model where authorized treatment centers, who we define as a center that contains a certified sickle cell program, a FACT-accredited bone marrow transplant center, and an apheresis program, works in tandem with mental health care, social work, nursing care, and nutritional support. We know that there are important key barriers that our patients face to this that we have to overcome, including housing, fertility preservation, and survivorship. So here at the Massachusetts General Hospital and the Harvard Medical School, we have been working to build this coalition between these different departments. We created a meeting of these different departments that comes together every month to discuss the potential candidacy of patients who have expressed interest in gene therapy. And the goal right now here at our institution is to walk one patient through this process from beginning to end and then reevaluate how we go through the process. We are about to do this first stem cell collection in that patient in June. At the same time, because these transformative therapies are giving rise to the question of survivorship, we need to define what survivorship really looks like in patients with sickle cell disease, because we've never had that opportunity. And so really this is got coming together of our primary care colleagues, palliative care, nursing, and social work. Here at our center, we're building the first of its kind survivorship program in sickle cell disease with a commitment to being able to take care of patients who have received either curative or transformational therapies, because we know that they're going to have ongoing consequences from their disease that are going to require management. We also know that these patients are going to continue to need ongoing screening for kidney disease and eye disease, and who would be responsible for that? Who would also be responsible for the management of chronic pain that lingers after these interventions, and who would support the families of these patients as well? Those are the key elements that we're trying to work on in the building of our survivorship program. So lastly, I wanted to summarize here, because we are excited around the availability of these transformative therapies. And historically, sickle cell disease has really existed, sadly, in this very data-free or paradigm-free zone. With the emergence of these new therapies, especially the first of their class, new CRISPR-Cas9 interventions, or new therapies that are targeting fetal hemoglobin or PK, we are once again having to blaze the trail to go ahead of other disease processes to be able to define how these new interventions are going to work. Our patients are rightfully wary of the healthcare system, and trying to help earn their trust as we begin to move forward with these new interventions is critical. We have to weave together these three integral threads: the physical, psychological, social, and political challenges around these diseases, as well as the broken scaffolding of a negligent healthcare system, and the reality that this is a global disease that affects more people around the country every day. the majority of patients are unable to access even the most simplest of interventions. And so how are we going to extend these greater therapies to them? We are truly walking the camel through the eye of the needle. But fortunately for us in sickle cell disease management, we have been doing this for decades, and our previous experience will hopefully help guide us forward. So with that, I will conclude, and I'm very happy to take any questions. I thank you all for your attention, and again, for the kind invitation to present to you all today.
Thank you so much, Dr. Azar, for the really excellent and very impressive and exciting news about the new medications for patients with sickle cell disease. Actually, let me see if there's questions. I mean, there's one question for you. Is there is implementation on the sickle thalassemia cases?
Yes. So currently, gene therapy is approved for patients with sickle beta 0 and sickle beta plus thalassemia. And the trials that are going on in the studies that I've described to you are including sickle beta 0 thalassemia. Unfortunately, they are not including SC or beta plus patients, as has historically happened before, unfortunately.
Thank you so much, Dr. Azar, for the excellent presentation. And again, apologize for the delay because of technical difficulties in some speakers.
No need to apologize. Thank you again for the invitation.
Thank you so much. Okay. And now we move to the next speaker, Dr. Abdelwahid Zainal. He's a pediatric infectious disease consultant and faculty member at Sidra Medicine in Doha, Qatar. He's also an assistant professor of clinical pediatric at Weill Cornell Medicine, Qatar. He has been working as attending physician since July 2023 and also serves as assistant program director of pediatric residency, pediatric infectious disease fellowship, associated program, and for pediatric infectious diseases fellowship program. He is involved in several committees related to infection prevention and control, renal transplant, and antimicrobial stewardship. Welcome, Dr. Abdelwahid.
Thank you, Dr. Najat. I also had some technical issues. I couldn't share or use the microphone or the camera on my computer. But I am able to log in through my phone, and I'll be sharing the screen from my computer. So thank you again for having me here today, and it's really a great pleasure to be among such a group. I will shut the camera down so I can use the computer, but I just wanted to say hi to everyone and thank you for having me. So today's presentation will be about approach to febrile neutropenia. And before I start, I'd like to confirm that I have no conflict of interest in relation to this presentation. Before I go, so there are some parts of the objective of this talk is an outline is to include the definition of febrile neutropenia in children who are on chemotherapy, and non-chemotherapy children. Then we'll go toward the end over the current guidelines for febrile neutropenia management by the IDSA. So as I mentioned, it's very important to define fever. So what is fever? Fever is a single temperature, oral temperature of more than or equal to 38.3. Temperature or a temperature of 38 or more for a longer than 1 hour, or 2 elevations of more than 38 during a 12-hour period. Now we have to make sure that we are all on the same page in terms of definition of neutropenia, but we have 2 different categories. The chemotherapy group patients who are based on their status and diagnosis. So non-chemotherapy induced neutropenia in patients with basically in patients with non-chemotherapy induced neutropenia. Neutropenia is generally defined as an absolute neutrophil count of less than 1,500. while chemotherapy-induced neutropenia, usually the definition of neutropenia or neutropenia is defined by ANC of less than 500, or an ANC that is expected to decrease to less than 500 during the next 48 hours. In this slide, there is basically the number of the normal white blood cell number, ANC number, and the percentage of neutrophil of white blood cell from the neonatal age group to children up to age of 10 years of age. And we can see that throughout the years when the kids get older, there is a drop in percentage of a neutrophil throughout. So it's important also to classify the severity of a neutropenia as it affects the management and what is the antibiotic choice, as well as the expectation and outcome for the patient. So you can see that the normal ANC is anything above 1500 cell per microliter. Neutropenia starts with ANC less than 1500, and then mild neutropenia between 1000 and 1500. Moderate neutropenia between 500 to 1000, severe neutropenia less than 500, and then profound neutropenia in less than 100 cell per microliter. So it is important to understand the etiology of neutropenia as it's as critical as affect the management and plan for patients with neutropenia. There are many acquired causes of neutropenia, like infection, drug-induced, or immune disorder being the most common. Post-infectious neutropenia may represent the most common cause of acquired isolation neutropenia in most instances, particularly post-viral infections. The neutropenia usually are short-lived in such cases and rarely results in bacterial superimposed infection. Example of these viruses include HBV virus, HIV, hepatitis B virus. And neutropenia and bone marrow failure can be seen in severe vitamin B12 deficiency, folate deficiency, as well as copper deficiency. Then there is the other category that's always important to keep in mind, which is the drug-induced neutropenia, and can occur as an adverse reaction as the second most common cause of neutropenia. Additionally, we shouldn't forget the congenital neutropenia due to some syndromes, which include severe congenital neutropenia that are seen in Kotzman syndrome, for example, and some other syndrome. Congenital neutropenia can also be seen in certain inborn error of metabolism. So in this slide, there is a long list of medications that can induce some major medication with a definite and known association with granulocytosis and can induce neutropenia. Some of these are antimicrobial that sometimes we need to use in some of these patients. Not surprisingly, I guess. Then I will start with the first to discuss febrile neutropenia in non-chemotherapy patients, and a very quick presentation and management on how to approach such cases. So fever is usually used as a marker of infection. Fever is the most common and often the first clinical the first clinical manifestation of serious infection in children with neutropenia. It's also the sole sign of occult infection. If a child with neutropenia develops fever, or if a previously healthy child is found to have an isolated neutropenia during a febrile illness, the possibility of serious infection must be considered. But then the question comes, is it only fever? Or what if the child is afebrile but looks unwell? And then in such cases, serious infection must also be considered in children with neutropenia who does not have fever, but are ill-appearing. They could have hypothermia or hypotension, confusion, and listlessness. Patients with neutropenia who appear ill or are in an increased risk of serious infection should receive empiric antibiotic after all the needed blood cultures, including blood cultures and other, are taken. We'll go into this shortly. So there are factors that affect the susceptibility to infections and make these patients prone to severe infection. Some of these are the degree of neutropenia. The greater the severity, the greater the risk, as well as the duration of the neutropenia. The longer the duration, the higher the risk. As well as it's very important that some diseases patient might have a small number of neutrophil, but the function is not as we hope. So neutrophil function is also part of risk factor that are associated with infection. The ability of the bone marrow to respond to infection is also one of these risk factors. Others are function of other components of the immune system, the barrier, the skin, the lymphatic system, the NK cell, the complement, and the immune sense, and so on. Additionally, the integrity of the oral and GI mucosa, there are many neutropenia patients who develop gastritis, typhlitis, which put them at increased risk of translocation, mainly of gram-negative pathogen from the GI gut, the gut flora, therefore developing severe sepsis. Then also it's important to know about the presence of foreign bodies like central lines, indwelling devices, a prosthetic implant like Foley catheter, and endotracheal tubes. This is a risk categorization, severity of the neutropenia. So low risk patient categorized similar to transient isolated neutropenia or chronic autoimmune neutropenia, which is the chronic idiopathic neutropenia. Then there is the low to moderate risk that are seen with cyclic neutropenia. However, high-risk susceptibility to infection are ill appearance, severe congenital neutropenia, aplastic anemia, and neutropenia that's associated with a primary immune deficiency disorder. Then comes a very important part of the management of such patients are the evaluations. So it's very important. I always remind myself is to take history once and again, twice and thrice, history, and then physical exam. In terms of history, there are some specific things that I like to focus on, including ensuring that it's not only fever. Does the child have any other symptoms? Are there any new complaints or recurrent complaints? Did the child have any previous infection and list them, like any previous UTI, any previous bacteremia, and hence the history, the use of antimicrobial as well, and any other antimicrobial prophylaxis that the child had to be on. There's also some other part that important to know, the colonization of any MRSA, MDRO, CPO. Also it's important to ask about in the review of chart if the child has received any recent blood product, and which is in your patient population, it's a very common thing that patients are receiving a blood product. Then if there has been any recent surgeries, any other chronic illnesses like diabetes mellitus and so on. Very importantly is also knowing if the child has been on any immunosuppression medication. And as I mentioned earlier, any foreign body and indwelling catheter and central lines are also important. Regarding physical exam, it's a very common, it's very important, and I like always to remind myself to examine the child head to toe, not only once, on daily basis, because some of these patients might develop symptoms after the fever on day 2 or 3. So these are important to keep on your mind. Regarding investigations, there are some routine cultures that we like all to do, is including blood culture should be collected in such patient. Aerobic and anaerobic blood culture also should be collected from central and peripheral line as well. Other cultures should be kept in mind based on the clinical history and presentation, as well as complaint, including wound culture, urine culture, as well as CSF culture if there is any CNS symptoms. Some other additional investigation might be needed if the child have respiratory symptoms, so a chest X-ray or respiratory panel, PCR. Then if the child has GI symptoms, including diarrhea or vomiting, then stool culture, ovan parasite, as well as stool PCR might be considered. That takes me to the next patient population that we are discussing today, is patients who are on chemotherapy for their diagnosis. So in patients with cancer or hematopoietic stem cells, fever occurs in approximately 1/3 of patients of a neutropenic episode, with a huge range of 10 to 60%. Then the approximate rate of occurrence is 0.76 episodes per every 30 days of a neutropenia. So in this study that was done in the US, they assessed the trend of the inpatient resource use and mortality in pediatric hospitalization for fever with neutropenia between 2007 and 2014. They noticed a significant increase in febrile neutropenia hospitalization trend was seen mainly in the age group 5 to 14 years, male of all races, while overall mortality rate remained low at 0.75%. However, the 15 to 19 years age group was at a significant greater risk of mortality. So risk factor for infection in this population, including underlying immune deficiencies, associated comorbidities, and treatment-related adverse effects. Clearly, more than one predisposing factor might exist in some of these patients, and their cumulative burden more accurately reflect the risk of infection. To some extent, these risk factors are associated with a specific infection pathogen, and underlying of each individual risk factor can help to direct strategies for diagnosis and treatments. So some of these treatment-associated factors like surgery, radiation therapy, immune suppression therapy, antimicrobial use, which might affect the microbiome and predispose a patient to different pathogen and therefore infections. And then diagnostic and invasive procedure that patients might require for their own diagnosis. So in this slide, there is again shows the risk of infection based on the absolute neutrophil counts decline. The graph on the left shows the duration that's shown in red, and the severity that are in white of neutropenia increase the risk of infection, as we can see in the graph. However, the graph on the right shows that the highest risk of infection is during the nadir period that the patient go through. So this is a slide with a lot of pathogens that we don't like to see in patients' culture that are common in patients with febrile neutropenia. The most common documented infection is bacteremia, which accounts for approximately 20 to 50% of the cases that with isolated cultures. The proportion varies with the underlying, depending on the malignancy and the institutions. Other sites of infection include the GI tract, the upper respiratory tract, as well as UTI and soft skin and soft tissue infections. The frequency of isolation of a specific organism varies, as I mentioned earlier, on institution to institution. In the past, gram-negative was more common than gram-positive. However, with the use of prophylaxis antimicrobial as well as indwelling venous catheter, and now there has been a shift toward gram-positive organisms. So some of gram-positive organisms that we see are the coagulase-negative staphylococci, then as well as viridin streptococci and Staph aureus, including MRSA. While the gram-negative include the common gram-negative bacilli, mainly E. coli, Klebsiella, Pseudomonas, Acinetobacter, and Enterobacter. Then we have the fungi, and the most common fungi that we usually see are Aspergillus and Candida. Candida bacteremia, and then Aspergillus mainly causing pneumonia. Then we shouldn't forget viruses that are associated. So respiratory viruses, herpes simplex virus, as well as varicella zosters. Then there are the non-infectious etiology that we should keep in our mind, including drug fever, cancer-related fever, and deep vein thrombosis, pulmonary embolus, as well as transfusion reaction and dysautonomia. In terms of management, so one of the most critical steps in the management of patients with febrile neutropenia is a prompt initiation of empiric broad-spectrum antibiotics. It is the cornerstone of therapy, and by prompt start, it means that has to be started within the first 60 minutes of triaging the patient. So this why early introduction of antibiotic is important. So the question is answered by this paper. This paper was a report of a quality improvement project that sought to decrease time to antibiotic delivery and assess associated clinical outcomes in pediatric patients with cancer and febrile neutropenia. The achievement was that time to antibiotic delivery, less than 60 minutes, significantly reduced the need for ICU consultation as well as admission for this population. This is another study that was published in 2014, and the objective of this study was to determine whether the time to antibiotic delivery is a predictor of mortality in adult cancer patients with febrile neutropenia. In this study, patients with febrile neutropenia episode with transient with time to antibiotic delivery of less than 30 minutes had lower 28 days mortality rate than those with time to antibiotic delivery between 31 minutes and 60 minutes. So in conclusion, early antibiotic administration was associated with a higher survival rate in a context of febrile neutropenia. So the management of antibiotic choice, so in our institution, we use the IDSA guideline. So for high-risk children with fever and chemotherapy-induced neutropenia who are clinically stable and in whom there is no suspicious of resistant infections like MRSA, we usually recommend initiating a broad spectrum with an anti-pseudomonal beta-lactam agent, including cefepime, meropenem, or tazocine, or piperacillin tazobactam, whichever you guys call it, to provide activity against the pathogens that are associated with a serious or life-threatening infection in neutropenic patients. For high-risk children with fever and neutropenia following hematopoietic stem cell transplantation, cefepime is preferred over meropenem and piperacillin tazobactam. And the reason is that there was an observational study that used that noted that the use of antibiotic with anaerobic activity like meropenem and piperacillin tazobactam eradicated the beneficial gut microbiota and has been associated with the increased rate of graft versus host disease and overall mortality. A second gram-negative coverage and or a glycopeptide like vancomycin is reserved for patients who are extremely unwell or had a history of previous resistant gram-negative and or MRSA. So that brings me to a common question that we get in the ID team: should we add vancomycin for this patient? So in other words, what are the indications for vancomycin? So hypotension or other evidence of cardiopulmonary impairments, radiographically documented pneumonia to cover for MRSA pneumonia, as these patients might be colonized and being in hospital for a long time usually. Clinically suspected serious catheter-related infection, mainly to provide MRSA bacteremia coverage. A skin or soft tissue infection at any site, known colonization with penicillin and cephalosporin-resistant pneumococci or MRSA. Positive result of blood culture of gram-positive bacteria with pending identification. So there is then the low-risk group patients with febrile neutropenia who are initial or step-down outpatient management if the infrastructure in place to ensure a careful monitoring and a follow-up. It is a weak recommendation because institutions must have the infrastructure in place to safely implement outpatient management. Clinical outcomes were similar between the strategies, and thus resources and preference are important consideration. Also consider oral antibiotic administration if the child is able to tolerate this route of administration reliably. So this is a flow chart represents the previous recommendation that I was discussing for all the patients. And now comes what if the fever persists? So persists. What should we do? If the patient is still continuing on empiric antibiotic and he's still febrile for more than or equal to 96 hours, and ANC is not increasing, then the patient has, first of all, to continue on antibiotic therapy, as we can see here. Evaluate for occult fungal infection. And we do this by ultrasound or CT of liver and spleen, CT of the chest, CT of the sinuses if the child is symptomatic, and then biopsy of any suspected lesions if there are any. Then add antifungal therapy with one of the following antifungal, either amphotericin B, an echinocandin, or a triazole derivative like voriconazole or posaconazole. If no fungal infection is identified, continue on antibiotic and antifungal therapy until ANC is more than 500 and increasing, and the child becomes afebrile. This slide and the following is basically a detailed summary of assessment and management of what I have been talking about in the past few minutes. So antifungal, why do we use it? Or in other words, when do we add it? Who are the patients at risk for fungal infection? Patient with AML, patient with high risk of ALL, relapsing acute leukemia, children undergoing allogenic hematopoietic stem cell, children with a prolonged neutropenia, and children receiving high-dose corticosteroids. So is preventing febrile neutropenia possible? There are some agents that are FDA approved, filgrastim and pig-filgrastim, which are pigletide granulocyte colony stimulating factor. The difference between the two is one of them is the short acting and the other one is the long acting. So this study compares basically it's a meta-analysis that looked into 8 studies that comprised of 167 patients and 550 courses of treatment. And they noticed that there was no difference between pig-filgrastim and filgrastim for the rate of febrile neutropenia in children receiving chemotherapy. So that brings me to the end of my presentation, and I just wanted to emphasize on a single take-home message, that if there is one message that I want to deliver today is that start empiric antibiotic therapy as early as possible, as it affects the outcome and mortality for our population. Thank you for having me present in today's conference. It's really a pleasure to be part of this conference, and thank you, Dr. Najat, for having me again.
Thank you so much, Dr. Abdelwahid, for your excellent and very impressive coverage of febrile neutropenia. We have 2 questions for you. The first one, the sickle cell patient having recurrent ESBL infection, not supersede with meropenem. So what is the next remedy?
So are these it's not sensitive to meropenem?
Not responsive, yes. So what would you recommend?
So it depends on, there are, if the pathogen is sensitive to meropenem, but patient is unwell and not doing well, sometimes we consider adding a second line agent, like aminoglycosides, which can provide some synergy. The other thing is that I always keep reminding myself, the fellows and the residents that I work with, is that we need to make sure that it's not only bug and drug failure, because sometimes we need to make sure that we have a good source control of the infection. So, for example, if it's a UTI and there is, for example, pyelonephritis, and there is a collection somewhere in the kidney, so we need to make sure that this is drained, or if there is an abdominal collection. So this is a common thing that I face sometimes, is trying to convince the IR team or the surgical team to intervene for a patient who are persistently febrile. And I actually have one case today that I saw in hospital, is still febrile and on appropriate therapy, but not responding as we hope because there is a collection. So sometimes we need to make sure that we intervene and do source control. I hope this helps.
Okay, another question is, any data about pedia hemato-oncology patients colonized with infected by Candida aureus? Is it also prevalent for such patient population?
Luckily, so far in Qatar, alhamdulillah, we did not have any cases of Candida auris, although we screen for it in our hospital, because there has been a couple of cases of Candida auris in the adult hospitals and the adult ICUs in Qatar. But when I was attending a conference for GCC Pediatric ID in Saudi Arabia, there have been some cases reported in Saudi Arabia in some of their NICUs. There has been 2 or 3 cases. But at this point, we screen for it. But if we suspected, we usually make because there are big, or not a big percent, actually, it's almost 4% of Candida auris are resistant to all the to the most common classes of antifungals. So we always need to screen and have sensitivity to know what choice of antifungal to use. But so far in PEDS in Qatar, we don't have anything. Alhamdulillah. I'm not sure about the team in Bahrain.
We do have cases also. Another question is, should we give a prophylactic antibiotic for moderate neutropenia, which is virus-induced? Post-viral.
So no, I would not recommend this, and the guideline does not recommend this, especially if this is post-virally induced. And as I mentioned earlier, that could usually resolve within a few weeks to months. Just need a clear follow-up with repeat blood workup to ensure that it's trending up. That's one. And then another thing that I always like to say is to educate the families to bring the child back once the child looks unwell or start to spike fever, to have a proper assessment.
Okay, thank you so much, Dr. Abdelwahed. We'll move to the next speaker. Our next speaker is Dr. Stacy Crotio. She's the Medical Director of Boston Hemophilia Center, Assistant Professor of Pediatric, Harvard Medical School, and Clinical Researcher at Dana-Farber Boston Children's Cancer and Blood Disorder Center, specialized in bleeding and clotting disorders. Welcome, Dr. Crotio.
This session is entitled BWD, Novel Approach and Practical Experience. I'm Dr. Stacy Crotio, pediatric hematologist at Boston Children's Hospital and medical director of the Boston Bleeding Disorder Center. Thank you to the organizers for inviting me to speak with you today on this important topic. The history of the recognition of von Willebrand disease is now almost 100 years old. Pictured here on the right is Dr. Eric von Willebrand, who first identified this bleeding disorder when he met young Ordis Sandblom, who was originally from the Åland Islands and had actually been hospitalized in Finland due to excessive bleeding. Initially entitled pseudohemophilia, we've learned a great deal about this bleeding disorder over time. But when we look at a timeline from its early description in the 1920s through present, we've had a very limited number of therapies that have become available for von Willebrand disease. Some of the earliest treatments, of course, were related to plasma and cone fractionation, first administered to a subgroup in the Åland Islands in 1957. And subsequent to that, pooled crowd precipitate plasma-derived factor concentrates have been available since the 1970s. We were able to add desmopressin to the armamentarium in the 1980s. And subsequently, we've really only added higher purity plasma-derived concentrates and a single recombinant von Willebrand concentrate to our armamentarium. In comparison to our individuals with hemophilia, for example, far fewer treatment options and clinical innovations have been made to date in this space. But there is hope for the future. And as we go through this presentation, we'll highlight some of the emerging treatment options that are currently in preclinical and early phase clinical study for individuals with von Willebrand disease. Von Willebrand disease is challenging to diagnose and challenging to manage. And we've had some support coming in the way of guidelines from 2021, the BWD clinical guidelines, which were a joint effort of the American Society of Hematology, the International Society for Thrombosis and Hemostasis, the National then Hemophilia Foundation, and the World Federation, and individuals, including professionals, as well as lived expert experiences, coming together to use some rigorous methodology to identify guidelines both for diagnosis of von Willebrand disease as well as for the management of von Willebrand disease. VWD is the most common inherited bleeding disorder, and yet accurate and timely diagnosis remains challenging. Current barriers, as many of you will be aware, include a lack of understanding in the difference between normal and abnormal bleeding symptoms, as well as lack and limited availability and expertise for specialized labs, especially specialized coagulation and platelet function lab testing. It's important to accurately diagnose bleeding disorders and accurately diagnose von Willebrand disease in order to help individuals have access to care, minimize further inappropriate testing, but there's also harms caused by overdiagnosis. So again, making that distinction between abnormal bleeding phenotype bleeding disorder and perhaps abnormal minor laboratories without a significant bleeding phenotype is important. There's currently wide variability in the clinical practice for the treatment of von Willebrand disease. And again, this has to do with lack of high certainty of evidence to help guide some of this decision-making. There are a number of recommendations, both for clinical diagnosis as well as management, and we won't go through each recommendation today, but I do encourage you to pull both of these guideline papers to help support your clinical practice. There are 11 recommendations in the clinical guidelines for diagnosis. These include call for improvement of education around the value and use of bleeding assessment tools, particularly by referral-based centers and primary care physicians. These can be used as an initial screening tool in an attempt to help identify abnormal bleeding phenotype versus normal bleeding phenotype to help inform further testing, particularly at a primary care level. We also have some new recommendations about broadening the classification of von Willebrand disease to be more inclusive of individuals who experience VWD-like bleeding, but whose von Willebrand levels used to confirm the diagnosis do not meet the previous less than 30% guideline. I think the important thing here is for individuals who experience VWD-like bleeding. So it's not the case that we are now classifying everyone with levels in the 30 to 50% range as type 1 von Willebrand disease, but certainly individuals with abnormal bleeding symptoms without another either anatomic cause or other bleeding disorder etiology should be managed appropriately and recognized for their abnormal bleeding symptoms. There's also some suggestions about how to change the approach for a diagnosis of type 1 von Willebrand disease for individuals who normalize their VW levels over time. And also some recommendations focused on genetic testing, particularly for the diagnosis of type 2B VWD. These guidelines also include a very helpful diagnostic algorithm, and I'll just highlight a few of the key elements here, as I'm sure the diagnostic algorithm is familiar to many in the audience. Certainly for individuals with a suspected bleeding disorder or von Willebrand disease, leveraging the BAT or bleeding assessment tool can be helpful. For a negative BAT or negative bleeding assessment in general, and a low suspicion of a bleeding disorder, this helps exclude a bleeding disorder or von Willebrand disease. It is important for those pediatricians in the audience to consider the limited prior hemostatic testing and hemostatic challenges that children may have. And so in the context of a strong family history of von Willebrand disease or other bleeding disorder, the lack of bleeding in an individual who's young may not be completely exclusive of a need to evaluate. The bleeding assessment tool can come in many forms. This is a snapshot of a condensed version of the ISTH BAT, for example. There are patient-administered versions of this, web-based administered versions of this, as well as longer paper forms. I do encourage you to leverage this both in terms of teaching within your specialty clinics, but also sharing it and educating primary care and referral centers who will have patients that may ultimately be seen by you. For individuals who have a positive bleeding assessment score, and I've highlighted the normal ranges here to the left of the screen, which do vary amongst the pediatric population, women and men. For those individuals, it's appropriate to start a hemostasis workup, and these boxes highlight the typical first-tier bleeding disorder evaluation. Certainly for individuals with antigen and activity levels greater than 50%, leads one to exclude a diagnosis of von Willebrand disease. But we do have a few caveats here as well. Considering the clinical context is important. Are there concomitant medications that may raise the von Willebrand factor levels? Are there other physiologic stressors that are present at the time of sampling that could bolster the VWD above its baseline? So remember, normal physiology has a number of factors that can increase von Willebrand levels: aging, exercise, high estrogen levels, stress. There are some normal factors that may decrease von Willebrand factor levels, for example, type O blood. We also have exogenous causes, as you can see here, and a number of pathologic causes listed here as well. So clinical context matters in terms of using your von Willebrand labs and evaluating them. For individuals who may have an antigen activity in that gray zone or low von Willebrand, 30 to 50% with no bleeding, consider these individuals low von Willebrand. Again, there may be prior limited hemostatic challenges, so we may not be certain about the no bleeding given the age. There's also variance in populations that can interfere specifically with the ristocetin-based von Willebrand activity test due to specific common variants in the population, which do not have impact on in vivo hemostasis, but can make the ristocetin assay certainly less than 50 and in some cases less than 30%. So for isolated discrepancies in the antigen and ristocetin or isolated ristocetin less than 50%, consider an alternative functional test. Listed here on the left of the screen are a few different examples of von Willebrand activity assays. One of the newer ones that we have available is the VWF GP1BM assay. And what you can appreciate here is rather than leveraging ristocetin as a trigger, it leverages a gain-of-function mutation in the GP1B region as the trigger. So it doesn't fall victim to the genetic variation that can interfere with ristocetin activation. Other nice parameters of this alternative test is it has a lower limit of detection, a less coefficient of variation, and so overall has some better test characteristics. The biggest challenge at the moment is lack of wide availability of this test. For individuals in the low von Willebrand, previous low von Willebrand category with a clear abnormal FAT, or for individuals with levels less than 30%, you're certainly moving towards a diagnosis of von Willebrand disease. And then it's important to identify the correct subtype. So looking at the ratio between von Willebrand factor activity to antigen is the next step. Again, optimizing the correct ratio to make the distinction here varies a bit from 0.5 to 0.6 to 0.7. So taking a bit of a conservative approach and using 0.7 as per the recommendations. When ratios are greater than this, you're really thinking about a type 1 von Willebrand disease, and you can leverage the DDAVP challenge or use of a propeptide assay or both to help distinguish the type 1C rapid clearance variant of type 1 von Willebrand disease. For those that have an abnormal ratio, you may be thinking more in the von Willebrand type 2 category and needing additional subtesting, category specialty testing, or potentially genetic testing to help confirm those diagnoses. Also very important to remember to look at your factor 8 level. And so for factor 8 levels, especially that are discrepantly less than the von Willebrand, thinking about von Willebrand factor 8 binding and or genetic testing to confirm the diagnosis of type 2N von Willebrand disease. In many cases, these individuals may first be erroneously diagnosed with mild hemophilia A. Certainly, there are a number of classifications of von Willebrand disease, and this is what contributes both to some of the diagnostic challenges as well as we get to thinking about novel therapies, some of the bleeding heterogeneity and grouping of patients and how to optimally study bleeding in von Willebrand disease patients and capture the efficacy of some of these novel treatment approaches. There are 12 new guidelines on management, and again, do not have time to go through all of these, but you'll identify some that are, in my mind, of particular importance. Thinking about prophylaxis for recurrent bleeding for individuals with von Willebrand disease. While prophylaxis is very much standard of care for all more severe bleeding phenotype hemophilia patients, many individuals with von Willebrand disease are not routinely prophylaxed, though this is changing. Also important to think about guidelines for optimizing hemostatic support in the face of procedures and surgeries. So it may be the case for minor surgeries that targeting von Willebrand factor activity over 50% and leveraging tranexamic acid may be adequate. However, as we get towards major surgery, important to think about both the von Willebrand component as well as the factor VIII activity troughs. In many cases, traditionally, individuals have followed just factor VIII levels as the marker of adequate hemostasis, but it turns out that measuring the von Willebrand activity is equally as important, and optimizing those levels over 50%, at least in the initial post-operative period, is important. Leveraging both hormonal therapy and tranexamic acid therapy for hormonal bleeding, and then also thinking about neuraxial anesthesia and targeting non-pregnant normal levels at a minimum. There's a number of areas, though, that have been identified as areas of uncertainty, including around antithrombotic management, further evaluation, leveraging use of tranexamic acid versus not in post-operative management, and what is the value added. And again, coming back to prophylaxis, identifying which patients, which subtype of patients, which type of bleeding and severity of bleeding might help inform who we can optimally use prophylaxis in. When needed, prophylaxis can be incredibly helpful and is very important. But at the same time, prophylaxis is cumbersome and is an added challenge for both patients and families in terms of administration, supplies, etc. And those added challenges are worthwhile for individuals who are having bleeding symptoms. At the same time, just adding prophylaxis for individuals without significant bleeding symptoms adds to the complexity of their care. As I mentioned, we have many treatment options that are promising in the space of von Willebrand disease. I've highlighted a few categories here, including pegylated aptamers, generalized hemostatic therapies, and nanotechnology. Focusing on the pegylated aptamer, BT200, for example, this is a pegylated aptamer that binds von Willebrand disease A1 domain. The goal here is to increase von Willebrand and factor VIII by decreasing clearance of both of these proteins. It can be administered through subcutaneous injection. They have completed a phase 2 study in von Willebrand type 1, 2B, and heme A patients, and identified, focusing here on the 2B subgroup outcomes, in tripling of the platelet counts from a median of 60 to nearly 180, as well as increasing the von Willebrand antigen. So there is interest and hope in moving this on to additional clinical trials. In the generalized hemostatic therapy section, we have two VGA-039 and Heme-001. The VGA-039 is a monoclonal antibody directed against human protein C. And the goal here is to enhance thrombin generation through inhibition of protein C. And its activity for both TFPI alpha and activated protein C. Early studies have used both intravenous and subcutaneous administration, and a phase 1 trial is actively recruiting. And as such, we don't yet have patient outcomes or safety data. The Heme-001 is a bispecific antibody binding and stabilizing both activated factor VII as well as the TLT1 on activated platelets. The goal here is to facilitate factor X activation and enhance thrombin generation. This is administered subcutaneously and is also recruiting a phase 1/2, so I do not yet have outcomes or safety data. The last category is nanotechnology, platelet-inspired nanoparticles, and KBV1A12. In terms of platelet-inspired nanoparticles, these are synthetic platelet nanoparticles, small liposomal particles with multiple peptides, facilitating binding to collagen, von Willebrand factor, and activated platelets. This is in preclinical work so far, and early studies show proof of concept, but for optimum efficacy and efficacy that would help promote moving this forward into human trials, additional work is presently needed. In terms of the V13A12, this is a bifunctional molecule that binds albumin and von Willebrand factor, increasing von Willebrand plasma levels. It can be administered subcutaneous, but is also presently in the preclinical phase. There are a lot more products ultimately coming. I've identified some genetic approaches that are being investigated here in terms of somatic gene therapy. The benefit of many of these approaches, whether it's somatic gene therapy, transcriptional silencing, other gene editing cellular therapies, is that they can be targeted towards all types of VWD. There's other protein-based approaches. So we have now in the hemophilia A space licensed BIV001, which is an enhanced ultra half-life factor VIII concentrate that also incorporates stabilization of the factor VIII by an added D' D3 region. So it helps make the factor VIII independent of endogenous von Willebrand factor and as thusly really dramatically extended the half-life. As well as emicizumab, a bispecific antibody, which replaces largely the activated factor VIII function in the body. So while both of these work very well for prophylaxis in hemophilia A, they also have the possibility, and have had early demonstration, to be of use in type 3 von Willebrand and in some instances type 2N von Willebrand disease, where some of the driver of bleeding symptoms are the low factor VIII levels by being able to stabilize and improve factor VIII. There's also additional attempts at increasing endogenous von Willebrand factor levels and further stabilizing their half-life and reducing their degradation. And you can see that both here with the interleukin 11 as well as this other antibody, MAP508. So the future is bright for individuals with von Willebrand disease as we continue to generate new possible therapeutics, and at the same time have the need for really developing thoughtful clinical trials that appropriately identifies the right subpopulation to benefit from these therapies, and carefully selecting not only that inclusion and exclusion criteria, but also carefully selecting the appropriate bleed outcomes so that we're able to clearly demonstrate benefit when the benefit is there. Thank you for your attention.
Thank you so much, Dr. Crotio, for the excellent and very impressive review of von Willebrand disease. As we don't have questions, we come to the end of the conference. So we come to the end of day 2. We really dived deep into the latest achievement in pediatric hematology by experts in the field. It was very fruitful and really enriched our knowledge. I would like to thank all the eminent speakers who joined us today, and thank all the audience for staying late. Thank you again. Have a good day. See you tomorrow at 9 a.m. Kindly log in 15 minutes before the conference, before 9 a.m. And an important announcement that you need to attend the full 3 days to get your CME certificate. Have a good day and see you tomorrow, inshallah.